I know. There we go. Good morning. Oh. Uh-oh. Good morning, everybody. Could I ask everybody to settle down? It's day 2. I get to moderate the first half in the morning, and my rule of thumb is start on time and end early. And we've already broken the first half of that. So, we're going to start with a slight change in the program. Bob Wright is going to speak first, and then David Balshaw is going to speak after Bob. Bob is the Weiss Professor and Chair of the Department of Environmental Medicine at Mount Sinai. He's also the person who explained to me what the exposome was, I guess, about 5 to 7 years ago. And he's going to convince all of you today, because he's working on me, that Alzheimer's disease really is a pediatric illness and not a disease of older adults. So, Bob, welcome.
So I probably should have warned Sean that I completely changed my talk. Well, there might be a little bit of that in there. I wanted to talk about something a little bit different, what I'm calling environment is medicine, and how exposomics fits into larger trends in science, such as precision medicine. So I'm going to start with a quote from Steve Jobs. So you can't start with the technology and try to figure out where you're going to try to sell it. You've got to start with the customer experience and work backwards to the technology. So just keep that quote in mind. So this is a tangent. I became a grandpa about 6 weeks ago, so this is my grandson. Nikolai Robert Murkison, that's actually him 2 days ago. My daughter texted me that picture. And the first one is when he was born. So I have no conflicts of interest to report, financial or otherwise. And so I'm going to begin at the beginning. So remember what Steve Jobs said. You got to start with what the public experience is. So what is the public experience? He didn't say, give the people what they want. He said, try to understand the experience, then build to fit the needs. So in the United States, this is what scares everybody. Healthcare costs are sky high. So how do we provide high-quality care cost, or high-quality care at a lower cost? And almost everyone is fearful that if you get ill, it could lead to bankruptcy, because health insurance is no longer a guarantee. Even if you pay the premiums, it's a possibility. Another experience is that we do need better treatments for diseases that need them. Cancer definitely fits into this. I would argue that neurodegeneration and Alzheimer's disease is going to be really difficult to create a treatment for, because neurons have died. And I'm not even sure what would happen if we started growing new neurons. Would you have the same memories? Would you have the same personality? It's going to be a big challenge. So precision medicine may not fit for Alzheimer's disease. I actually had heart surgery about 1.5 years ago, and I think myocardial infarction and treatments for that actually work pretty well. I'm not sure we need new treatments for that, because it's actually going much better. And then the third public experience is sustaining good health. Healthy people want to stay healthy, and that's something that I think has been left out. Also, if you have a chronic illness, you don't want it to get worse. And that's something I'm going to talk about, how precision medicine fits into that as well. So that's the experience. What are the perceptions? So the public believes that treatment and prevention take place in a physician's office. It's all about medications and procedures, and in primary care, it's about lifestyle guidance for preventing a disease. That's the public's perception. Public health is just this vague concept that takes place in government offices. And what I mean by this, if we want to make movement towards prevention, we really need to partner with clinicians, because that's who talks to the public. At the population level, it's thousands of physicians talking to millions of people. And that's what's going to move the needle. I'm going to be honest, I don't think policy is going to move the needle much, at least not in the United States. Even policy to ban chemicals in the United States has largely failed to ban any more than 4 chemicals over the last 50 years. And one of them, asbestos, went from being banned to not being banned. So my argument is maybe we should think of other ways. It doesn't mean we can't also work on policy, but we really need to partner with clinicians if we're going to move the needle. So the public believes healthcare providers are both clinical agents and public health agents. We need them as allies if we want Exposomics to move forward. And then there's a backdrop of big picture research trends. So research is funded against a backdrop of shifting priorities. The big 2 are precision medicine, that's the 800-pound gorilla. And then the newer one is something called health span, which I'm going to talk about, which is actually very close to public health. So let's define them and think about how Exposomics might fit into both. So this is actually the U.S. National Academy of Science definition of precision medicine. It's research to optimize therapeutics for patients using genetic or molecular profiling to tailor the treatment to the individual's genome. It's about developing drugs, primarily, not entirely, but primarily for the day that you get sick. So think about that. It's for the day that you get sick. If you're not sick, is precision medicine serving you? So what's health span? So health span prioritizes extending the number of years lived in good health. So it's similar to longevity, and it's similar to lifestyle medicine. It's really about what can you do now to avoid getting sick. It includes diet, exercise, and socializing, social networking. But it also involves toxicant avoidance, alcohol, tobacco, microplastics, pesticides. And it's a recognition that in the United States and other developed countries, we might have a lifespan of about 80 years, but we spend the last 10 years or so with a disability. And this is something I learned from Sean. So this is a movement to try to shorten those number of years that we live with disabilities and chronic illnesses. So, and this is the precision medicine research template. So map the genome either in a family-based or case-controlled design for a disease and find candidate regions in the genome, replicate and validate to identify target genes and sites on those genes, study the functional biology of those targets, drug the finding, go through preclinical and clinical trials, then go through regulatory approval of a treatment. It takes about 20 years for each drug. Exposomics could do this. All we would be doing is replacing the genome with the exposome. So we could map the exposome in a family-based or case-controlled design on a disease to find candidate regions or candidate exposures, replicate, validate to identify the target exposures, study their functional biology, drug the finding, etc., go through regulatory approval, and create a drug. So that is an option for Exposomics. The goal, if we were to go in that direction, would be to create a drug to treat rather than prevent disease. The current practice of environmental health, which Exposomics is really a subclass of, perhaps ironically, because it's bigger than environmental health, but it's population-oriented and it's public health-oriented. So common questions, this is sort of a general type of question that we ask, are do microplastics cause learning disability in children? Or PFAS, forever chemicals, do they cause obesity, or do pesticides cause Parkinson's disease? The underlying principle is, are the exposures going to increase the probability of getting an illness at some time in the future in a population? So we tend to deal with probabilities rather than diseases themselves that exist. We're trying to prevent them, which is a good thing, but I'm just pointing that out. Health span is actually pretty similar. Rather than working at the population level, it works at the individual level to try to reduce your exposures and improve your health through lifestyle changes so that you're less likely to get sick in the future. So that's health span. And there's challenges to both approaches. So the challenges to precision medicine are this. Each medication that gets developed costs about $1 billion and takes 20 years on average to go through that process that I went through. It's very unlikely to reduce healthcare costs, right? If we have more drugs, each one costing $1 billion and each one adding 20 years of time to develop, do we really think that's going to reduce healthcare costs? Not an economist, but I would argue that that seems very unlikely to me because in economic terms, precision medicine actually needs scarcity in order to recoup those costs. So part of why I think healthcare is getting more expensive is because we're not working to reduce those costs. In fact, a lot of the research we do is probably increasing it. Now, this is not meant to be a global criticism. In some areas, like cancer, precision medicine has done fantastic things, particularly with immune therapy. But I think for the diseases that we're talking about today, I think it's unlikely that medications are going to affect it, at least not in the near future. And as somebody in their 60s, I don't think I have 20 years to wait for that drug to be developed. I want something I can do today. As I said, if I'm 65, I'm actually only 63. So do I have 20 years to wait for that better drug for Parkinson's or Alzheimer's disease if I develop it? And then there's other challenges that public health faces. So public health and health span are very, very parallel findings, are very, very parallel fields. So many, if not most, healthy people actually don't listen to population-level messages about prevention of disease. So the young and the healthy feel invincible. And it's easier and it's cheaper to eat unhealthy and be sedentary, particularly in the United States. And if you're successful, nothing actually happens. You didn't develop the disease. That's really challenging for public health. And for many, many reasons, those being among them, clinicians largely ignore public health. The average clinician has a really hard time defining what public health is. The ones in this room, I'm sure, can do it, but the average physician probably cannot. And keep in mind, they only have about 15 minutes in a visit. It's really hard to bring in these messages effectively in 15 minutes and do all the other things you're trying to do in that 15 minutes. Also, health is more difficult to commercialize in disease. Health is abundant, as opposed to precision medicine, which really in drug development, which uses scarcity. So it's really hard to make money, which has actually slowed down this kind of research. So Western societies, however, are getting less healthy. Over the last 25 to 30 years, chronic illnesses in children and adults are getting more and more common. So perhaps we should try to think of another way of approaching research to address what the public needs, like Steve Jobs said. Think about what they need and then build the technology to what the need is. So, is there a way that would address the public's need to stay healthy, avoid healthcare bills, lead a more active life, live longer and healthier by avoiding disease, target prevention to populations that are receptive to us? Remember, the biggest challenge in public health is that no one listens to us. Well, maybe there's another way. And also, can we create interventions that are abundant, meaning they're not that expensive and not scarce? And in the ideal situation, we'd build partnerships that would include genetics and environment. So I'm going to propose what I'm calling environment is medicine, which I'm borrowing from food is medicine, which is a similar movement. So it parallels public health research, but focuses on people who have a disease, i.e. people who will listen and come to clinics to engage with clinicians. Also, it builds a natural partnership with clinicians. Because people with a chronic disease, they're a vulnerable population. All of us in public health study vulnerable populations, whether it's women in pregnancy, whether it's young children, whether it's the elderly. People with a chronic disease, we've largely ignored, but they are a vulnerable population. They live in the same world that we do. They get exposed to microplastics. They breathe unclean air. They drink water that's been contaminated by PFAS. All of that happens, and it's affecting their disease, and we don't study that. And maybe we could do low-cost interventions that might actually help prolong their lives and improve their health by just avoiding the kinds of environmental exposures that the young and healthy we counsel about, but they ignore us. As somebody who has a chronic disease, I've started to listen to some of these recommendations. We know the sources of exposure for many of these common environmental exposures, and we could advise on reducing the exposure. The interventions are mostly inexpensive, relative to drug development, certainly inexpensive, so they're abundant and not scarce. And here are some examples. So instead of, do microplastics cause learning disabilities in children, maybe we should ask the question, do microplastics increase antisocial behaviors in adults and children with autism? People with autism have pica, they eat non-food substances. They probably have really high levels of environmental chemicals. It's different from asking, does lead poisoning or microplastics cause autism? That's actually an irrelevant question in this situation because these people have autism. Prevention is no longer an issue. What we can do, though, is maybe make their disease a little less severe by counseling them on diet and environment and exercise and socialization as much as you can, obviously with autism. But those are interventions that I think families of children and adults with autism would be receptive to, and that research is not being done. And it can be done now. We've been studying the genomics of autism for 20 years. We're not that close to a treatment, let's be honest. And the families are getting angry because it's taking so long to get anything to them that is actionable. This could be actionable in a very short amount of time. And the same thing could be true in Parkinson's disease. I've actually talked to Brad about this many times, that maybe if we could reduce environmental exposures in patients with Parkinson's disease, it might improve their phenotype. I think he's been skeptical to some degree, but I think it's possible. Although he's actually been very much an advocate for the overall concept. I shouldn't have said that. And I tell my trainees, play this like a board game, because I think there's a lot of good research ideas in here where you just look at the public health literature on environment and a disease, and if you think that there's a relationship between environmental exposure and a disease, turn the question around a little bit and say, well, what happens if I have that disease and I have that environmental exposure? Because once you have the disease, you're still living in this same world with all these environmental toxicants around you. It's happening and it's doing something to your disease, and we don't really know what that is yet because we don't study it. So I would encourage folks to actually think about doing this, partnering with clinicians, which will actually be a lot easier for recruitment. Let me tell you, people with the disease say yes when you try to recruit them. Healthy people say, I'm too busy. And you could actually make a real impact in their life if this works, and that by reducing exposures, it actually improves their health. And it can integrate with genetics as well as health span. Let's say you carry the ApoE4 variant, which is a major risk factor for Alzheimer's disease. Well, what can I do? It's not fate. Not everybody, even people who are homozygous with ApoE4, they don't all get Alzheimer's disease. Something's happening that's modifying that effect of the genotype. Maybe it's simply diet, exercise, and socialization, but also environmental exposures. Maybe HEPA filters in your house may actually improve or reduce your risk long term. Maybe I should eat organic products. And I recognize there's a socioeconomic status difference there, but that doesn't mean we shouldn't try to help people that are at risk that can afford it. I think we should be able to give that advice. I actually think a lot of work that's been done in the plasma proteins, the phosphorylated tau 217, 181, and the amyloid betas, might be a great way to track whether or not it's working. So I know I made a comment that Cecilia should get a 10-year grant, and I think you deserve a 10-year grant because it's going to be tough to answer that. But maybe these plasma proteins can help track whether or not it's working. I think that's kind of a second research question, though. So, but there may be ways to do this that we can actually see that things are improving by environmental interventions. So what other mitigation strategies can you employ based on your genes and your environment? We have these polygenic risk scores. We understand who's at higher risk, and maybe we can target those people because maybe they're more receptive to the message if we tell them that we know that they're at higher risk. Because right now there isn't any effective treatment. So telling them, well, we're developing this drug that maybe will cost you probably an arm and a leg because it's going to cost $1 billion to develop and it won't be ready for another 20 years, isn't the best message to give folks. Another example might be, do PFAS chemicals trigger diabetes in somebody who's pre-diabetic? All of us who go to the physician regularly after the age of about 40 or 50 are getting their hemoglobin A1C checked, and we know who's pre-diabetic and who's not. And if you're pre-diabetic, you're going to be more receptive to the idea that you need to do something on average than somebody who's not. So I think public health, our biggest challenge has been we've been trying to preach, prevention to people who won't listen to us. Let's move towards people who will listen to us. And I speak from experience because, as I said, I had heart surgery about 18 months ago, and I pay a lot more attention to what I eat and to my lifestyle than I used to. And I don't think I'm unusual in that sense. So we could even personalize it. So there is a component of precision medicine here. Is there an exercise plan that fits your schedule and where you live? We could use maps to figure out your built environment and where the parks are. I think clinicians could do that. We could use, again, polygenic risk scores, and we could track progress with hemoglobin A1C, just like these plasma proteins for ADRD. But what it really means is that how do I avoid getting sick in the first place? Which is a very different dynamic than precision medicine. Because precision medicine is waiting until you get sick, and then there's a market for your drug, and then we intervene at that point. But I don't want to get sick. And I think most people don't want to get sick. And basically, this is a form of health span. So it combines public health principles with clinical interventions. It brings public health into the physician's office to people who have a disease or are at high risk for a future disease. And it can be implemented now, not 20 years in the future. And it won't cost $1 billion to implement. And that's why I bring up implementation science, because I think implementation for these types of low-cost interventions don't need a randomized controlled trial. We are fairly certain that clean air is better for you than polluted air. So why do we need a randomized trial to use HEPA filters, for example? Why not we just look at what the effect is in people with a disease and track their disease long term? So how do these approaches fit with the public needs? So on the top row are the needs. Does it reduce healthcare costs? That was my third slide. Does it prevent illness? And does it find better treatments? And on the subsequent rows are the different fields: precision medicine, public health-based environmental health, traditional public health, and what I'm calling health span and environmentalist medicine. So precision medicine, I don't think it's going to reduce healthcare costs. I don't think there's any reason to think it'll reduce healthcare costs. It will not prevent disease. In fact, the incentives are actually, if you have a sicker population, you're going to make more money. So the incentives are all wrong for prevention. It is good at finding better treatments, and certainly if I had cancer, I would want precision medicine. Immune therapy is a big success, but it's not going to work for every disease. So we should recognize the fact that we're applying something broadly that probably isn't going to work for a lot of the diseases in which we're trying to apply it. And then public health-based environmental health, if people listen to us, it would reduce healthcare costs, it would prevent disease, but only if adopted by healthy people, and it won't find better treatments. Whereas what I'm calling health span, environmental is medicine, I'm going to argue, and granted this is all speculative, it's just my opinion, it would reduce healthcare costs. It's much cheaper than drug development. It would prevent illness, or at least it would prevent illnesses from getting worse. And it is, I think, a better treatment. It is a form of treatment to live a healthy lifestyle when you have a chronic disease. So I think it works on all three levels. So that brings me to the end, which is about implementation science. For those of you who are unfamiliar with the term, it's relatively new. It is its own science now. And it's really about how to get research findings adopted by providers or communities. So we've known for years, even if you do a randomized trial for a drug, you got to get the message out there that it works. You got to get physicians to do it, or they might do an intervention that might be a procedure which might require something that they don't currently own in their practice. So there's all kinds of adaptation barriers to getting anything implemented that we've ignored for many, many years. So this is a science about how to overcome those barriers. And exposomics is going to have a lot of those barriers. And one is just going to be education. I think if you go into a clinic and you talk to the nurses and the physicians and you tell them how important environment is, you're going to get a lot of skepticism. They probably haven't read the papers about air pollution and Alzheimer's disease. They probably don't know what PFAS is. Some of them might, but a lot of them won't. And if you're changing the way they do their work, they're going to resist it. So implementation science is all about how do we get people to change their behaviors to match the science. And it's a lot harder than we think. And it's something I think we really need to focus on. But it can be done. So here's an example. So I think we could actually start studying, everybody knows that if you exercise, eat well, get more sleep, and socialize, you'll be healthier. What we don't know is, why is that so hard to do? Because it's really hard to do in modern societies. I think that should be the focus of our research. So this is an example of studying why we don't sleep well. Last night is because I had probably too many glasses of wine. But on other nights, it's something else. But can we improve a patient's sleep environment using HEPA filters, noise and light sensors, so we know what the sleep environment actually is? We have Apple Watches that can actually measure that. And maybe dietary changes. Maybe they're eating chocolate after 8 o'clock and they don't know that caffeine is in chocolate. There's all kinds of things that patients wouldn't necessarily know that might be stimulating that they're doing too late at night that may actually affect their sleep. And that's something that we could do. And in fact, I would argue that this is something that environmental health should take on. We need to factor in where somebody lives, whether it's the home or the nursing home, whether they have a chronic illness, and what their drugs may be doing. It may be that a slight modification of when they take their drug may actually allow them to sleep more. And we're actually not doing that kind of research. But if we partnered with physicians, I think we could do that. And again, for Alzheimer's disease, maybe we could reduce phosphorylated tau 217 levels over time if we could improve their sleep. So we could actually see an effect. Right now, we're not asking these kinds of questions. We're looking for drug targets. I think we should be studying the things that will make us healthy long term and how environment and the exposome plays a role. Because this is one of my favorite authors, Ursula K. Le Guin. There are no right answers to the wrong questions. I think we're not asking the right questions about health. So in summary, high healthcare costs and expensive drugs are the public's reality. Precision medicine actually encourages scarcity rather than abundance. Patients with chronic diseases are vested in prevention. The healthy and young people are not. Environment is medicine. Thinking about the environment around people with chronic diseases actually encourages abundance. It's a relatively low-cost way to intervene. And partnering with physicians through implementation science, I think, is going to have a big impact if we can do that. There may be ways to create commercial incentives for that. And I think HealthSpan actually is starting to happen. I think MAHA and HealthSpan actually have some parallels. And MAHA, I will give them credit for actually getting people to talk about food in America, because nobody was talking about that for a long time, until about a year ago. And now it's all people talk about. And that's a good thing, because our food system has been poisoning us. So HealthSpan starts with what the public needs and works backwards to the technology, which is what Steve Jobs recommended. The tools already exist. Environmental exposures, preclinical markers, and genetic risk can all be defined, and they can be integrated for prevention and treatment. And this is, I think, my last slide. So all this comes back to where I think we should start to expand our scope of study into the commercial determinants of health. So a lot of corporate practices are designed to addict you to products. Everybody I see out there looking at their cell phone may have a problem with addiction to their cell phone. That's not unintentional. So whether it's food, whether it's tobacco, well, just name it, the most profitable corporations on the planet use addiction. And that's what's driving a lot of health disparities and a lot of healthcare costs. Tobacco and alcohol perfected that. Ultra-processed food and social media have now taken over that arena, and it's affecting us. It involves marketing, product design, and political lobbying, and throwing money around, quite frankly. That's I would argue what we really need to start moving towards, because this is what's happening to us at every level of society. And as I said, the most common strategy is using addiction as a business model. And I think that's why implementation is crucial, because we can start doing implementation now. We don't need randomized trials. And the clinicians need us to understand how to do that implementation. And I think they would be receptive to it, because their patients for the first time are starting to talk to them about things like, what should I be eating? How much should I be exercising? And I think most clinicians, if they're really honest, they don't know the answers. We didn't get a lot of nutrition training in medical school. Most of what I've learned in the last 18 months since I had my heart surgery. And I have absolutely changed my diet. And I think I feel more comfortable giving that advice. I would not have felt comfortable giving that advice even 2 years ago. So it is something that I think the world needs to move more towards. That's the last thing.
That was a good, thought-provoking talk. But I want to point towards that 15 minutes that we have with the patients. How do you intend to make that implementation successful?
That's a great question. So I know you're familiar with open evidence, which is, so in medicine changes so radically that there are companies that market online search tools to find information that a clinician can either print out or read very, very quickly to understand a situation. Open evidence uses AI to search the medical literature and finds information and collates it into something actionable whenever appropriate. And it's actually monitored pretty closely, and it's actually being adopted by most healthcare systems worldwide. I'm sure there are hospitals in France that use it. I think we need to get companies like Open Evidence. Another one is UpToDate. UpToDate has been around for like 30 years, but they currently don't use AI to my knowledge. And I think that's why Open Evidence is replacing them. But if we could get them to look at environmental factors, and if we published research like what I described on patients, then it will end up in the literature, and Open Evidence will pick it up and start to use it. So I think that's the quickest way to do it. So we have to start doing some of these studies, but we also have to lobby these companies, or at least clinicians, to ask that this information be included in UpToDate and Open Evidence. I believe Epic is now actually moving. Epic is the largest electronic health record company, I think, in the world. And they've started to mimic Open Evidence, and they're starting their own system, which is actually kind of brilliant because they have a monopoly almost on EHR, so they'll probably have a bigger market than Open Evidence in the long run. But those sorts of companies that now exist would be a good way to use AI and actually implement some of what I was talking about. But if we do the research, it's also just going to happen. Open Evidence will pick it up.
Bob, great talk, and very important take-home messages. I actually like your reference to MAHA, because this is what MAHA is all about. Just one thing I'd like to emphasize, though, is you talked about how get to the people who are already clinically impacted. I'd like to maintain that we're developing the tools now to get to the people who are genetically, say, programmed and environmentally programmed before they start developing the clinical presentations, and then focusing on the types of environmental exposures and environmental factors that can mitigate the actual appearance of the clinical phenotype. The geneticists are working not just to develop drugs, but a big focus now is to try to ascertain genetic predisposition, and it's a complex trait. Autism is a great example of this. There's probably hundreds of different allelic variants that may predispose to autism. But also, you're probably familiar with the poly-exposure score. I don't know if you're aware of that, but that's, and what we're actually at NIEHS determining is the polygenic plus the poly-exposure score actually gives you a better predictor of what your clinical outcome is likely to be. But then, you touch on implementation science. That's a big challenge, of how to actually get this out there, both to physicians who never get training in this, but how to get it out there to actually influence the types of lifestyle changes that can utilize, environmental exposures in a positive way. So I think that's one of our big challenges, and it needs to be an area of focus where we actually look at not just drugs treatments, but are there environmental exposures and different lifestyle changes that give you tangible evidence that you're actually moving in a direction to improve your health. So great points.
Hyacinth, you had a question?
Yes, quick question. I think one of the challenges is the issue of unintended consequences. So I'll pick a particular example. Was first you could go to grocery stores and walk down the aisle. So we got exercise doing that. Now you can have the grocery put in your refrigerator. So we don't even get the exercise of actually going to the grocery store and all. So technology always results in unintended consequences. And how do we as exposomic scientists or people looking at the exposome start addressing some of those things that, yes, it looks nice, yes, it's good advancement, but how do we sort of provide the education that says there is an unintended consequence of what we are picking up new? And I'll stop there. I had two questions, but I'll stop there.
That is a great question. I hadn't thought of that, so I'm thinking off the top of my head. But I think it just requires that we be vigilant, that, because you're right, something's going to happen that we didn't anticipate. It always does. And we have to be ready for that. When we see data that suggests something's not working that we're doing, if we move in this direction with exposomics and environment as medicine, then we need to shift. But it really just requires monitoring. And I think I'm being told I have to stop, so.
Thanks, Bob. Now, again, we're going to continue with a slight change in the schedule. And I promise you, David Balshaw will be speaking. He will be speaking, but next. So it's a pleasure to introduce Brad Rosette, who's the Kemper and Ethel Marley Professor, Chair of Neurology, and Senior Vice President at the Barrow Neurological Institute in Phoenix, Arizona. Brad. And I am not going to be introducing the names of the talks anymore since Bob messed me up.
Good morning. So, I'd like to first thank the organizers for inviting me to speak. Sorry for those of you who thought David Balshaw was going to be presenting now, so you'll have to suffer through a half hour before he speaks. Bob and I started talking about me contributing to this conference a couple years ago, and I'm like, I don't really do that much AD research. I'm a neurologist, Parkinson's expert, and but I see people with dementias and all sorts of other conditions inadvertently many times. But but he sort of lit a fire under us to start to think more about expanding the work we're doing. And so what I'm going to describe today is a platform for sort of taking a different approach to exposomics and really addressing some of the comments that Remy made yesterday and several of the other presenters made. I'm a clinician, so there'll be a bit of a slightly more clinical leaning to this talk, but for the most part, this is a talk about using sort of cutting-edge geospatial methods to understand the contributors to the environmental contributors to neurodegenerative disease. Just advance. These are I have no disclosures. This is the grant funding for our lab currently. So overall, I'll start with an introduction to Medicare research because the methods that we'll be discussing today are primarily using administrative claims data to study Parkinson's and ADRD, and then a bit of an introduction to how we approach exposomics and the concept of geospatial neuroepidemiology. Show some examples of Parkinson's disease where where our work started, and then some mostly unpublished but rapidly developing work in ADRD. One of the the challenges that we sought to address when we started to use Medicare data is a comment that Remy was making yesterday about sample size. So when we first started doing, when I first started doing research in Parkinson's in the 90s, a large environmental study in Parkinson's involved maybe 1,000 patients. But we said, well, and a lot of what we know about Parkinson's risk factors came from some of that work and some parallel work, and that's why most of what you hear with Parkinson's is pesticides cause Parkinson's. That's a very probably overstated in terms of the role of pesticides, but the focus has been almost exclusively on pesticides, until more recently. So we asked the question, what would happen if you just blew up that sample size? And Medicare allows us to do this. So what is Medicare? So for those of you who are not from the United States, Medicare is the only national health insurance in the United States. We can purchase these data, and they come with complete demographic data, race, age, sex, diagnoses, date of death. You can purchase in different ways. We tend to purchase by a primary diagnosis of interest and create retrospective cohort studies. And then each beneficiary can be tracked forward and back in time using a unique beneficiary identification number. We can geocode beneficiaries down to the 9-digit zip code, and that won't be intuitive if you're not from the United States, and even if you are, it may not be. Those are actually mail routes, but they can be as specific as a building in urban areas, but in rural areas they can be quite broad. So that is one of the challenges of geocoding, is that our precision is much better in urban areas. We can link these to environmental data sets, and we can conduct a variety of types of research. Most importantly today, we'll talk about spatial epidemiology. So some advantages and disadvantages of using Medicare. They are generally population-based, but only for the population 65 and older. So you're not eligible for Medicare until you're 65 years, or if you're on disability or have certain conditions. But for the most part, for this talk, these are people who are 65 and older. Of course, you get great statistical power. There's just some examples of that. Because the data are submitted for claims for physicians to be paid, physicians in hospitals. Physicians pay more attention to that, so they are audited. They can be used for discovery or hypothesis testing. So I'll provide examples of both. A lot of our PD work is really hypothesis testing, but the ADRD work we're doing is really trying to use this exposomics concept to do some discovery work to identify novel risk factors. They're useful for identifying minority populations that are almost never included in most environmental studies. And as I said, we can link to other data sets, and I'll show you what I mean in a second. One of the challenges is exposure lagging is limited, and we heard several presentations yesterday where presenters discussed the long lag time between the neuropathology evolving in the brain and when the disease actually is diagnosed. And that's a challenge that we don't have a solution for, because we only can identify people and track their residential location once they hit age 65. They don't have the granularity of electronic medical records data. And just a couple larger comments. The data these are large data. They're expensive. Cost about a complete set of PD data, for example, is about $40,000 or $50,000 per year purchased. And the fun thing about that is that if you have an NIH grant to do work with these, you still have to pay the $50,000. So it's not, there's no bypassing that CMS operates this. It's separate in terms of its cost center in the government. So it's an expensive set of data to own. These are the data use agreements we have with Medicare right now. All total, over 40 billion records of data that we have in our lab, and this is what we've accumulated over the last 15, 16 years. I'll focus today on work from a PD data set, which early data set, which has 100,000 PD cases. You see the size of the scale we're discussing here. A more recent PD data set with about 300,000 PD cases. And then our Alzheimer's cases are in the range, each incident year is about 500,000 incident AD cases, about 700,000 all-cause dementia. And then we have a new frontotemporal dementia data set that's about 50,000 cases. All right, so just to give you a sense of why we like these methods, these are big sample sizes and some that are just have not been used in these diseases previously. So we merge these data. So on the left, you see examples of environmental data sets that are publicly available in the United States. And then we merge them with the CMS data, and these are diseases that we're actively studying on the right. In addition to these, which are some of our richest data sets, we have one DUA that has over 2,000 neurologic diseases identified in 2018. So we can study almost anything now with the resources that we've built. We link these down to the claims data down to the zip 9 level, in most cases, sometimes zip 5, depending on how common disease is, because there are some limitations to what we can report out. And then the environmental data generally links to the census tract, which we can merge into the same geospatial level of certainty. And then we take a series of approaches. I'm going to show sort of different versions of the way we approach this. First of all, we map the standardized incidence. And this is sort of, I find this to be a really good first pass of how is the disease distributed through the United States. The United States is highly geographically, geologically, and ethnically different throughout the entire United States. So there's a lot of variability that we can use to our advantage. And then the next step typically is we do a nationwide regression to look at the association between the disease and the exposure. And then we're interested in not just is the exposure associated with disease, but where is that associated? So we want to understand. So, for example, paraquat is often cited as a risk factor for PD. Probably is, but it's not used everywhere in the United States. And so it makes sense that association is only going to be seen in certain areas. And so we're interested in where the PD or other diseases are associated with environmental chemicals, because we recognize that there are probably dozens of associations, dozens of causes, and it's regionally specific as to what is the risk factor in those areas. And that's what on the third panel you see what a spatial correlation map, which is called by Lisa. This is a somewhat adjusted map, so it's standardized incidence is the input, and we look at high exposure, high incidence of disease, and then low as the areas where you see the strongest correlation. And on the bottom right, you see a geographic weighted regression, which is where we can provide the strongest evidence for an association between exposure and disease. So I'll show you various examples of the way we use these methods over the last several, in particular these methods we've used in the last 5 years or so. Okay. Start off with 3 diseases that we'll talk about over the next few minutes. So on the left, you see a standardized incidence ratio of Parkinson's disease in the United States. And so the first thing you'll notice is this is a disease that's not evenly distributed through the United States. And this has been published in numerous ways. We first published this back in 2010. And just the incidence map alone, the risk of PD in the sort of Rust Belt up in the Northeast is 10-fold greater than in California. Very strong evidence that something's not right there in that part of the country. And we still don't really totally understand this. There's definitely a concentration along the Ohio River Valley and the Mississippi River Valley. And in this case, you'll see that sort of spotty areas throughout the industrial east. The all-cause dementia map is very much in that band in the south, which is the stroke belt, where the area where we have sort of the worst health at almost all possible outcomes, cancer and cardiovascular disease. And then this is brand new work that Ben Schumacher in my lab has done recently. You see the concentration of frontotemporal dementia in the sort of the center of the country, and this is very raw. We've only did this because Bob challenged us to do this in the last few weeks, but it's pretty confident this is a true pattern. The explanation for it, though, we're still working on. Okay, so how do we approach this? So this is work that Brittany Kurzanowski published back in 2023, looking at the relationship between PM2.5 and Parkinson's disease. PM2.5 is, of course, associated with many health outcomes. There was less data at the time on Parkinson's disease. And you see, she took this in this case, this is a 100,000 incident PD cases from 2009. We looked at exposures 10 years prior to diagnosis, still within a prodromal window, so not perfect, but it's at least temporally appropriate, which is an improvement upon many of the studies that have been done. And you see the spatial correlation. You see high incidence of PD and PM2.5 in some of those same areas in the Midwest where we saw the clustering, and then low in the mountain states. You see a relatively linear up to about 12 micrograms per meter cube of PM2.5. And what's interesting here, important, is that you see a linear dose response even below the National Ambient Air Quality Standards for PM2.5. So there's a pretty compelling relationship between PD and PM2.5. But interestingly, when you do the geographic weighted regression, we actually don't see that the strongest, the red signal is where you see the strongest beta coefficients. The strongest coefficients are actually in that low area. So, and interestingly, that low area is where is in that first part of the curve where you see the steep dose response. The Midwest is you have the higher concentrations, and it really levels off, which Bob and I have discussed in a couple meetings, sort of typical of many environmental neurotoxicants. So this is yet another example of a hypothesis testing. So there's been some discussions or a couple papers that suggest that exposure to trichloroethylene is associated with Parkinson's disease risk. These studies were fairly limited to military populations and whether people had been in an area where they consumed water that was contaminated with TCE. So we looked at airborne TCE in the United States in relation to PD risk, and I'm just showing you another unique method that we've applied to this paradigm. So on the left, you see a dose-response relation between TCE in the air and PD risks. TCE levels on the x-axis and PD risk on the y-axis. And in the map, you see the emitters of TCE in the United States. So these are the areas of the country where TCE is emitted the most. And on the right, you see a different method called MapGAM, which creates a risk surface emanating from a specific point source. So this particular point source is in Oregon, where there's a TCE emitting facility that had been investigated by EPA, and the risk I think it's as much as 14-fold greater as you get closer to the facility, and then the risk reduces as you get further from the facility. So this is a way for us. So for air pollution, of course, air pollution is distributed throughout the United States, and it comes from a variety of sources. TCE is primarily going to be a point source, and so in this case, we can not only identify the relationship nationwide, but we can tell you exactly where that risk is occurring and the facilities that are probably the greatest concern. So Bob thinks I doubt him, and I don't listen to his comment to what he says. So, but we also ask the question, does TCE affect the phenotype? So Parkinson's disease is sort of classically, clinically we see a couple initial phenotypes. A tremor predominant version that tends to be a little bit more slowly progressive, and then a gait predominant version that is more rapidly progressive. And so what we find is, in fact, we do see a relationship, a dose-response relationship between TCE exposure and the phenotype. And this is using an assortment of codes to capture gait abnormalities, dementia, and falls. And so you see that only the gait dementia variant of PD do you see this dose-response relation? So phenotype probably is influenced by environmental risk factors, and we've seen this in manganese, where a lot of our work is as well. So we have done this in AD, and this is not particularly surprising to anybody that we can demonstrate that on the left, this is a BILISA again, showing high exposure to PM2.5 and high AD risk. And on the left and on the right, you see a somewhat flatter dose-response relation between annual PM2.5 and relative risk of AD. So pretty dozens of studies have shown this, but just sort of proof of principle, we can see pretty much the same thing using in AD-RD as well. All right, that's not very interesting because other people have done that, but it's sort of proof of principle, yes, we can study this disease. But not all geospatial clustering is due to the environment. So AD is much more complicated. PD is a great disease to study because it probably has mostly environmentally mediated. I mean, there's, you know, and we can debate that over coffee later, but PD is definitely a more clearly environmental disease. AD is much more complicated. So what you see on the left is the SIR for all-cause dementia, and it's the BILISA looking at the correlation between cardiometabolic disease. And this is 8 diseases coded in what we call the CCW. A very rigorous way of identifying people with stroke and various forms of heart disease and hyperlipidemia. And this is work done by George Carway in my lab. On the right, you see the population attributable fraction of CMD on dementia. And what you see is in that area of the country in the south where we see the stroke belt with the worst health, we see that you see the greatest population attributable fraction of CMD on dementia. As much as 60% of all-cause dementia in these counties, this is county-level research work, can be attributed to cardiometabolic disease. So huge public health message here. This is where the money is with all-cause dementia. You've got to address these risk factors that we all know are really important. So that makes, obviously, AD more complicated. You have to address and you have to adjust for cardiometabolic disease in your models. So this is some more work done by Brittany Kurzanowski and Vishal Harner, a medical student in the lab. So Brittany looked at a subset of PM2.5 in relation to all-cause dementia risk, and we see that you pretty much see a dose-response relation for traffic-related air pollution and all sort of subcomponents of traffic air pollution. This is data from NEMO. And I flipped the paradigm a little bit. So in the graph on the map on the top right, you see a GWR showing where in the country you see the greatest relationship between traffic-related air pollution and all-cause dementia risk. And on the bottom, we put the BILISA in this way on purpose because if you wanted to focus on cities where you have the highest PM2.5 and highest dementia risk, but also where you see the highest coefficients, it's Boston, New York, and St. Louis where you'd have the greatest impact public health-wise. So flipping the paradigm a little bit to sort of identify where can we intervene at the environmental level to have the greatest public health impact. I'll finish with the FTD work that Ben Schumacher has been doing in the lab. And so Ben, this is the only work that I'm showing today that's sort of truly discovery-based in silico exposomics. So Ben took 175 nanochemicals in an unprecedentedly large study of frontal temporal dementia, almost 48,000 cases and 190,000 controls. And we identified 24 toxicants that were associated with FTD after adjusting for multiple comparisons. The top signals were this group of 9 industrial solvents in the environment measured in NADA. So yes, where do we see it? Does this explain that clustering in the United States? Absolutely not, unfortunately. So we got some work to do on that. But interestingly, these are very highly correlated. So you have 2 groups of solvents. One group that's that's represented on the left with trimethylpentane. You see this clustering of beta coefficients in California, into Georgia and the Carolinas, and up into the Northeast. And then hexone, you see some overlap, but really you don't see that southeastern portion. So we have some evidence that, at least in certain parts of the country, that frontal temporal dementia is related to industrial solvent exposure. And this is a disease where almost no research has gone into environment. It's almost exclusively focused on biomarkers and pathophysiology of tau and genetics. About 30% of this disease is genetic, but 70% is not, but nobody focuses on this piece. And this is and we approached FTD because its phenotype is unique enough that we believe it's more identifiable in claims data. So conclusions, PD and AD and FTD have unique geospatial disease patterns. PM2.5 increases risk of PD and AD, but the risk varies throughout the United States. TCE increases the risk of PD, and specific facilities may contribute to this risk. And then AD is associated with TRAP, especially in St. Louis, New York, and Boston. Bob, you've lived in 2 of those. I've lived in 1 of those. And then FTD may be associated with exposure to industrial solvents, an area, the brand new area that we're hoping to explore in future work. So I invite you to visit us if you are ever in town in in Phoenix. I've spent 2 years in St. Louis. So this is the Bayer Neuroanalytics Center where my lab and other labs are based, where all of our environmental work is based, as well as other labs. About 20,000 square feet of dry lab space, all dedicated to computer-based research. And these are our funders, and of course we're very appreciative to the dozens of people who've trained in the lab over the years. Okay, I'm done. Yeah. They all just want to see David Balshaw talk.
Hi, great talk. Natalia Vilor-Tejedor from Utrecht University. Yesterday we were discussing, based on the Livingston curve, the impact of air pollution on dementia. And in Livingston curves, they reported at late life. I partially disagree. And actually we saw in some preclinical studies impact on amyloid positive individuals, etc., through more mechanistically neurovascular and inflammatory processes. I want to know your opinion about that.
So is the question on timing? Or the role of...
So they reported that air pollution impacts dementia late life. I think it's much more before. Yeah. What is your opinion, what you observe in your studies?
Yeah, I have lots of opinions on this, but no answers. When I see the presentations that talk about these windows, and Bob and I have talked about this, my wife and I have talked about this actually. I don't know what that relevant window is, but I do know that we rarely study it, and I don't actually know how to even begin to design a study to address that window, because to do the studies that are needed, one, the sample sizes are massive to do the studies that are needed. This is what Remy was getting at yesterday. You need to say millions of people starting at a very young age to understand what those windows are. And we literally, the older people in the audience, me and Bob included, are not going to be around to see the results of the studies. These are very complicated studies to do. I don't know what that window is. And in PD, it's complicated because there are risk factors for PD that are formed, before teenage years, personality and other factors that are actually pretty important in PD risk. So I think there's a component of risk that's probably coded in very early on in life, but studying people at 50, is definitely not the right window, because we know that pathology is progressing. An 80 window is much longer than PD.
Thank you.
Brad, great talk. Just a question. So with the CMS data, you're dealing with people who are age 65. So you're actually looking at essentially where they live when they retired or they're at age 65. But as we know that there are a lot of exposures that have happened much earlier in life. Yep. Do we have any sense of what percentage of the population in the United States is highly mobile? Yeah. So looking at something at 65 may not actually truly reflect. You may be seeing an impact of all those farmers from Wisconsin that are retiring in Texas and Florida.
Yeah, so very good question. So we do have data. Every paper we write, we have to actually look at this. We have the ability, so if we look at people who are 75, we have 10 years of data, so we can look at mobility in that range. And there are some data on this. About 85% of people are non-mobile. Now, I tried to get CMS to give me some data, I wanted to buy some data from them to get the first 3 digits of people's Social Security number. Because if we can get that, we know the general region that they live in, but they wouldn't let us have it. It's not identifying, right? Because it's just your region code, it's where you were born. And it would really allow us to kind of get at this a little bit, but CMS just wouldn't allow it. So I think there's opportunities. We talk about cohorts. Medicare is a giant cohort for us. If we can do a better job of harnessing that, I think there's some power to that. But the residential piece, if we could actually know people's lifetime residential history, this work is exponentially more powerful. But this is, I'm sorry, Medicaid. Well, but Medicaid's very biased, right? Medicaid's based to the poor, people with disabilities, and so it's you can use that, and it's very difficult to work with because the states manage it differently, so the data is much harder to clean and reconcile across the different states. So we've not done much with it because it's a huge hassle, and I don't think it's going to have the same breadth and power that we would see with Medicare. I'm getting the hook. Oh, okay. All right, good. We have a question. This late.
Sorry, Bob. Yeah,
I
finished
try
early,
to keep
so
on time.
we can have a couple more questions.
Hi, Rolf Meulen, Utrecht University. Thanks for a wonderful talk, and I will build on that later in this afternoon. Just a comment, because we have a somewhat US focused on what we can do with this kind of HR data. Just being in the European perspective, that within the census data of the Nordic countries, including the Netherlands, we do have complete residential histories. If you then look at how many people move, at least for the Netherlands, that's about 5% of the population per year. But the interesting thing is then that people do not change very much their exposure status. So when we look basically at mobility, that people that were high move but are still most likely high in air pollution, and the ones that were low move in their vicinity but stay basically in a low area. So there's basically, to come back to Rick, at least within the European data, good evidence that it is stable over time, and therefore I would argue that this data, and I would argue perhaps also for the US, that it does have relevance also to reflect the earlier life exposures. But this needs more research, but I think this can actually be done.
No, I appreciate that. And we've done some work in Finland in the past, and one of the challenges is that Finland has 5 million people, right? It's the Maricopa County where we live has 5 million people. So I think you need the combination of these different studies to really sort of inform the field. No one of these is going to be the answer. And we do, obviously we all rely on convergence of data to really to provide the most conclusive evidence.
Hello, nice, great talk. So you've talked about some correlation between PM 2.5, and then you've also talked about some correlation between chemicals. I'm wondering what's the reason for looking at those specific chemicals, and is there any correlation between PM 2.5 and those chemicals specifically? Yeah.
So those specific chemical models, TCE and all solvents are adjusted for PM 2.5. So we always address that because, they are correlated. So everything's adjusted to the extent you can. Now, there's some of these that are so correlated with PM 2.5, or at least traffic-related pollution that you can't you really can't isolate that individual effect. So we're still teasing that out. So why those chemicals? So TCE, there have been a couple of military studies showing association with TCE. So we wanted to look at airborne TCE. So that was why we looked at that. And the FTD work was purely discovery based. It was purely to do some exploratory work to identify novel risk factors, because there just hasn't been work. It would be very difficult to even develop a hypothesis with FTD because people haven't done it. The work is the funding has been almost entirely focused on these non-environmental areas. Okay, I'll give you plenty of time. Thank you.
So we have solved the technical difficulties. So it's my pleasure to introduce our second day's keynote speaker, Dr. David Balshaw, who is Director of the Division of Extramural Research and Training at the National Institute of Environmental Health Sciences at the National Institutes of Health in Bethesda, Maryland. No, it's Bethesda? North Carolina, that's right. I knew that. David, welcome. Thank you.
Sort of have the technical problem solved.
Watching it in real time.
Indeed. As we're getting the presentation loaded in, just to kind of orient to how I approach this. So when Bob invited me to speak, he's like, you know, the Exposome's turning 21 this summer, and I'm one of the few people that has been playing in the Exposome for all 21 years, and in fact, as you'll see, even a little bit before that. And so it was a really fun opportunity to kind of go back and think about where were we 21 years ago, and how did we think about this? And really, it got me thinking a little bit about my own career and what is so much fun about being a program officer. Is the ability, when you come in and you're young and you're thinking about the role is not to do the science, it's to think about where do you want the science to be in 20 years. And now we're 20 years later and the science is where we want it to be. And so it's been a lot of fun, and I think we're ready to go. Cool. Okay. So the Exposome at 21. How do we get here, and where are we going? So we're going to step back in time, and we're actually going to go more than 21 years ago. We're going to go back to 2001, where you saw the culmination of another 20 years of effort, both by the government in the Human Genome Project, but also by the private sector with the Craig Ventnor completion of the Human Genome Project. And this was the solution to everything in health. We have been told that the genetics are the root cause of all disease. And once we have completed the genome, all the questions will be answered. Well, obviously that's not true. And we knew even then that that was not true. But it really did bring a very different mindset to how we conduct research of the change from focusing on a candidate gene and you're looking at what are the variants in this gene and how is that leading to whatever disease, to thinking about the whole genome and the whole area of genomics coming about. So what were we doing in the environmental health sciences in the early 2000s? Our mindset hadn't really changed that much in the early 2000s. So we were still working under the paradigm from Ricky Pereira and the 1987 National Research Council report on what is the stratagem to get from exposure to disease, going through the internalized dose, what is the biological effective dose, what are the early biological effects, the altered structure function, the clinical disease presentation, and then the ultimate outcome. And then also thinking about points of departure. So, if you're in the adverse outcome pathway area, we're still using all of this thinking, but this was the framework that we were operating under. Of you have normal biology and something in the environment perturbs it, and you go down the route towards disease. As the Human Genome Project was being completed, you started to see people, not even in the environmental health sciences. So Walter Willett was publishing, if you look at the 4 major causes of morbidity, mortality in the United States, cancer, stroke, heart disease, diabetes, very little of that is actually attributable to genetics. This is 2002. This isn't 2026. It's due to environmental factors. Willett was only looking at 4 exposures: diet and alcohol, smoking, and physical activity. So this is not the NIEHS definition of environment. This is a much broader, more fundamental part of environment. But we didn't really have very strong metrics for any of this. We were using in the. Oh, I need to get closer. Okay. So we were using much coarser techniques to do our environmental assessment. most of this was based on questionnaire survey data with very low correlation, very low accuracy. Or we were working with the fixed site monitors from EPA and a few mobile monitors. So you were doing a local study and you could take a field deployable monitor out and do the assessment. There were some wearables that were, not really wearable. So we had, 30-pound backpacks with PM monitors with vacuum pumps and all of this stuff. And we asked kids to go play. And of course, the first thing they did was they took the backpack off. And so you're not actually measuring their exposure. You're measuring something that's close to their exposure. So jumping forward just a few years to 2005 with the firebrand and what I would call a silent revolution. So we all know the landmark paper that Chris Wilde published in 2005, just shy of 21 years ago. So it's the beginning of August, where he was reflecting on the completion of the Genome Project, and we said, in environmental health, we need the same mindset change. We need to think about the exposome. And at its most complete, it's the life course environmental exposures, including lifestyle factors from the prenatal period onwards. But he also was very honest about the challenges that implementing that mindset was going to be. So we have to develop the tools, the capability to be able to do that. That's going to be very difficult to do. And unlike the genome, the environment is not static. It's very highly dynamic. It is, as we just saw with Brad's presentation, it's spatial. It's dynamic in time, in space, and your response to the environment is different throughout the life course. So what were we doing at NIEHS in 2005, and actually a little bit earlier than that? We were not as focused, when I came to NIEHS in 2003, we were not as focused on the exposure side of environmental health. We were very much focused on the biological side of environmental health. And a little known fact is that NIEHS was actually one of the big innovators in omics at NIH. So we did one of the very first genomics projects. We had the Environmental Genome Project, which was looking, it was a candidate gene approach. This started before the completion of the Genome Project in the late 90s, looking primarily in P450s for variants that altered the response to environmental exposures. We had the Toxicogenomics Research Consortium, which was NIH's very first transcriptomics program, trying to develop and understand the variability of transcriptomics technologies and apply that to environmental health sciences. We had NIH's very first proteomics initiative, looking at proteomics approaches to understand the biological response to exposure. And we had the NIH's very first program in metabolomics. We held the first workshop and published, I believe, the first article that used the term metabolomics was a result of that workshop. We also were the lead on the NIH epigenomics roadmap program. So before the Common Fund, we had the NIH roadmap, and one of the first projects through that was our epigenomics program. And our goal with all of this was to develop the technologies to be able to understand how the biological system, so a systems biology approach, to understand the comprehensive response to environmental exposure. So when I came in, one of my major contributions was we also need to think about how we do the exposure different. Fortunately, we had leadership at NIEHS and NHGRI at the time that was actually pretty keen on really getting into understanding gene-environment interactions. And Francis Collins and David Schwartz managed to make a pitch to Congress that we need a concrete investment to understand gene-environment interaction. But in order to do that, we need to develop the fundamental capabilities first. So we got, I believe, $80 million from Congress specifically to do the NIH Genes Environment and Health Initiative. So I got to lead the exposure biology program on this, which was really focused on enhancing the exposure side. And the Genome Institute, under Francis's leadership, so he was the director of NHGRI then, they had the bulk of the money to do genome-wide association studies. So the first GWAS that were published came out of this program, as well as the statistical methodology to do this. The concept of a haplotype map came out of this program. Really, this changed a lot on both sides of the domain. On the exposure biology program, we had a number of different initiatives focused on improving exposure assessment, but not just chemical exposures. So we were focused on chemical exposures, but we were also trying to develop technologies to improve nutritional assessment. So the cell phone pictures that identify what you're eating, how much of it you're eating, those came out of this program. Physical activity assessments, so actigraphs did exist at this time, but something like your Garmin watch, this did not exist. We developed the kernel of those ideas through this program. Psychological stress and use of addictive substances was a focus here, so developing ecological momentary assessment technologies to do contextual prompts. They were looking at stress markers and behavioral cues from wearable sensors, and they would send text messages to do prompts of what's going on in your environment with very short surveys on this. So we also had an idea within this that we not only wanted to improve the exposure assessment, but we wanted to improve the linkage of exposure with biological response. So in the chemical exposures, we had sensors for VOCs, particulates, pesticides. In the nutrition side, we had some alcohol assessment and those things. But we linked this to projects that were using that systems approach to look at biological response and identify early biomarkers of susceptibility in readily accessible biological tissues. So that program was active from 2007 through 2010. And the real focus of the sensor side was developing things that are very usable. They're low, minimally invasive sensors focused on improving, can we measure more things with greater precision and with near real-time spatial resolution, those kinds of things, lightweight, easy to use. We followed that up with a validation program that was really focused on can we do those sensors actually work to measure what we said that they're going to work with ranges that are appropriate to environmental variation, and how do we deploy them? So are they actually usable? Can we put them into a mailer and send them out? So some of the interesting things that we found is if you're doing that, weight actually matters. So one of our PM sensors, the RTI micropalm, was about a 300-gram sensor. But if you could get it less than 250 grams, the cost of mailing went out or went down. So it becomes just a very simple deployment issue of decrease the size a little bit, decrease the weight a little bit, and you save your study tens of thousands of dollars on postal service expenses, things that you would just not think about as a researcher. So these are some of the technologies that we developed. Most of these are commercially available today, or variants of them. There's been a lot of continued development in this space. But we were also starting to broaden some of the perspective of how do we do the data integration. So how do we take data from questionnaire, from wearable sensors, from the EPA monitoring station? How do we integrate all of that data together? How do we create the maps and doing the correlations like Brad was talking about? So as we were doing that transition from the GEI and the exposure biology program to the validation and starting to think about what are the next steps, I want to give a lot of credit to Steve Rappaport and the real critical insight that he had. So in 2009, he actually read Chris's paper for the first time. And he's like, the way he has described it is like, his mind opened, and he's like, this is something that is going to fundamentally change our world if we can do it. So he happened to be on a National Academies panel at the time, and he said, hey, National Academies, why don't we do a workshop on the exposome and have a conversation with the community about, is this something that's real? Is this something that we can do? And as a result of that, he and Martin Smith published the first science article that really laid out how could you implement an exposome project, thinking about the multiple exposure assessments that you could do. The same year was the year that Chirag Patel, as a graduate student working with Atul Boot and this guy named Jay Bhattacharya at Stanford, published his first paper taking NHANES and trying to do a non-targeted analysis, taking all of the analytes that CDC was measuring for NHANES and just saying, what of those correlate with type 2 diabetes, with uncontrolled glucose over 120? And can we discover environmental exposures that are associating with diabetes that we didn't know? And I think there's two important take-homes from that study. One was, yes, you can identify things that you don't know, but you can also identify things that you do know. And I think that that's one of the under-recognized parts of discovery science, is the validation of the approach is you can confirm the known knowns in your discovery science. Because we've been working on these areas for a long time, and we do know a lot. So I'm going to skip over most of the next 15 years in just a few slides to start to think about where are we going from here. So a lot of this has been covered in other venues, and many people already know this, but after that 2010 paper and Chirag's paper, you started to see more and more what I would call comprehensive exposure assessment activities. They weren't really exposome efforts, but they were done with an eye towards building that. So we'll hear from Soji later on JEX and what was happening in Japan. We'll hear from Roll, and we'll see what was happening in the Framework 7 and 10. In 2015, we established the Hercules Center, and we also established CHEER, which was the first real exposome effort that we did at NIH. 2016, we established the ECHO Consortium to start to implement exposome on a tens of thousands of participants scale. And now we're at the era where we've got people that are actually publishing real data on exposomics, doing the epidemiological studies, and we have these global coordination efforts of Nexus, IHAN, the Exposome Moonshot Forum that are starting, and GEC, that are starting to pull the community together to think about how do we do this on the scale of a human genome project. And we've seen it happen in the literature as well. So that first publication in 2005, the word exposome does not appear again in PubMed until Stephen and Martin's paper in 2010. There's not a second incidence. Now we're up to, we're on course for hitting 1,000 publications this year. So we're really getting there. We've kind of achieved success in building the capacity and implementing the exposome. So where are we going next? Where do I think, as a driver, but not a doer, what are some of the things that I think are next? And I want to put a little bit of a disclaimer on this, that these are my own thoughts. When I was putting this together, I was like, oh, I'm going to be very provocative, and I don't know that I actually was as it came together. I think that a lot of this is things that you've already heard from others at this meeting, but these are not the stance of NIH or the US government. With that, I actually think, and this is me, David, speaking, not the director of extramural at NIEHS. I think we have an unprecedented opportunity right now. We have the MAHA agenda. If you read it outside of a political lens and you put the science first, it is one of the most exciting things that I have seen from the United States government, from an administration. Every line of it is environmental health and the exposome at the forefront. And to back that up, we have, obviously that is a passion of Bobby Kennedy, the Secretary of Health in the United States. But we have Jay Bhattacharya, the NIH director, who is absolutely bought in on the exposome. We have we have strong leadership at NIEHS. Rick got us started, and now I think Kyle is coming in and is driving things in a very positive way. We have an opportunity to deliver and to convince the broader biomedical research community that what we're doing is real, it's important, it's going to give us information on what leads to disease and what can we do to prevent disease and improve health. I nodded to the global coordination, and I think that this is really where the opportunity for us to develop a human exposome project is going to come, because I don't think that a human exposome project can be led by a single country. The Human Genome Project was predominantly led by the United States. It was an international effort, but it was very US-centric. I don't think that an exposome program project can be US-centric. I think it has to be a global effort because the variation in the exposome is too broad. If we really want to understand what is the baseline and what is the normal variation, we have to do it on a global scale. And so having these global coordination efforts where we're bringing people together to think about what are the technologies, how do we do it, what are the ethical implications of conducting an exposome project, bringing the community together to talk through these issues, and importantly to say, what is the goal? What is completion? So if you step back to the Genome Project, the completion in 2001 was not complete. It wasn't completed until, 2003, they did the T-to-T sequence? So it's more than 20 years after they completed the genome that they actually completed the genome. And so what are we going to define as the point of completion for the project? And then I think that there's also the real public health potential of the exposome and applying that to improved health through precision environmental health and thinking about how do we use the exposome in a data integration paradigm to understand what are the drivers and what are the interventions to improve health at the individual level and at the population level. So what are the policy, what are the behavior changes, what are the activities that we can do to improve health, understanding the individual risk, the individual response, similar to precision medicine, but how does that then lead to improvements in health at the population level? And then I think importantly, how do we integrate the exposome into other omic approaches and thinking about that biological piece of the response and really starting to get at what is the latency, because one of the real key drivers of environmental health is only in a few cases do you have a direct acute relationship between environmental exposure now and disease now. Most of the time there's years or even decades of lag in between where you have a prenatal exposure that is leading to PD in late life. And how do we understand what are the molecular signatures underneath that? So as I'm wrapping up, my thoughts on what are the next steps. We need to maintain momentum. So we need to continue the effort that we have in building the capacity to do the exposomics. the standardization of the technologies, and I think one of the important things is we need to commoditize the exposomic analysis. So when transcriptomics actually became reality is when we got away from doing the kids in the room don't remember, when we used to do transcriptomics, we had inkjet printers in our labs that put little dots of mRNA or oligonucleotides on a microscope slide, and we put those into the Fluorimeter. Correlation within a lab with a single technician doing it was abysmal, let alone lab-to-lab variation. Where that actually took off was when you had commercially printed arrays that had controls manufacturing, and then ultimately the evolution of that technology into mRNA-seq and those kinds of things. But it was the commoditization that is what actually had it take off, that you didn't have to be an expert. You don't have to be an analytical chemist to do the mass spec. You can just buy a package to do it. And I think particularly in the United States for the next couple of years, demonstration. We need to show take advantage of the opportunity that we have now to show the value of this across biomedical research. We need to continue efforts to build the visibility and nurture those partnerships. So, we've heard a few comments that, you might need 1 million people to do this. How are we going to get cohorts with 1 million people? Well, we're going to build partnerships with the cohorts that already exist. There's things like the Global Alliance for Chronic Disease or the International 100,000 Cohort Consortium that are already thinking about, from the genomic side, how can they do analysis and understand the role of genomics in chronic disease on a global scale. Let's work with those communities to implement an exposome in that as well. And then really start to think about how does the exposome not just inform us about what are the unknown and unknown exposures that are contributing to disease, but what do we do about it? How do we integrate that into clinical practice? One of the things that we've been talking for a few years at NIEHS about is how do we build environmental health, not just the exposome, but environmental health, period, into the relationship of a primary care physician with their patient. You go in for your annual physical, and not only is your phenotype, your blood pressure, heart rate, whatever, being integrated into your course of care, but your exposure is as well. And with that, my timer is done by 10 seconds, and I am done. So thank you all, and I'm happy to take any questions.
Thank you, Dave. That was fantastic. I have a question about what you said about what's the beginning and what's the end of the exposome. Since environment never stops changing, some of the PFAS chemicals we're exposed to today didn't exist 10 years ago. Social media didn't exist 25 years ago. Why do we need to know the beginning and the end?
So I think if we're going to call it a project, a human exposome project, I think part of the billing for that is understanding what the deliverable is at the completion of the project. So I don't think it has to be the original Chris Wilde, totality that gets invoked a lot. But I think we as a community need to say, when have we done enough to understand what is, in my view, the baseline exposome, and what is the normal variation of that, in space. So if I really liked Brad's point about what you're exposed to really does vary very highly by where you live, and that may be contributing to different etiology of disease in those places. So having that map, I think, is really critical.
So as a suggestion, could we define it by life course? We could do a study where we enroll people at all different ages, from pregnancy, birth, and onward till being old like us.
Yeah.
And that's the definition, so that we understand it at each life stage. And then I think we have to acknowledge that we have to always monitor it because it's going to change.
Yeah. Yeah, no, some of the conversation that we were having on the boat and over dinner last night is, how do we build the transitive property, if you want to call it that, of, you have early life exposure that's correlated with an epigenetic mark, and then you see in adulthood that epigenetic mark is associated with some preclinical phenotype, which, in a completely different study, you have association of that adult preclinical phenotype with an elderly onset of disease, and you kind of reconstruct the study without having to take a lifetime. That was one of the original complaints of the exposome, is if you're going to do life course epidemiology, those studies are going to take a lifetime to do, and I think it's a solvable problem.
I would just hearken, as a pediatrician, I hearken back to the first growth curves. The way they did it was a time series, so they just measured growth of different children who were at different ages, and they did that in like 2 years. But then they did a longitudinal study that took obviously 20 years, and they did get different results. But the first one got something on the table that was useful, and then the second one, was probably a little bit better, but took a long time.
Yeah, but I think there's a lesson from that as well, that those charts that we use today, I think are the ones that were developed in the 80s. So
right, and we are our growth has it's changed. So it has to be constantly.
It has to be updated regularly, and I think that gets back to your point of the environment is constantly changing. So we're going to have to build into the program the regular updates of what is exposure.
Thank you so much for the great talk. My name is Sarah Assaf. I'm a PhD student in epidemiology from the American University of Beirut. It's very interesting to view the trajectory of how Exposome came to life in US and Europe and other developed countries, and especially since introduction in 2010, and how it has taken on wide research attention and its wonderful findings. But I was thinking, what about the Eastern world and other less developed countries? And I think expanding Exposome toward these countries should be a priority of the next steps, because people there are vulnerable and have different exposure profile. So what do you think are the challenges in expanding Exposome there, and what's the process of expanding it?
Yeah, I think it's a very important question, and it's actually one that garnered a lot of discussion. So we recently had the Global Exposome Summit meeting outside of Barcelona, and there was a lot of discussion there about how do we integrate the Global South and lower resource countries into this. And I think that point that I was making about the commoditization of the technology. So let the United States and Europe develop the technology and the capability, because we have the resources to do that. But let us develop it in a way that it's readily deployable by the lower resource researchers. It's not cost prohibitive to do that. And it's responsive to their needs and interests. So I think that there's an awareness of that within the community. And as we're driving this at NIH, and I know the European Commission is thinking in similar ways, that this is part of the goal, is to have this be usable.
So it's a pleasure to introduce our final speaker of the morning. Here we go, Dr. Nicholas Skarmeas, who is professor of neurology at the University of Athens, and he also holds an appointment at Columbia in my hometown in New York City.
Okay. So I would like to start by thanking Cecilia and the rest of the group for inviting me to this wonderful city. I will try to, to review a little bit the complexities when we look into the relation between nutrition and cognition and dementia. So I will take you a little bit from the more general to the more concrete, and it's a little bit, and maybe I will take you from big numbers to smaller numbers. So let me try to show to you some of the methodological challenges, but also some of the literature and where do we go from there. So this indicates that there's an effort to rather than asking people what they eat, to measure biomarkers in their blood. So and here's an example on the left. You have different food groups, and then you have different biomarkers that have been identified to to measure, to estimate the consumption of these food groups. There are about 50 of them. Here on the right side, there are these remaining things to do regarding these particular 50 biomarkers. A lot of issues, a lot of gaps in our understanding of these 50 biomarkers. So it's like every other biomarker, it's not a trivial thing. We have to have information about those responses. We have to have replication in different cohorts. We have to have stability information and so forth. So all this work has recently started trying to estimate these biomarkers that reflect food intake, and it's really in the infancy. But so I showed you, more or less 50 food-related biomarkers, but the reality is that there are many more. This is the so-called the nutrition dark matter, and so let me see if I can. Okay. So you can see here there are about 140,000 chemical compounds that are estimated to exist in what we eat every day. These are color-coded based on structural subclasses and chemical similarities. And just to give you an idea, on the right side, you can just see garlic. Imagine what proportion of our everyday diet is garlic. And just in garlic, there are about 6,000 to 7,000 compounds, just in garlic. And you can see where they are in this nutrition dark matter. So it's quite more complex, and we have started, scratching the surface by trying to estimate, 50. And these compounds, they seem to be very biologically relevant. So what you see here are about, 18,000 human proteins. And that's what you see at the background in the gray color. And in pink color, you see which of these proteins are targeted by the food molecules that I showed you before. So almost half of the proteins we have in our body are targeted by these food proteins. So it seems that it's very biologically relevant and very pertinent. So the biomarker part of nutrition is still, in its infancy, but let's move a little bit to foods, right? So maybe we can move one level higher up in the pyramid. So the association between foods and cognitive change is not, it's not very well, it's quite conflicting. So this is a study we did a few years ago. We tried to take into account, big studies, more than 1,000 participants, prospective studies, and studies that included people who are cognitively healthy, and looking at changes, incidence of dementia or changes of cognitive function over time. So it's prevention data, it's not prognosis data, it's not people who already have dementia. And what you see in green are studies that suggest that there's a beneficial association for this particular nutrient or food group, and then in red, detrimental association, and then in yellow, neutral, so no association indicated. And as you can see, there's some data for, from flavonoids, for poly or monounsaturated fatty acids, for alcohol, for caffeine, for fish, for vegetables, but overall it's a very conflicting literature. And the truth of the matter is one could pick and choose a study and support an idea that has in his head, but if one looks at the whole universe, it's not clear about the beneficial or detrimental effects of different foods. But in reality, we do not eat nutrients. We don't eat vitamin A for breakfast and vitamin C for dinner, right? And we eat foods in combination. So one other approach in the nutrition science is to look at dietary patterns, combinations of foods. And there are many different dietary patterns. One could look into this article to compare one to the other. We have the Mediterranean type diet, and you can see from the nutrients and the food groups what identifies each of these dietary patterns. And actually, there are many more. There are many more. So one could look in a more holistic way into nutrition. So what about the literature on dietary patterns and cognition or dementia? The one that has most support for is the Mediterranean type diet. So one of these green dots is our study in Manhattan, another one in Greece, another one actually is the 3-city study here in France and in Bordeaux. And you can see that there is research for not only the Mediterranean diet, but for some other dietary patterns. I'm not sure it's enough, but there is some hint. But again, there are also conflicting results. So now I will go from the exposure part to the outcome part. So let's go into the cognition or the dementia part. So, cognition by itself is quite complex, although we use a word, but, it's, our language skills, it's our memory, and there are different types of memory, it's our visual spatial skills, it's our emotions, it's our judgment, right? So it's even in its phenotype, it's quite complex, but also it's quite complex in terms of the underlying neurobiological mechanisms. So we always have in mind amyloid, for example, on the top left, which is, the main, neuropathology relating to Alzheimer's type dementia and tau, but there are so many other neuropathologies. So, there's alpha-synuclein, there's TDP43, we have the so-called late, and there are vascular changes, there's inflammation, there's oxidative stress, and so forth. And if one looks actually at autopsy series, the most common underlying pathology of dementia is mixed dementia. So having isolated amyloidosis in the brain is about 20%, 25%. The most common is amyloid plus something else. And there are many different combinations of pathologies. So there's a lot of complexity in terms of the outcome part. So could nutrition affect some of these neuropathological pathways? So here's a study from New York a few years ago. I will just show you a couple of examples. 70, cognitively normal people followed for 3 years. So what they found in the study was that people who were following a diet that was more close to Mediterranean diet principles, a healthier diet, they had slower rates of amyloid accumulation over time in their brain. That's what you see with 0.6% per year with the red line, and then with the blue line were those who were following a less healthy diet, a diet that was further away from Mediterranean diet principles. And in collaboration with our colleagues in Australia, the ABLE study, we showed something similar. We replicated this finding. So what you see here, the tertiles are, number 3 are those who follow more Mediterranean type principles. And then you can see on the y-axis the rate of amyloid accumulation over the course of 3 years. So those that were following a healthier dietary pattern, they were accumulating less amyloid over time. So it seems that diet affects, brain amyloidosis, and there are actually, studies, touching into some of these other, neurobiopathological changes in the brain. Not that many, I would say. So this is one way to go to look at nutrition and look at a particular neuropathology, but it's not as simple. Because, one could imagine, let's say, a nutrient or a food affecting maybe in a positive way with green, let's say, a vascular mechanism, and then in a negative way in red, maybe a neurodegenerative mechanism, and maybe not affecting some other mechanisms in blue. And then the effect on cognition would be like a linear combination, the weighted sum of the effects in these particular mechanisms. And then imagine what happens when we add the second nutrient, right? Which could have different effects on different pathways. So the truth is that it becomes very, very complex. And keep in mind, we're talking about one aspect of the exposome here, right? And so how can we better capture, estimate these effects of nutrition in these different mechanisms, pathways? So I will just show you a couple of examples. Of course, it's not a solution, just a very, very tiny attempt. So we have developed in Athens this study, it's called the Albion study. So it started in 2018. So we're focusing, like everybody, in the preclinical, in the prodromal stages. So we're trying to go early. And of course, we have an emphasis on lifestyle. And because we try to go early, we recruit from the age of 40, trying to go before the neuropathology in the brain has started. And we don't recruit people with dementia, but people who are cognitively normal, or at most they have mild cognitive problems. So before the phenotype of dementia develops. And right now, we have about 450 participants. It's an open study. We keep on recruiting, and we keep on following up. On average, we have 3.5 years of follow-up. These are the number of visits. We don't really have attrition, but it's just not enough participants have reached, the 6 or the 8 year mark. So what do we have in this study? Of course, as you can see, we have information on nutrition and on cognitive function, but we try to use wearables, and we try to have an MRI, an electroencephalogram, and we try to use to have a lot of biomarkers. Beyond stool and beyond blood, we also try to get CSF. So we have CSF on everybody, and I think that's the most important asset of this study for now and for the future. And we are in the process of estimating many different biological information, on stool, in blood, of course, we have the genetics, and in CSF. Some of this is in progress, some of this has been completed, not for everybody, but for the majority. So we have, for example, metabolomics in the blood, and we have proteomics in CSF, untargeted proteomics, and we have started, looking into that. So one way to look into diet using this type of approach, actually, I have to say that one of the limitations is what we heard yesterday. I mean, we have much more data than participants, which is a big challenge. But maybe in collaboration with other studies, we will be able to capitalize on this information. So one way would be to have some sort of molecular signature of different diets. So what you can see here, we started with a Mediterranean diet. The Mediterranean diet could be estimated using different scores. You can see the MDS, Mediterranean Diet Score, the MIND diet. So we can have different estimates, and sometimes the reason we have conflicting results in nutritional epidemiology is because of the way we estimate the exposure. So we wanted to see whether we could estimate a metabolite signature of a Mediterranean type diet, and examine its association with cognitive performance. So we had a population-based study, the HELIAD, you see on the right, and we derived this metabolic pattern. And then in the Albion study that I showed you before, we replicated. So we created a pattern of about 30 metabolites that was capturing this essence of a Mediterranean-type diet. And actually, this pattern was mostly related to lipid pathways and inflammatory pathways and neurodegenerative pathways from the pathway analysis. And interestingly, we found that it was related to memory, both cross-sectionally and longitudinally, and it was performing better than the dietary scores that we were getting from the questionnaires. So it was capturing something more biologically relevant. So this is just an example. Of course, we're talking about nutrition and nutrients and foods and patterns, but there are other aspects of nutrition, other aspects of the exposome in general that haven't been touched yet. So one of these is what is called chrononutrition. So, there's almost no literature, very minimal literature on aspects like, does it play a role how many times I eat a day? Does it play a role on when do I eat? Does it play a role of when do I have my breakfast or when do I have my dinner in relation to sleep, which is another very important factor? Does it play a role that I go to a conference in Bordeaux and then the regularity of my meals completely changes? The distribution within and across meal of all these nutrients. So all these things have not been looked at all. There are different aspects of nutrition. and different aspects of the exposome. And part of the reason is that it has to do with the way we collect the information. For example, the food frequency questionnaires is the usual way to collect this information. So we ask people what they usually eat over the course of the last month, the last 6 months, the last year. So we do not have this temporal information. In order to do this, you need to have these dietary recalls. So that's what we have in Albion. So in each participant, we have 4 dietary interviews on 4 different days. So we ask them what do they eat on this particular day and when do they eat it. So we have this temporal dimension of the information. I will just show you just a couple of examples very briefly. So this is a few years ago. This is people who are cognitively normal versus people who had mild problems at baseline. And if you look at their calories, they consume more or less the same calories. But if you look at the timing information, so let me guide you here. So what you have circled is 8 o'clock in the evening, 8 p.m., right? And on the right side, you see the global cognitive score. When you go from -3, z-scores to 0, you go from abnormal to normal. So people who are cognitively better, they consume most of their calories in the evening. And the opposite happens in the morning. You see here the caloric intake in the morning. So you see on the left, you go from 0 to -3 cognitive z-scores, and you can see, it's going up. So although we have groups of people that consume the same amount of calories, when do they consume the calories seems to relate to their cognitive performance. And without taking of your time, we had another study looking at how frequently we eat. So what we were finding there is that the more frequent eating and eating at later times was related to better cognitive performance. Very small study, very, very much in the beginning, but I just want to indicate you how much we still need to learn in this field. Another issue here is the issue of observational studies versus experimental approaches versus clinical trials. So I showed you before, this is the same slide I showed you before, the different nutrients and food groups and their relation with incident cognitive performance. And you see here the observational studies. Look at the trials. It's almost empty, right? Something not very dissimilar happens for dietary patterns. So these are the observational studies, and these are the trials. So the truth is that in terms of experimental manipulation in this field, we don't have very much. Some of the successful approaches actually are the so-called multi-domain interventions. I think Sandrine will talk to us a little bit more later in the afternoon. So I will just very briefly touch on this and show you, a few successful examples. There are other studies like the MAPT study here in France or the PREDIVA study in the Netherlands. But I will just show you just a few examples, and maybe Sandrine will expand a little bit more, because nutrition is one part of the exposome. So this is the very well-known, the finger study in Finland. You can see more or less 600 participants in the intervention and the control group. So the intervention here is nutrition, but not only nutrition, physical activity, control of vascular risk factors. These are the so-called multi-domain interventions. So it was a positive study. It showed, after 2 years, better cognitive performance in those people who were in the intervention versus the control group. But even a smaller study by the group of Christine Jaffe in California, the SMART study, you see the numbers. They also did a multi-domain intervention in cognitively normal people. Here is just to indicate that it was not only diet and not only vascular risk factors, not only physical activity, but also they targeted depression, they targeted sleep. And each participant was getting a different intervention depending on their needs. You see here the overlap of these different detrimental conditions for cognitive health. And again, this was a positive study. It showed an effect after 2 years, despite the small sample size. A more recent one is the Pointer study in the US. And here we have 1,000 participants in a structured multi-domain intervention and 1,000 participants in a self-guided, which serves as a control group. And again, it's people who are cognitively normal, but they are at risk for cognitive changes. They have suboptimal diet and sedentary lifestyle. and some other risk factors for dementia. And there's a target of many different lifestyle aspects: physical activity, nutrition, vascular risk factors, cognitive stimulation, and so forth. And again, this was a positive study after 2 years. The effect sizes in all these studies are not that great, but still it's cognitively normal people. So it's quite impressive to see this efficacy with behavioral interventions. And the last study I will show to you is this study from Australia. I really like this one because it was an online intervention that talks about feasibility and how we can scale up these interventions. And because it was online, there were advantages. So, for example, they were able to do it for 3 years. For 2 years was the intervention, and 3 years was a check whether there was efficacy effects. And you can see they targeted different aspects of lifestyle, nutrition, but also physical activity, cognitive activity, and depression. And they had different modules depending on whether you were impaired or you had problems in one of these lifestyle factors or more of them. Here you see really big numbers: 3,000 participants in one group, 3,000 participants in the other, because it was online, so the cost was more manageable. They were really able to change the behavior through these online interventions. What you can see on the top left is the change in their nutrition, and then changes in their physical activity. So they were really able to change the exposure, and it was a positive study. There was also an effect in cognitive function overall and in different domains. So I will just end with some future directions. Maybe I hope I will use less time, actually. So this is a paper by Cecilia a few years ago, talking about these issues. So clearly we go more towards personalized nutrition for dementia prevention, and nutrition not by itself, but within the whole exposome, taking into account genetics, other lifestyle factors, but also different neurobiological mechanisms that may be happening in different people. This is a big issue. So the NIH convened this workshop where we tried to advise on how can we better design interventional studies in this field. So it seemed from this working group, we came up with at least 2 approaches. Of course, they're not exclusive. One could think more of a personalized approach, so we could investigate with biomarkers, for example, what are the individual pathologies starting in people's brain, and we could target these pathologies using particular food groups or nutrients that have shown some effect, and then we could measure outcomes using biomarkers, so we would have small studies of shorter duration, but they can inform us much more about effects on a neurobiological level and mechanisms. But at the same time, we could have these large, simple trials that we see in cardiology, for example, where we could have thousands of people, and there the intervention has to be much simpler. It could be a pattern, or it could be a single nutrient, and then the outcome there could be even rougher. It could be even from electronic health records, for example. But then we could go to larger scale, and this could give us a lot of information on population health. So maybe we could use these 2 complementary approaches. And this is where actually the American Academy of Neurology is going. When we see people at our cognitive disorders clinic everywhere in the world, about a quarter or a third of these participants are people who are the so-called worried well. So people are really worried about their future cognitive health. So there's already a big demand for these preventive services. We do not need to create the demand. It's out there. And, the American Academy of Neurology has this Safest Brain initiative. And we have more and more development of the so-called brain health clinics in Europe and in the US. There's no clear, funding model for these clinics, but it's something that is in development. And there are also efforts for more clinical trials. You see the FINGER initiative from the Alzheimer's Association. So there are trials that have started happening in many different parts of the world using, individual elements of the FINGER trial, customized on the geographies and the different countries. So there's a worldwide effort to have more and more interventional information from these multi-domain approaches. So finishing up, it seems we need more personalized models. We need to have a deeper dive into the biomarkers, both the nutrition biomarkers, but also the cognition biomarkers. But we need to take into account the whole exposome and have also a more holistic approach. So maybe nutrition along other aspects of lifestyle. Definitely we need more trials to have higher confidence, but there are a lot of challenges in terms of cost and duration, and definitely we need, and we all try to go earlier to the preclinical stages given this latency between brain pathology and cognitive changes. And I will stop here. Thank you.
Thank you. That was fantastic. I'm not sure I'm completely interpreting your data, but it sounds like we actually know quite a bit about good nutrition and what people should eat. And I think, to me, the missing piece is, all these diseases are getting worse. Obesity is getting worse, particularly in the United States. So what are the implementation barriers that are preventing this from, coming to the general public to improve their health? Because there's clearly a block somewhere. I don't know where it is, but there's something where the information doesn't get to the people, or the people won't take it up for some reason.
Yeah, I mean, this is, I guess, we all know this is a whole science. How do you implement, and how do you change people's behavior? And it has to do with, there's a lot of literature from the psychological point of view, all these techniques, how do you make people convinced and what motivates people, but also there's all this literature on, environmental changes. I mean, when you go into a building, I don't know, you see the elevator or you see the stairs, and how do you walk, and how close are you in green spaces or into pollution space. So I think, I'm not sure we need to have an absolute, answer whether something is fully, we're absolutely convinced that, certain aspects of nutrition definitely help for this particular disease, because we have also a lot of observational data. And I think I feel pretty confident saying to people that most likely, not definitely, if you eat healthier, it will help you on the long run. And if not in terms of dementia, we know it will help for, other conditions, like for diabetes, or so it doesn't, it will be only a plus if you follow a healthier diet. Now, how do you convince them? I'm not sure I have a good answer for that, but it's all this effort from these different angles.
Yeah, great talk. So Americans seem to want simple messages around nutrition. And then you have people who deliver on this. There are some credible scientists that just say, remove fructose from your diet and you're going to be healthy. There are others that say it's the omega-6 fatty acids. That's why we're seeing such a massive increase in colorectal cancer. Others are, it's those artificial sweeteners. Get it out of the diet. So is there any credibility to these big offenders?
Yeah, I think one of the issues in nutrition science is that there have been a lot of changes over time, and that also has threatened the credibility. Once they asked Ansel Keys, he had changed his opinion about something, and they pointed that to him, and he said, when things change, I change, and you? So I think the same happens in science. We always, validate new things, and we invalidate previous hypotheses, but what happens with nutrition, it's very much out in the news. So maybe there are studies in, I don't know, mesothelioma that have been proven to be wrong, but it's not in New York Times. In nutrition, everything that comes out, because it affects, it's in the interest of many people, it's out there. So the differences in what we learn and understand, get a lot of publicity. And regarding what people recommend, I think another aspect is that people, are focused in their small, narrow area of research. And what they find there, sometimes they want to generalize. And, that applies actually to me. I'm talking to you about nutrition, but it's not the only important factor, right? So if you're a basic scientist and you're doing research on omega-3s, and you think that, that's the whole world. But I don't have any particular recommendation for this. That's how it is, and the more we understand and we learn and we inform public, the better we can digest and filter the information that is coming from the media or from scientists.
Maybe a little bit more implementation science, so we better understand. Social media likes simple messages, and unfortunately, nutrition is not such a simple thing.
Exactly.
This is Eric Timmy from the Swiss Public Health Institute. Thank you very much for sharing your insights with us. I would like to briefly touch on the later part of your presentation, where you suggest that we should investigate the beneficial parts of precision or personalized prevention through nutrition, where you gave the example on Alzheimer's disease. I do agree that there's certainly some degree of variation of needs between individuals with regards of nutritional uptake. However, I'm not quite convinced yet why we should have specific diet recommendations to prevent specific health outcomes. So maybe you could briefly explain why you think that we need a specific diet to prevent Alzheimer's, or a specific one to prevent strokes or myocardial infarctions. For me, I have the notion that a good diet would prevent most of these chronic diseases.
Yeah, if you look at it, it's a good point. If you look at it from a public health point of view, you can go even before different types of dementia. You can go to different health outcomes, because then we will start saying what's a good diet to prevent diabetes, and what's a good diet to prevent cancer, and what's a good diet to prevent dementia, and then we have to pick and choose. But, from an individual point of view, we are not all susceptible to the same biologies. So we know that, if we do a PET scan, or now the blood test, the p-tau217, in people who are 50 or 60 or 70, certain people will have already accumulation of amyloid in their brain. And certain other people are more vascular patients, right? So, they have strokes, they have heart attacks, they have peripheral vascular disease. So it could be that, if I am prone to develop neurodegenerative changes in my brain, I could benefit more or less from certain aspects of nutrition or the exposome. And if I'm prone to develop a lot of strokes, a lot of vascular dementia, a lot of blood vessel-related changes, I may benefit from different aspects. So, of course, it's very hard to give a very credible answer to that, but it's very conceivable, because these two are very, very different things. So that's the thinking behind that.
Thank you very much. That was very fascinating. I really like your future direction of taking a holistic approach in this. And I think especially you mentioned also nutrition or diet kind of relates to so many different aspects of life. For example, timing or regularity of sleep. And then also physical activity obviously also interacts with nutrition as well. So I wonder, do you know if there's any evidence sort of looking into the interaction of these different lifestyle factors and how that might influence cognition? Because I can see it can get really complicated in that. And also we recently found some evidence showing nutrition or diet actually impacts on your sleep, and then that can have downstream effects on cognition. So just curious to hear your thoughts.
Yeah, so very briefly, because I think we have taken much time between you and the coffee break. And all these lifestyle factors are correlated. They're certainly not collinear, but they're clearly correlated. Interaction, it's a very big literature, very mixed literature. I'm not sure about, additive or multiplicative interaction between different lifestyles. I think we're very far, we're beyond this level. Now, regarding the question about sleep, there's a lot of research on sleep and its importance in relation to dementia, but studies looking both at nutrition and sleep are really very few. We have a lot of neurobiological information about the effect of time of nutrition on the quality of our sleep, but looking at these two parameters in relation to dementia, I think we don't have a lot of information yet. Thanks.
So that's the end of the morning session. We're going to break for posters and for lunch, and please be back here at 1 p.m. sharp, Carla tells me.
No, I was here yesterday. Ah ouais, tu parles français?
Commence to get blurry. Ouais. J'habitais à Paris il y a 20 ans.
Ah d'accord, ok.
I think you'll be able to get in. Come and find me. Okay. I mean, I'm not going to watch the laptops, but it's if you. I think we have a pretty good group. Mine has been in here, so I'm leaving mine.
Non, j'étais là hier et je reste là demain et tout est très intéressant.
Thursday afternoon. Nicolas? Oui. Vous pouvez lui dire comment ce qu'il faut faire?
You're presenting next.
Bonjour, oui, je suis le suivant.
Ah, en français.
En français,
du coup, vous aurez le mot de présentateur ici, donc vous aurez vos notes, etc. Si jamais vous en avez besoin, ce sera en
cœur à découvert. Je n'ai rien à y gagner. Si je te perds.
Okay, thank you so much for your attention and for attending this symposium. This morning was fantastic with a large series of talks, and I hope you had a wonderful lunch and a nice poster session sharing some good science. So I'm excited to introduce Dr. Alexis Elbaz, who is the Director of Research at INSERM Center for Epidemiology and Population Health. And he'll be talking about challenges and opportunities in exposome studies of Parkinson's disease. So without further ado, Alexis.
Thank you very much, and welcome back. Thank you very much to the organizers of the meeting for inviting me to Bordeaux and this nice meeting. And we're going to switch a little bit topics and talk about Parkinson's disease. You will have two presentations this afternoon about another frequent neurological disorder. So as for dementia, the number of patients is increasing and was between over 30 years, the number of PD patients has multiplied by 3 and it's continued to increase. And as there are no major changes in incidence rates worldwide and in most places, this is mostly due to aging populations. But another factor that is less often mentioned is the fact that PD patients are also living longer with the disease. So not only there will be more patients in the future, but patients will also have longer disease duration and will be more complicated to treat because they will have complications. And so this really is going to introduce some pressure on the healthcare system. So we really need ways to try to prevent or at least delay the onset of Parkinson's disease, and this was mentioned this morning. So there's a genetic contribution to Parkinson's disease. There's a number of Mendelian genes, but these account for a small proportion of the patients, and the heritability of Parkinson's disease is rather low, except for very young patients, so patients who have a young onset of the disease, because the genes that are causing Parkinson's disease are usually associated with younger onset of the disease. There's one interesting finding I think that's relevant for what we're discussing here is that the two most frequent genes, LRRK2 and GBA, have a reduced penetrance, which means that there may be other factors, maybe genetic, but maybe also environmental, that modify the penetrance of the disease. And so this is a nice model of gene-environment interactions. But so in addition to genetic factors, there's a number of environmental factors that have already been identified in Parkinson's disease. Some of them increase the risk and some of them decrease the risk, and we will discuss some of these later. But before, I would like to discuss two methodological issues that I think are relevant for Parkinson's disease, but also for dementia and other neurodegenerative diseases. So the diagnosis of Parkinson's disease is mainly clinical. There's no real test that can be used in the clinical setting, at least until now. And despite the use of well-defined criteria, there's a risk of misdiagnosis. And in autopsy studies where there were patients with PD that were autopsied, the accuracy of the disease is about 80%. So you see that there's, even in very experienced centers, there's a risk of misdiagnosis with other causes of Parkinsonism, such as atypical Parkinsonism. And so that's in clinical settings, but in epidemiological studies that use healthcare databases, there are some studies that have tried to validate the way the patients are identified, and these are those two studies in the US. And you can see that compared to expert review of medical records, using ICD codes alone to identify PD patients is associated with a risk of misdiagnosis. And you can see, for example, that in the Mayo Clinic or in the VA databases, the positive predictive value of this algorithm was only 46%. So there's a risk of misdiagnosis. And we've done some analysis in the UK Biobank. We started working on the UK Biobank, and we found out that, in fact, the way they identify PD in the UK Biobank is based on hospital records and death certificates. And this is a problem because PD patients are not often hospitalized during the first years of the disease. They're mostly hospitalized when they have complications, they fall or become demented, have hallucinations. And so it means that in the UK Biobank, we identified in PD patients rather late in the disease, and also not all patients are hospitalized. So we defined, and so this is because they have primary care data including drug claims, but only for a proportion of the patients, in the participants in the UK Biobanks. Only 25% of the participants have primary care data, and only for a limited period of time. So they could not use these primary care data for the whole cohort. And so what we did is, for this proportion of the cohort, we used an algorithm that we've used in other studies to define PD. And then we looked at how many patients with this identified through this algorithm were identified through the UK Biobank algorithm, and we found out that, for example, that what you can see, only 78% of the patients were identified after 15 years of follow-up. But there was what I think is more important is that there's a delay between the diagnosis using drug claims and the hospitalization records, and you can see that 50% of the participants were diagnosed using hospital records after 4 years compared to the drug claims. And on the right, you can see that, in fact, using these different algorithms can induce difference in associations. So here we just looked at two common, one risk factor of Parkinson's disease, sex, and one prodromal symptom, gait speed. And you can see that the association changes depending on which algorithm you use. These are, of course, very strong associations, but it's probably more problematic for weaker associations. And you can see also that we looked at the mortality in PD patients identified in these two different ways. And you see that there's a very striking difference in the ones that are identified through hospitalizations, because they had a 9-fold increased risk of death, which is a lot higher than expected for Parkinson's disease, compared to 2. So it means that we're identifying patients with more severe Parkinson's disease, and that was our hypothesis. So I'm just showing this because I think it's important when we do epidemiological studies on Parkinson's disease to really look at how the patients were identified, because this can have very important consequences in terms of the validity of the findings. The second issue that I wanted to discuss is reverse causation, because this is really also a major issue in Parkinson's disease, and it's really something we're starting to understand better, because the natural history of the disease, we really have made a lot of progress in the past year. So we knew before, so Parkinson's disease is due to the degeneration of a small part of the brain that leads to some motor signs, and we knew from a long time that, in fact, the symptoms appear when about 50% of the dopaminergic neurons have disappeared. And so we see that, in fact, the loss of the dopaminergic neurons starts about 6-7 years before the diagnosis. And during this period, there's a higher frequency of some motor signs, such as tremor, balance problems, etc. But what is more recent is that, in fact, we see that for some patients, there's a very long prodromal phase characterized by the presence of non-motor symptoms, such as anxiety, constipation, REM sleep behavior disorder, which is a very particular kind of problem, anosmia. And these non-motor symptoms can be present 10, 15, 20 years even before the diagnosis of Parkinson's disease. So this has led to the hypothesis that there may be two forms of Parkinson's disease, and probably this is an oversimplification, but I think it's nice to frame a little bit the discussion. So there would be one brain-first subtype of Parkinson's disease that would be the more common, that starts in the amygdala or the olfactory bulb, and I think this is also important for the studies, exposomic studies, because it can have implications in terms of the route of exposure, how the neurotoxins can enter the brain. And these patients have a more benign disease course than the body-first subtype of Parkinson's disease, where the alpha-synuclein pathology, alpha-synuclein is the protein that aggregates in the brain in Parkinson's disease, originates in the gut and then spreads to the brain through the vagal nerve. And again, here, this can have implications for the route of exposure, because maybe it means that the route of exposure is through the digestive system. And this is important because in Parkinson's disease, there's something that is a little bit striking, is that when you look at the associations with risk factors, there are many inverse associations, so exposures that decrease the risk of Parkinson's disease, and less risk factors, so risk factors that increase the risk of Parkinson's disease. And so the question is whether this is true. Are these really causal associations and protective factors, or is it bias due to reverse causation? So what's reverse causation? This is the situation in which the outcome precedes the disease and affects exposure. And for example, in Parkinson's disease, it's possible that constipation may have an effect on diet many years before the diagnosis. It's possible that patients with RBD use sleep drugs, for example, or antidepressant. It's possible that dysautonomia may change the way people are prescribed drugs for blood pressure. It's possible that weight loss, and we'll discuss this in a moment, also affects diet, that subtle motor signs affect the way people do physical activity, for example, or the risk of head trauma. And there are studies showing that people in the years before Parkinson's disease have more frequent medical contacts because they're starting to get sick, and also that maybe they have more sick leaves. And this is important for studies that look at occupational exposures. So this means that if it's important to use a life course approach in order to be able to look at midlife exposures, and this is something that we've already mentioned, it's interesting to use to do studies where we have repeated assessments of exposures in order to do trajectories analysis, or to adjust for subclinical disease, or do lagged analysis, so where we include a lag between the exposure and the disease onset, or to use other methods to improve causal inference, such as, for example, some forms of instrumental variable analysis, such as Mendelian randomization, gene-environment interactions, or natural experiments. So I'm going to give just a few examples of reverse causation in Parkinson's disease. So on the left, you have the association between beta blockers and Parkinson's disease, and this is a typical example of reverse causation, because we've seen that patients in the few years before the diagnosis start having tremor, and beta blockers are used for tremor, in particular propranolol. So you see that the curves show that the frequency of prescriptions of beta blockers in, let's see if I can do this. Here. So you can see here that this is time 0 is the time of diagnosis, and you can see that the frequency of prescription of beta blockers goes up compared to controls in the years before Parkinson's disease. And so if you look at this period, then you're going to see that there's an association between using beta blockers and the risk of Parkinson's disease. But if you don't take into account this period, so if you include a lag, then you see there's no association with the use of Parkinson's disease. So this is typical reverse causation. And for statins, we see something a little bit different. We see that the prescriptions of statins are higher in controls than in cases many years before the diagnosis, but then 5 years before the diagnosis, the rate of prescriptions start to become similar in cases and controls, and this is because patients start to see more often doctors than controls in the years before diagnosis, so maybe probably motivating more prescriptions of statins for prevention. And so if you look at the association, taking into account this period, you won't see any association with statins and the risk of Parkinson's disease. But if you discard this period, then you see an inverse association. So an example of reverse causation. Body mass index is another example of reverse causation. There's a large literature because we know that PD patients lose weight when they become diseased. So the question is whether body mass index before the disease has an effect on the risk of Parkinson's disease. And what we saw in this study, this is in the E3N study, nearly 100,000 women followed for 30 years. So we identified here the patient using medical records that were validated, we used to validate the diagnosis. And we had repeated measures of BMI, and you can see that, in fact, the frequency of obesity was lower in cases compared to controls even 30 years before the diagnosis, so a protective effect of BMI on the risk of Parkinson's disease. But you can see that patients start to lose weight about 10 years before the diagnosis. A similar thing happens for physical activity. There's a large literature on whether physical activity is protective for the risk of Parkinson's disease. So we used repeated assessments of physical activity in the 3N cohort, and we saw that the cases had lower levels of physical activity throughout the 30 years of follow-up, but that the level of activity started to decrease in cases compared to controls in the 10 years before the diagnosis. So if you look at the physical activity level here, you would overestimate the association compared to if you look at the physical activity level in midlife. And this is something we quickly discussed this morning, but it's possible that because patients start to be more sick in the years before diagnosis, maybe this could affect the way they move. And so we looked at whether the trajectories of moving were similar in cases in controls over the follow-up. And we found out that, in fact, there was a slightly different pattern of moving between PD patients and controls in the years before diagnosis. So here are the cases, here are the controls. So at the end of the follow-up, if you look at the cumulative number of times a person moved, you can see that controls tend to move more than cases over the follow-up. And this is important because we use the residential addresses to attribute the exposures in many studies. So if there's a differential way cases and controls move, this could have an impact on the associations. So it's difficult to do a talk about Parkinson's disease without discussing smoking, because as you can see on the left slide, on the left side of the slide, there's an inverse association between smoking and Parkinson's disease that is really confirmed in all studies with a dose effect relation. And so this has triggered a lot of discussions because, of course, it's not very politically correct that smoking has a beneficial effect. And there's a number of biases that have been hypothesized to account for this. So survival bias, of course, because people who smoke tend to have a higher rate of mortality. But this is unlikely because we see this inverse association even for persons who develop very young onset Parkinson's disease, so before the rate of mortality becomes high. Genetic confounding is unlikely also because we see this in twins. So we see that in twins we confirm there's an inverse association between smoking and Parkinson's disease. It could be reverse causation, and it has been hypothesized that PD patients quit smoking more often than controls, but then it would need to happen very, very early in life because we see an inverse association between smoking even for persons who stopped smoking 30 years. And Mendelian randomization studies in which you use a gene associated with the likelihood of smoking confirm this inverse association between smoking and Parkinson's disease. Whereas the opposite, so whether the genetic predisposition to Parkinson's disease influence smoking, has not been confirmed. And these Mendelian randomization studies are less likely to be influenced by confounding or reverse causation. Gene-environment interactions may be another way to approach this question, and for a number of reasons, we examined the interaction between smoking and the HLA-DRB1 gene, and we found out that the inverse association was present only in persons who didn't carry a variant for this gene, and this was replicated in 2 studies. So for the potential mechanisms that explain this inverse association, this smoking by HLA interaction suggests that maybe it could be some mechanisms involving the immune response. Smoking has been shown to inhibit the alpha-synuclein aggregation. There's an effect of smoking on the microbiome, so that could be a possibility, and also an upregulation of cytochrome enzymes. About the components of smoking that could explain this association, this is really not clear at all, and there's a number of hypotheses, but really not final proof of which component of smoke could explain this association. Regarding pesticides and Parkinson's disease that have been mentioned several times until now, this is also one of the very robust associations that we see in Parkinson's disease, and the meta-analysis of occupational exposure, so people who have the strongest exposure, showed a 50% increased risk of Parkinson's disease in persons with occupational exposure. In France, we confirm a higher frequency of PD in farmers compared to the general population, and we found that farmers' men, because they are the ones who spray the pesticides, had a higher risk of Parkinson's disease, especially if they use insecticides and organochlorines. And I think that this is a nice example of implementation science that was discussed several times, is that due to these findings, PD has been recognized as an occupational disease in France among farmers, so they get a pension when they can demonstrate that they have been using pesticides for at least 10 years. Of course, the difficult part here is try to identify specific pesticides, and there are a number of studies in addition to organochlorines that have pointed to certain pesticides such as paraquat, rotenone, or dithiocarbomates. And there's toxicological evidence linking these pesticides to the mechanisms that are involved in Parkinson's disease, such as oxidative stress, aggregation of alpha-synuclein, but also DNA methylation or changes in microbiota. But of course, the number of patients attributed to occupational pesticide exposure is small, and the question is really whether residential exposure has an effect, because of course it would affect more people. And this can be done in California, where they have a pesticide reporting system that by law is able to record the exposure to pesticides, and they found out that persons who lived close to fields that have been sprayed with pesticides in a 500 buffer had an increased risk of Parkinson's disease. So that was a first study where they used that candidate pesticides, and then in subsequent studies they looked at a whole lot of pesticides, and I think this, so here for example they tested over 280 pesticides, some of which were very correlated, and they identified associations for 68 pesticides. But of course this really reminds of what Remis Lama was talking yesterday about looking at a whole range of exposures. In France, so we don't have this pesticide reporting system, so we did an ecological study where we used data from the agricultural census that describes the regions in terms of the kind of crops they use. And we did some clustering analysis to define regions with similar kind of agriculture. And then we looked at the frequency of incidence of Parkinson's disease in these regions. And what we found is that first, the incidence of Parkinson's disease increased with the density of agricultural land, so the proportion of the land attributed to agriculture. And then we really saw a cluster that stood out compared to the other clusters. And this is a cluster where with a very high proportion of vineyards. And vineyards in France is really a type of agriculture that involves a lot of spraying of insecticides and fungicides. And then we're continuing to do this analysis. So we don't have information of the specific pesticides that are used for these crops, but we have crop by pesticide matrices, so that historically attribute of probability of treatment with pesticides to each crop. And we have this for four kind of crops. So we can then map the frequency of use of these pesticides to the specific regions of France. And if someone wants to use these indicators of use of pesticides in France, these are available in this website, where we have included all the indicators for many pesticides in France over many years, over 30 years. And then what we're confronted with the problem that, of course, pesticides are used in combination, and we had a lot of mixtures of pesticides. So we tried to do some mixture analysis using this method, SNMU, that is able to define mixtures of pesticides. We've identified 22 mixtures of pesticides, and then we mapped these mixtures of pesticides, and then we looked which ones were associated with the risk of Parkinson's disease, and we highlighted one specific mixture of pesticides, and then we're continuing to do this analysis to understand better which are the pesticides involved in this mixture. Now, a final, two final slides on trichloroethylene that was mentioned this morning. So there was some interest in exposure to trichloroethylene due to a case report in 2008 of a small company in which all the employees were exposed to trichloroethylene, and several of them developed Parkinson's disease or subtle Parkinsonian signs. Trichloroethylene has been shown to induce the generation of dopaminergic neurons and alpha-synuclein degradation. And then there was a small study of 99 pairs of twins in which there was occupational exposure to trichloroethylene that was assessed and associated with a higher risk of Parkinson's disease. So regarding environmental exposure, this is a toxicant that is really very ubiquitous. There's been, for example, these two recent studies. So one of them on the right was already presented to you this morning. And so on the left, this is an interesting study because it's sort of natural experiment where in the US there was a camp of Marines where there was the identification of very high levels of contamination of water by TCE over a long period of time between 1953 and 1987. And so the Marines that were in these bases were very highly exposed to TCE. So they identified persons who lived for at least 3 months between 1975 and 1985. And the important thing is that persons were very young where they were living in these bases. So they were on average 20 years, and they lived for about 2 years. And they ascertained PD many years later. So the exposure occurred at a really young age. And then they looked at the risk of Parkinson's disease many years later. And they found, compared to another base of Marines, so this is really what's interesting in the study, that they were able to use a very nice control group that was very similar. They found a higher frequency of Parkinson's disease in the base that was contaminated with TCE. So to summarize, so the first point I wanted to highlight is that there's many databases that are now available to do PD research, such as the UK Biobank, which is a wonderful resource. But I wanted to really highlight that the fact we need to do some validation studies on the diagnosis to understand better what's the validity of the diagnosis in these databases, and if possible, to do some bias analysis. The second point is that PD has a long prodromal phase, which raises the issue of reverse causation. And it's important, for example, if reverse causation affects sick leaves, for example, for occupational exposures or the way people move. It also can affect the levels of persistent pollutants, because if they're affected by weight loss, and so we need to account for this, or do studies where pollutants are measured very early on, many years before the diagnosis occurs, and I think Roel is going to talk about that. The fact that there's this long prodromal phase also offers a nice opportunity, because now we can identify persons with prodromal PD, and there's a biomarker now, and so we could, in fact, do studies to understand which are the persons who develop PD from this prodromal PD, and it also highlights the fact that really we need to focus more on early exposures. I think PD is a nice model also for gene interaction analysis, for example, in particular for the reduced penetrance of LRRK2 and GBA. And regarding pesticides, I think that there are still few studies looking at environmental exposure, so additional studies on environmental exposures are needed. And for this, we need better exposure data, similar to the ones that are in California. And I think this is more for decision makers, but we really need to obtain better harmonized pesticide data, and that would be very nice at European level to be able to do to obtain this sort of data. And the second thing I think is very important is that pesticides change a lot. And so the pesticides that we are identifying now were pesticides that were used in the past, and most of them are banned. And so we need also better neurotoxicity tests as part of the regulatory approval of pesticides, because this will be for future generations. Thank you very much.
Hello, hello. Okay, this one's okay. Sorry about that. Merci.
Thank you very much for the really nice talk. I was just wondering for the pharmaceuticals if you have any data on psychotrops, like for instance antipsychotics, like neuroleptic that have direct action on the dopamine, or even methylphenidate that can have potentially protective effects. That's the first question. And I can really see the rationale behind the reverse causation with pharmaceuticals. For pollutants, except the weight loss, do you have any other explanations that could help to explain this reverse causation?
So for the second question, the fact is that many of these persistent pollutants are stored in adipose tissue. So then people lose weight, then they're going to go in the blood. And so the adipose stocks reduce. And maybe this means that if you measure the pesticide, maybe you won't find them anymore because they've already been released in the blood and you're arriving too late, or maybe the level that you will measure will be too high. So I think it really is going to introduce some measurement error on the exposure. For the first question, so neuroleptics is really a cause of drug-induced Parkinsonism. So in the studies that we do, we always exclude persons who took neuroleptics before the diagnosis in order to be able to rule out drug-induced. There are other drugs, in fact, that could really also be involved, and we've been doing a lot of these studies on drugs, but maybe it's too... Thank you. I think there's a...
Just is this working? Yeah. So a comment and a question. So comment, so even though some pesticides have been banned, it doesn't mean that they're not being used for maybe other purposes, rotenone being an example of that. Still used for, say, clearing out lakes, getting rid of fish species if you're actually interested in a lake.
Or in other countries, because many of these pesticides that are banned in Europe are available in Africa, for example.
Yeah, so the risk can still be there. Actually, the question I had was, what about DBS? And if is it possible that stratifying a patient population by gene, by environment, may help to identify individuals who are more likely to respond to DBS?
So regarding the environment, I don't think there's any study that has looked at whether there's a difference in response to DBS or not. There's a lot of studies, of course, on DBS in patients with LARC2 or GBA, and it seems to be, in particular for LARC2, it's not a contraindication to DBS.
Really great presentation. I was struck by the reverse causality, which is always a problem in a lot of these models. But you have a REM behavior disorder for Parkinson's disease, and maybe not at scale because the diagnosis itself sometimes lags behind. But have you looked at that? So use of these drugs in individuals with RBD?
So RBD is not specific of Parkinson's disease. In fact, other diseases, for example, patients with MSA or dementia with Lewy bodies, in fact, can also have RBD before. So it's not really specific of Parkinson's disease. But I think that, yes, there's really a lot of interest at the present time to study patients with RBD and to follow them longitudinally to see what's, in fact, the natural history of when they're going to develop Parkinson's disease. And in fact, that even is not that clear. And it's even more important now because we have, in fact, abnormal alpha-synuclein can be measured in the blood, in the CSF or in the skin. And so there's a lot of interest really in looking at how persons with positive alpha-synuclein are going to evolve. And it's really a very active field of research.
Thank you very much, Alexis. That was fantastic. Up next is Dr. Sandrine Andreu, is a professor and chair of the Department of Clinical Epidemiology and Public Health at Toulouse University Hospital and affiliated with the INSERM Center for Epidemiology and Research in Population Health. And she'll be talking about multi-domain approaches to prevent cognitive decline. Thank you.
Hello, good afternoon, everyone. So it's my pleasure to be here in Bordeaux. I didn't know that Bordeaux was a tropical city, so now it's done. So we are talking about clinical trials in prevention of Alzheimer's disease. And I have to give my disclosure and to say that I was involved in large clinical trials, so I'm a little bit biased and favorable to the multi-domain preventive trial. So what we have learned so far in the field of prevention of Alzheimer's disease and dementia. So we did a few years ago a summary of all the published large or not large preventive trials that have a good methodology. And the surprise was to see that most of the trials were negative. We have a huge amount of paper that find, with good methods, some negative study, and less than 20% of these clinical trials, preventive trials, were positive in the field. And among this small amount of paper that was positive, we have one multi-domain intervention that was just published at that time. It was a finger trial that we will see in details. So why do we have all this negative trial, and why is it so difficult to demonstrate an effect? And we will see that during the presentation. So for most of the people, when a trial is negative, the conclusion is that this intervention have no effect. This is a regular comment that we have. We missed the point. But in fact, there is two other explanations. Another explanation is maybe there is no effect in that particular trial because we decide the dosage, we decide the critical window of exposure, we decide the duration of the intervention, and maybe is not the good way. We didn't choose the good way. Another point is that maybe there is an effect within the trial, but the methods that we use are not optimal to detect a small effect, because we need to remember that we are in prevention, so everybody is normal, nobody have the disease, and so the efficacy that we can expect could be very small. So we decide to move to the multi-domain prevention trial for different reasons. This is a surprise, this nice picture. You know that since yesterday, or even before, that there is an amount of protective factors against Alzheimer's disease. And I'm completely in line with the comment of Cecilia yesterday, who said that, of course, there is these 14 modifiable factors, but we have more and more evidence for other factors. And I think about nutrition, I think about sleep, and maybe more. So it's at the minimum these 14 factors that we can analyze in trial. Another thing from EPI study was a paper from Nick years ago that found a synergistic effect of two protective factors like physical activity and diet for people who, in New York who have a good diet and good physical activity. It was much, they are less likely to develop Alzheimer's disease in comparison to the people who have got only one of these protective factors. So we will see here a sort of summary of the multi-domain preventive trial. So by doing that, we choose a randomized control trial that testing a multi-domain intervention, which is a combination of lifestyle-based approach and sometimes a dietary supplementation for the prevention of AD, incidence of dementia, or maybe cognitive decline, on even more on biomarkers that is a sign of the disease. And we select only the paper that exclude at baseline the demented people. It seems very frequent to do that, but some of the paper did not do that. So as it is a preventive trial, we select only this paper. And we select also the paper who have got an a priori sample size calculation based on the cognitive outcome. And for this particular presentation, I focus on a large-scale trial to avoid to have too many. So now we have 29 trials in the multi-domain area. 26,000 people were included in total in this multi-domain intervention trial. And we can separate this trial in two phases. The first phase were from scratch. In fact, we start all I think, at the same time to recruit the participants. So we were three teams start exactly at the same time in 2008 in order to recruit the population. And after that, we have some people who include the recruited population in 2009, 2011. What was remarkable at that time is that we didn't have any publication in the field of multi-domain intervention to guide our trial. So when we are doing a trial, it's always good to have good data in order to base our hypothesis. So in order to base our hypothesis, we did that from the epidemiological study, and we know that the population, including trials, are different. So we will not go within the details of all these 29. I focus my talk on few of them. So for each line, you have a green line when the primary outcome is positive. So I will start with the lead trial because it was published very early into 2015. And what was interesting in that trial, I think it was the first personalized preventive trial because she asked a health worker to define specific goals with the population in order to prevent cognitive decline. And with a very simple test of the MMSE, she found a positive effect of this intervention. It was a multi-domain intervention, very classic, combining cognitive activity, physical activity, nutrition, alcohol reduction, tobacco cessation. That's what they ask. And what was interesting in that population is that she had 5 arms. The only thing that differed between arms was the intensity of the intervention. And in fact, the more intense intervention arm was the more effective. And within that arms, she had something that is not so frequent. She gives some reward for the people who were adherent to the intervention, something maybe to keep. So after that arrived the finger trial. The finger is really the landmark of the multi-domain intervention trial. It was published in 2015. So she included 1,200 subjects, followed for 2 years. And the people who were included in that trial came from a cohort. So they recruit only people who have a high risk to develop AD based on the CADE index. And if you don't know the CADE index, you have this, and you can just calculate your score. I did that yesterday night. I think, oh, wow, now it's changing, so I stopped to calculate it. So, but the results was positive for this particular trial. So just to give you an idea about the complexity of this type of trial, so you have a combination of group session, individual session, on nutrition, on physical activity, cognition. They have to have the visit of the nurse every 3 months during 2 years. So it's a very demanding trial. And what was interesting in the type of intervention is that in the finger trial, they start with a low level of physical activity, and during the trial, they increase more and more the intensity of the physical activity. But usually, the trial starts hard, and then they have a decrease phase and the maintenance phase, like a step-down approach. And this is, I think, interesting in that study, this difference. Another study was interesting, published in the JAMA by Rovner in 2018, because they focus on people that need maybe some intervention, and in that population, maybe the intervention could be could have a huge benefit, and so is what they find in the Black individual who have already amnestic MCI, and so they have a positive trend in that store. And there is also few more that were positive, but nothing new. Then arrived a very bad period for us. All the trials were negative, even big one, even well-designed one. We have this dark, I would say dark phase. So in this presentation, the green bubbles are the positive trial and the gray bubbles are the negative trial, and the size of the bubble is dependent on the number of subjects included. So we were close to the people that designed the Prediva study in Netherlands, which was a an intervention, multi-domain intervention based with a nurse approach that see very frequently the person. They have more than 3,000 people follow for 6 years, but the outcome was a dementia incidence, and they miss the point to demonstrate that. After that, we have this list of negative trial. And then arrive since 2024, so since 2 years, we have a nice paper, nice positive intervention that I want to focus. So this morning, Nick discussed about a SMART trial that was designed by Christine Yaffe. This trial is important because it's a personalized intervention. The health coach go to the person to visit and define some goals, and they include people who are at risk to develop AD, and they found positive results on the cognitive outcome, but also on the composite risk factor score, which could be a surrogate or something near the cognition. And then we were part of the ProDemo study because, as you see for finger, these trials are very complex, and we wanted something very light. So with the ProDemo study, we moved the intervention with a smartphone. So there was a coach in behind that gave information, but all was done with a smartphone to decrease the burden of the study. And 1,400 people were followed for 1.5 years, and we got a positive signs on the dementia risk score with a CADE score. Almost at the same time, there was another study in Germany who did already the same, but the result was negative. They chose another dementia risk score, the Libra score. So it's difficult to do a synthesis because the number of subjects are quite the same, the design are quite the same, except the modality to deliver the intervention. And then we have the US pointer. So usually in this kind of trial, we can have a placebo group, no contact group as a control group, or we can have an active group. In US pointer, there is no control group. She just compared, is the paper from Laura Baker. She compared 2 types of intensity of the same intervention. A very intense intervention in comparison to the self-guided intervention that could be very useful and very easy to implement in the general population. So she included people with a high level of risk, and after 2 years, in 2,000 people, she found some positive effect on cognition. And then arrived the Maintain Your Brain study, which is completely online. All is online. The intervention is online. The assessment on cognition is online. So Henry Brodati in Australia include 6,000 people followed for 3 years, and he found a positive effect on the cognitive score. At the same time, the Apple Tree do the same online trial with a very low intensity of the trial in order to be easy after that to disseminate in the population, but they miss the point of the primary endpoint. After that, we have some positive and negative. So what we can say about all these trials? So if we are looking at the type of intervention that trialists use, they use physical activity. Almost all the paper have a specific group or individual action on physical activity. Then after, the cognitive activity arrive just after, and nutritional counsel. And in the less important range, we have the management of cardiovascular risk factors and social activity. And for few of them, we have smoking cessation, alcohol reduction, sleep management, chronic disease management, and even depression management. So if you remember the nice figure of Jill Livingston, now all these trial finally go through these risk factors, but now if we are doing just a summary, we have half positive and half negative, so it's difficult to do a real simple summary. So what are the challenges by doing that, and why we have positive and negative study? One of the challenges is to recruit the population that could benefit from the intervention. We need to avoid the super healthy participant that just want to be part of the preventive trial. When we designed the MAPT trial, near half of the population have got the high school diploma in France. At the same time, in the general population, only 17% of the people have got this diploma. So we have a huge selection of the population. So at that time, before this trial, because before we have another negative trial, but we say we need to understand why people accept to take part to preventive trial and why people refuse to take part to the preventive trial. And so we got the funding from the IRESP in order to analyze the determinants of the participation of the people when we ask them to enter, at the time when we ask them to enter in the preventive trial. And we use quantitative and qualitative approach. So we were lucky because usually the ethical committee don't like that we go to see the population who refuse to take part to the trial in order to understand why. But because it was maybe the main aim of our trial, our study, they accept that. So we have more than 50% of the people who refuse to take part of the large preventive trial that accept to be followed by our survey and accept to be even interviewed by a sociologist and a psychologist. So what is the main results of that study? Of course, we observed expected determinants of participation. The people with a high level of education participate more. The people who perceive the high level of risk to develop Alzheimer's disease was more likely to participate. But we have also some surprise. The main reason to refuse, the people say, I have no time, your trial is too demanding, there is a lot of burden, I have no time, no way to come 3 times a week for 1 month, 2 times a week for another month, it's just completely impossible for me. But when the sociologists go to see them in an interview during 1 or 2 hours, they got 2 information. The first one is that the concept of prevention was not completely understood by the elderly people. They say, I have nothing. My first baseline analysis is normal. Why I need to do something? Because I'm not sick. The second point is the credibility of the intervention on cognition. They didn't trust the link between nutrition and cognition, between physical activity and nutrition. So we need to better explain in general message and mass media message about that. And the third point was the fact that, at least in France, the representation of the disease in the media is a catastrophe. So in fact, the people say, I have nothing to do, Alzheimer's disease is a terrible disease, I have nothing to do. The second challenge is the amount of intervention. When we are doing a clinical trial with a drug, before we are naive to the drug. When we are doing a multi-domain intervention, we are not naive of diet, we are not naive of physical activity, so we need to take that into account, and it's not very easy with the tools that we have. We need also to pay attention about the adherence during the study period, but also the maintenance of the behavior change after the end of the trial, because sometimes we have a lag effect, so it takes a long time to observe an effect on cognition. What about this adherence? We were able to mix our data with a finger trial, and we saw that the adherence decreased dramatically with the complexity of the intervention and with the intensity of the intervention. And for example, in finger, it was very easy for the population to accept the visit of the nurse at home and to have this assessment of cardiovascular risk factors, but at the same time, less than 30% accept the cognitive intervention. In MAPT, it seemed that the adherence was okay, but if we are looking the very end period of the trial, only 17% of the population in the intervention group continue to do what they are supposed to do. So after 3 years, it's almost impossible to maintain the behavior change that we can expect at the beginning of the trial. And this also was found in the live trial, the publication of Marco Power, that found that when you ask people to change their habits in the field of physical activity, it's okay for the 6 first months, okay for 1 year, okay for 2 years, but at 3 years, all decrease. And at the same time, the control group start to increase a little bit their physical activity, so you can find nothing. So just to say that when we are doing a clinical trial, we don't expect to replicate what's happened in the real life according to the life course epidemiology. We know that when we are doing a trial, we are doing something at one point, which sometimes is not a good point, with a single exposure, with a non-cumulative effect. We are just unable to assess that. We have just one specific window of exposure. It's not maybe the good one. So this morning, somebody said, we don't need trial. I think we need trials. I think we need trial because until now it's the best level of evidence. And really, I think if we want to change the habits of the population, we need to convince them with some data. We need to assess also the effect size, the benefit that we can observe, and at the population level, we need to assess the cost effectiveness of what we are doing. So to conclude, I will speak about the perspective of the future trial. And like it was done yesterday and said, I think we need larger and larger trial and long-term trial because we are addressing a population elderly. I think elderly is more than 50. So we need to address the complexity of this population because they have lots of comorbidity. It is not the way to say, oh, they have lots of comorbidity, it's too complicated. I say that because when we ask for funding, sometimes people say aging is too complex. So no way you can go to another way to obtain the funding. We need to adjust the aim of the trial because all these trials that I present say that it's prevention of multi-domain prevention, but it could be very different if you want to enhance cognitive reserve in very normal population, if you want to maintain brain health in the population who start to decline, or if you want just to prevent AD in people who are really at risk. Another point is to better target the population in the future because the participants included in all that trial were selected based on the calendar age and selected on the normal cognitive function that was evaluated at baseline. And in fact, we know that already 30% of this population have already amyloid in the brain. So maybe in the near future, the blood biomarkers will change the field because it will be easy to implement that in the large sample in this kind of trial. Maybe the biological age will help us a lot, also more than just the calendar age, which means nothing for me. To conclude, I will say that we still need some kind of good surrogate because we need long-term study. We can't do trial for 20 years, so we need to have very good surrogate like it was done in the field of cardiovascular. And they succeed, but the large trial were quite recent, I think. There is a very good trials recent. So if we need to, if we succeed, the problem will still big because we will need to implement what we observed in trial in the general population. And this, I think, is more than science. We need to have the politicians with them. And in some countries, it's very difficult. So this is my last slide. Yesterday, we spoke about the funding. 5 years is not enough. 10 years is maybe not enough because between the time when we think about a clinical trial and the time when you can publish, even if it is negative, it takes longer time. So you spend 15 years of your life. Thank you.
Thank you, Sandrine. It was super important to emphasize the importance of the trials in that field, which is so complex. I have 2 questions for you. I would be interested to get your experience on the building of those trials and explain us how you choose the risk factors on which you want to intervene with these multi-domain trials, because it seems that there is a lot of heterogeneity across trials. And for people like me who are not in the trial field, it looks like a little bit people are doing a bet on a combination, probably based on very logical, based on what they see in the clinics. But I'm wondering if we could maybe make more intelligent use of observational data to simulate the optimal combinations for future trials, and maybe also figure out on how to incorporate global exposures which do not rely only on individual choices and behaviors, but how can we foresee to integrate, for instance, air pollution, exposures, and things like that? So very complex question, but what is in practice? How do people think about this when they build the trials?
Yeah, in practice, it's very pragmatic. So in fact, when we are doing a large trial, we know that we have an amount of money. We know that we have the sample size is calculated in advance in order to be effective. And after that, we need to see the more you have some risk factors, the more you are likely to see an event during the period of the trial. But the more you have some, I will say, early signs of something, maybe it's too late. So it's always a combination about that. When we did the GIDASH trial years ago, we decided to include the population who go to see their GP because they have subjective memory complaint. And we say, if something works, in this population, that will be finally the population that we could benefit from something. Well, we tested at that time antioxidants. But in fact, by doing that, it was very pragmatic. Now, I think I will just go through the risk factors for Alzheimer's disease, but not already subjective memory complaint, not already amnestic MCI. For me, it's maybe a little bit late to do that. For the second question, is very challenging. And in fact, the reason why I speak about biological age is because if in our trial we have biobanks that we can follow every year, we can have biomarkers of many things, but it's difficult sometimes to have the big range of the exposition because the number of sites are limited. And it's voluntary to be limited because if not, you increase, I will say, the heterogeneous measurement of cognition. So we wanted the quality of the clinical trial in this preventive trial. So we reduce the number of sites, but by doing that, we reduce the range of exposition in many things. But I think there is something more to do that we were doing until now. Yeah.
Can I? I've got the microphone, so I'm going to. Sandrine. Thanks a lot for your presentation. I have two questions. One is, I'm not sure I fully agree with you that when you say that you need to convince the politician, the politician or whatever, the deciders. Because if you think about the pointer trial, it's not sustainable to be applied to the whole population. So isn't it the other way around that the trial should be thought in advance with the decision maker to make sure that it's implementable at a large scale? Otherwise, we are pleased between researchers, but I'm not sure it's going to be implementable, and it's a big problem. And the other question is, there are some criticisms about pointer, saying that it's rather a practice effect or whatever. So what do you think of that?
Yeah. So for the first question about the fact that we need to have politicians with us, I think that at least in France, maybe in US also, we need to give science for politicians in order to give us the best data in order to take clear decisions. And I think that we are in our own world, just scientists doing good papers, and everybody in the room knows the paper of the other one, but except that room, it's difficult to go out of this world. And I say that because, of course, in pointer, it was maybe not sustainable, but in fact, she gave money. She gave money to the people who were adherent, and also she reimbursed the fact that the people go to eat some fresh fruit and vegetable. It was blueberries, but anyway, something that we need to think if it is, the politicians can decide that it will be easy, cheap to buy healthy diet than to buy bad diet. until now, if I'm going everywhere, it's very easy to buy junk diet, but very difficult to find good one. And if I find good one, it's very expensive. So I think this is is something that is politics. It's not scientific. Everybody knows that. Everybody knows that healthy diet is better than the junk diet. But the people who eat not so well, sometimes they have just no choice. That's the first question. And the second one, because now I have my CADE score who is increasing.
It was about the practice effect.
Yes, but yes, I did a comment about this paper about the practice effect. I think yes, but it's happened to many of these type of trial. Yeah.
Hello? Okay. I agree with you about the necessity of surrogates, but I agree more with the sentiment that came from the previous question asker. So if we assume that we can trust just the positive results and disregard the null, if we assume that the small effects that we see are truly meaningful to people, if we assume that all that we're throwing at people, do more physical exercise, eat better, do this and that, change your entire life, is sustainable, is it really the right solution to do more trials with a longer time frame if we might just end up with 2 intervention groups that are pretty much the same and a huge percentage that have just been lost to attrition?
Yeah, I think yes, because what I saw when we are analyzing deeply all these trials, there is a huge variability of the population, of the duration. Some of the trials are 3 months of intervention, some are 6 years. There is nothing to compare, in fact. So if we have one day a big trial that helps us to analyze subgroup and maybe to decide one one outcome that have value for everybody, it will be okay. The clinical value of the change in 1 point or 2 points on a cognitive scale, I agree with you, is something very difficult to admit from the population. They don't have to expect something that is visible, in fact. When we are doing prevention, it's like when you brush your teeth every morning, you can see nothing, but you do that. And I think the solution is maybe to learn to the young people to have more healthy diet, healthy way to do physical activity, to avoid us. Because why we are doing clinical trials? Because some people at one point have not chosen or not, they don't have the good physical activity level and they don't have the good diet. So our aim is to see, is it possible to change the outcome in that population if we change the habits, or if it is too late, if it's not enough, etc., etc. So I think it's important to demonstrate that. And maybe for another point, I would say that I'm not somebody who is fond of physical activity. My father will kill me. He was a rugbyman, professional. But I need to have proven data that maybe will change something for my life if I have to do physical activity.
Merci beaucoup, Sandrine. So up next, I would like to thank Roel for coming from his sabbatical, especially for this meeting. Dr. Roel Vermeulen is a professor of environmental epidemiology and exposome science at Utrecht University and the University Medical Center at Utrecht in the Netherlands. And he'll be speaking about the fields of risk, mapping the exposome landscape of Parkinson's disease. So without further ado.
Thank you very much, and I would like to thank the organizers as well for the invitations. Indeed, I was in the mountains of Corsica, but happy to actually come down the mountain to be with you here today. I'm going to talk about Parkinson's disease, and Alexis already gave a very good introduction to the topic of Parkinson's disease. And I think if we look at Parkinson's disease, we basically have this picture of the 1990s, 2021, where we know that we have about 12 million people with Parkinson's disease globally, and the projection is basically in 2050 that that will go to 25 million people. The reason that that is happening, and Alexis was really right to point that out, is that when we look at Parkinson's disease, it is either the increasing incidence that is causing that. It's either basically because we have more people living longer with Parkinson's disease and therefore we have more patients in the populations. And the only way that that would decrease is either we find a cure for Parkinson's disease that would actually reduce the number of Parkinson's patients that we have, or actually try to curtail the incidence of Parkinson's. Now, there is a debate in the Parkinson's field about what this incidence is actually doing globally. And I think Alexis was right that if we look at the literature for Europe, that I think the incidence is indeed not increasing and that it's either stable. I think that's the current kind of status that we know. What I show you here is actually an analysis that we recently did in the Netherlands by actually combining different data resources. And Alexis already pointed out that only doing this on ICD codes is not enough. Doing it on mortality is not enough. Doing it on the insurance data is not good enough. Of doing it on medication data. And what we did here is basically combine all those 4 data sources together to actually build trajectories to understand how medication actually leads to later occurrences within the insurance system or within the hospital system, or eventually death. And that's how we actually reconstructed the incidence of the Netherlands. And that basically leads to the observation that we have about 3,750 kind of patients per year newly occurring in the Netherlands. And that has, of course, a huge effect not only on the patients, but Parkinson's disease, because of its debilitating effects, also has a huge influence on the families that are confronted with their family members having Parkinson's disease. So this is actually a painting that one of the Parkinson patients actually made, and so this is basically what patients currently have, right? I mean, if there is no cure, then the only way that we can actually hope for now is that we actually find the causes that actually drive Parkinson's disease and come up with primary prevention programs that would work. So the question that we can then ask is basically, okay, what do we now know about Parkinson's disease? What are basically our current level of knowledge? And that's basically shown in this paper. This is a commissioned paper by Nature Reviews Neurology, trying to summarize the current status. This is done by Susan Peters, an associate professor in our program. And if you look at the left side, which is basically where we have strong evidence, and that is what you have seen today recurringly coming back from Alexis, but also from Brad, that we do have good evidence basically for pesticides. But there are things that we actually have to note when we talk about pesticides. That evidence base is mostly based on the fact that it is from occupational exposures and actually developing Parkinson's disease. And the open question there is, well, what does it mean for us here? What is basically the risk of basically pesticide residuals in nutrition? What does it mean of living next to fields where pesticides are applied? And that's really where the results of Alexis speak to. That's also where the results of Beata Ritz speak to, that we start to observe that perhaps this is not only an occupational risk factor, but that it also occurs in the general population. And that is important to actually start to get our minds around. The other aspect there is that we talk about pesticides, but pesticides is not one exposure. It's just a multitude of active ingredients that have been used over time on different crops. So it's too easy to say pesticides, and it's also not a really good actionable information that we have, because what are we going to do? We're not going to ban all pesticides. We want to ban basically specific pesticides that actually might be harmful for human health. And there the evidence becomes much more difficult, because there we know that paraquat, basically the evidence is getting very, very strong of the current use pesticides, but for many others that evidence is much weaker. Air pollution, we have strong evidence when we think about PM2.5. It's strong for NO2, but again, there are other air pollutants where that evidence is much less strong. But unfortunately, we shift basically to the second column and the third column, where we have to say, yeah, there's limited evidence when we think about solvents. We have seen trichloroethylene. There is basically also some evidence on PERC. There is some new evidence on formaldehyde. but that is not strong enough yet to actually act on. There's some interesting stuff that we have done on traffic noise, where we see some associations. We don't know exactly what that means. There's something on ionizing radiation, and there's something on certain metals when we think about lead and manganese, where there is some evidence base. And then we have basically where we actually have very limited and no evidence. So when I go back to the painting of our patient, we don't have many solutions yet to actually prevent basically the next occurrence of Parkinson's. And this is really why I came down the mountain to really discuss here today, how can we actually work together to make a difference? That difference we try to do in my program by trying to triangulate different levels of evidence. And we have seen actually these different levels of evidence coming by today. On one hand, that is really using the administrative data. So what Brad basically showed, basically using the census data in the US, trying to understand what is the geographical variance of that disease is one level where we can do that. And we have these resources now to do these studies where the exposome dimension is basically looking at different environmental exposures that we can link on the specific geocoordinates to understand basically what those associations are. So that is what we can do there. But of course, we don't have very deep phenotyping, and we have some issues about the clinical diagnosis if they are accurate enough. We then move basically to the cohort studies, where we now have good large cohort studies. I'm myself a PI of EPIC, which is a biobank of 500,000 people in Europe, where we started in the early 1990s, biobank the plasma and cells from people and following them up basically for disease. And I will show you basically examples of how we then use that to actually look at the occurrence of Parkinson's disease. So that is where we now can do a lot more, and in the resources that we currently have, and I will show you that, we now have somologic scans, so full proteomics, about 7,000 proteins, the methylome and the metabolome to really look at that. The third level, basically, of evidence is where we get much more clinical diagnosis. That's really hospital case control studies. But of course, there we have limitations what we can do on the exposure side when you think about the internal exposome, because we're looking at a disease population, and that might not be the right etiological time window that we are looking at, given the large prodromal phase that Parkinson's disease has. But it does have the best clinical follow-up. And I put in a slide, especially for Bob, because I think this is actually right. And so this is our hospital case control study, where it's a classical case control study. We have controls, we have cases. We do a lot of work to understand basically what their lifestyle is and what their exposures are. But then we actually follow longitudinally the cases to actually look at the chemicals, the exposures, the nutrition, to see what is actually the recurrence or the progression of Parkinson, I should say. Is there something that actually shows us that there are interactions between medication and the external and internal environments that we have that actually may make the treatment less or more effective? So this is exactly what I think we should do, and this basically is one example where we are doing that currently. What I wanted to focus on today is basically go back to the administrative cohorts and to the nested case control studies. And I'm going to do this as examples for pesticides. And by no means I'm saying that pesticides is the most important exposure for Parkinson's. I mean, we know air pollution has actually quite a significant contribution to Parkinson's. But I think it's a telling example, so I'm going to just talk about that a little bit. This is exactly the same picture that Alexis showed, but I think this is one of the first studies where our minds were basically brought to the fact that this relationship between pesticides exposure and Parkinson's disease is not necessarily only an occupational problem, that it actually might also affect the general population. And this is basically the study that was done here in France, looking at these different agricultural areas, compare that to the non-agricultural areas, and then looking at the clusters of risk. And you can see cluster 3, which is in red. And unfortunately for the people that would be drinking wine from the Bordeaux area, that is basically related here to a high-risk cluster. Now, of course, the question is that, yes, I mean, this is the finding, and it basically seems to be related to viniculture. We have the beautiful studies of Beata Ritz in California that have also shown basically associations between people that live close to the fields and pesticide exposures. But there are some differences when I then go to the Dutch situation. The difference is that we don't have viniculture, or not wines that I would at this moment advise to you to drink, but that's not the crop that we have in the Netherlands. When we think about pesticide exposure in California, there are different crops, but the other thing is that there's aerial spraying, which has a completely different drift and evaporation characteristics than what we have in Europe, where we only do downward spraying or sideward spraying of pesticides, which doesn't migrate that far from the fields as it does when you do aerial spraying. So quite different circumstances. So we are very interested to see what is happening in the Netherlands. Now, the Netherlands is a very peculiar country for many reasons. I'm not going to name them all, but what is peculiar about the Netherlands is that we actually are very densely populated and have a large agricultural production. And what that means is that in the Netherlands, half of the population lives within 1 kilometer of a field where pesticides are actually used. 5% actually lives within 50 to 100 meters of fields where pesticides are used. Very different than many other circumstances that we have in Europe, and that's just because we are densely populated and still want to have a very large agricultural operation in the Netherlands. This is the clustering that we just recently published in the Lancet Regional Health Europe, where we took basically our newly defined registry, mapped that geographically to the Netherlands, and basically saw this picture. We were surprised for many reasons. One is that we see a clear gradient for the Netherlands, and for people from the US, the Netherlands, when I go top north to south, that's 300 kilometers, 200 miles. Going from the east to the west, that's about 100 kilometers, so that would be about 70 miles. So this is about the size, right? So if we go from the north to the south, we actually see that the incidence in the north is higher, relatively, about 20%, than it is to the south of the Netherlands. So when we actually look at it statistically, there is evidence that indeed geographically clustering is happening. So this pattern cannot be explained by random distribution of the disease across the Netherlands. So clearly there are, in the broadest sense of the word, environmental or exposome variables that are really driving what we see in the Netherlands. But what we were surprised about is that when you look at this picture, you don't see Amsterdam, Utrecht, The Hague, and all the large cities coming up basically as the air pollution driver of Parkinson's disease. What you also don't see is that the agricultural areas that we have in the Netherlands are really clearly showing up. And what that means is that the etiology of Parkinson's disease is much more complex probably than what we have been appreciating on now. And to see a cluster, you actually have to have a very large attributable fraction to the disease to be able to see it, a stable population, a stable exposure, and that's something that we don't really have with pesticides, and that therefore I don't think these ecological analyses should be seen as basically there is no relationship. It's basically a call that when we have this ecological analysis, we need to move forward to actually do individual analysis. Now, this is exactly what is possible in the Netherlands, and that's what I alluded to this morning, that what we can do, and so we have 17 million people in the Netherlands. We link the population health records to the crop records, and we actually have been listing every single crop in the Netherlands for 40 years already. So we know exactly what was actually planted where in the Netherlands. And we have basically the pesticide reporting information that we know which pesticides are used. Unfortunately, and this is where Alexis is really right, we don't know exactly which pesticide is used on which field. So we still have to do a probabilistic assignment between basically what we know is used on a crop and where that crop is, but we don't know if that farmer did it exactly or the other farmer did it. There is a reporting duty in the Netherlands to actually register what you use on each field, but that is not open data that actually can be used for research, and that is where the political agenda should actually make that enforced. Leaving that behind, that political statement, we then basically link this information so we can actually calculate exactly the amount of crops around the homes of people. we can actually calculate exactly the kilograms of active ingredients that actually are used around the homes of people. And when you do that, you basically end up that for the particular study of Parkinson's that we do, where we follow this basically from 2005 to 2022, so that's about 17 years of actually knowing the pesticide exposure, and this speaks to the fact that we have this long prodromal exposure, and so we need to extend that as far as we can. Unfortunately, we would like to extend that further back in time, but that's where the data becomes more granular for us to actually be able to do that. So we still limit it with more slightly less broad window of inference. When you combine that data, you basically end up that there are 280 active ingredients used on these crops over that time period in the Netherlands. So a massive amount of different entities that you have. When we then go to filtering to actually ask the question which ones are predominantly used, you get to about 50 to 100 that actually are used more en masse in the Netherlands, and that's where our analysis are focused on. Now, I think here one of the key things is then to think about, okay, but how do we actually then use that information about active ingredients? This is where, and this will come back, is that we basically take an in silico approach where we actually predict which of the pesticides are potentially neurotoxic. The ones that we actually predict to be neurotoxic, we actually get into a more hypothesis-driven analysis where we say, okay, we have more evidence that these are related. The other ones basically go into more discovery-driven approach where we in principle have no evidence that they are neurotoxic, but we really want to look at them because we want to exclude that we actually throw something away, but we actually don't mix them. And I think that's important when we do exposome research. We should not throw away the knowledge that we already have. We basically, in a Bayesian way, have to actually infer that before we do the analysis. That's exactly what we do here. Now, I cannot show you the research on the active ingredients because that is something that we need to produce first for the government before we can do that. But what we can say at this moment is that we do see potential associations to the bulb fields, to some of the other crops that are in the Netherlands. So I think it's clear that there might be really residential relationships. We need to look at it further and then basically go back to the mixture analysis that Alexis also showed to really then identify what are the pesticides that are really related to the occurrence of pesticides. Just going to do a shameless plug. Asif Friedman is sitting over there, a brilliant PhD student in our program. His poster is downstairs if you come to the right, poster 9. And there you can see that we actually take the exposure assessment one step further. So Alexis was right that the gain that we have to do is really on the exposure side. And what Asif has done is that we actually can take now the pesticide use, but we actually can model, based on the methodological circumstances, the way that it's applied, how it actually migrates from the field to the home. So we are able now to predict exactly for each home in the Netherlands how much of the pesticides migrate from the field based on when the applications are, what the methodological circumstances are. So a much more detailed exposure assessment, and that's coming up. So that's one line of evidence that we currently have, and you can expand this to air pollution and others. The second example that I wanted to go into is basically what we call the EPIC for neurodegenerative disease, or EPIC 4ND effort. This is where we isolated all the Parkinson cases, the ALS cases, and the Alzheimer and dementia cases from the EPIC cohort within 5 countries that were able to do this. And we actually put controls next to it so that we actually facilitate nested case control studies where we have biological material that is 8 years or longer before actually the clinical diagnosis. And this is crucial because what Alexis was pointing out is that we have this issue about reverse causality when we think about Parkinson's disease. But when we actually can use the biological samples and show that this happened 16 years before, that is not that we therefore can exclude reverse causality, but it makes the likelihood of reverse causality much smaller, and that's exactly what we can do in this resource, and I will show you how we do that. Just bear with me for 4 or 5 clicks to take you through how we do this. So we selected for the Parkinson component of this 350 incident Parkinson cases that we have within the cohort, then basically match 350 controls, go back to the biobank, get the plasma samples out, and subject that then to exposomics profiling. And so this was done together with Gary Miller's lab at Columbia and Doug Walker's lab. I have to think if it was run at Emory or at Mount Sinai, but anyway, and anywhere in between. So that's basically an LC and a GC analysis to get both the endogenous and the exogenous molecules. Then this was really large work by the lab of Gary Miller. We went very deep in that data and isolated 290 different pesticides that we could annotate at a level 1, so that's with internal standards, or on a level 2 annotation within that data. So we actually find an enormous amounts of different pesticides back in the biological materials of these people. And actually there's no biological sample that doesn't have pesticides that we actually can measure. We then do the same as we did before on the administrative. We actually then use an in silico technique to predict which of these 290 pesticides are likely to be neurotoxic, and again split up the stream of saying, okay, there are about 40, 39 to be precise, pesticides that actually have evidence of neurotoxicity, and the rest basically doesn't have evidence, and that basically goes in a slightly different stream of analysis where one is more hypothesis driven, the other one is more discovery driven. We then took 2 different levels of analysis. One is basically to look at single active ingredients. So you could call that a pesticide-wide analysis, or to look at combinations, so basically using mixture analysis that could be WQS or BKMR, basically where we look at the combination of different pesticides. We did something else, which is called the D2 approach here, and that is where we did a very simple effect addition method. So we said, okay, if you have a pesticide that is neurotoxic, you get a score of 10. If you have 2, you're 20. And if you have 1 pesticide that's not neurotoxic, you basically get only 1 addition. So it basically is trying to scale this, and you can do this much more informed, and there are different techniques how to do this, but it's a crude way of actually constructing a cumulative score based on the evidence that we have on neurotoxicity. The fact that we ran GC and LC also means that we actually get the biology right, so we actually have all the small metabolites, and we can actually look at what might be the pathways that are involved potentially in that relationship between pesticides and the occurrence of the disease. So before I go there, I wanted to go somewhere else for a moment. And the reason to do that is that I'm sure that somebody's going to bring up the fact that we have 1 biological sample, and these are all pesticides that are relatively short-lived, so there's massive exposure misclassification. And I fully agree, there is massive exposure classification. However, I wanted to show this slide, and this is basically what we did in the full cohort of the 5 countries, so this is 190,000 people, where we looked at the intake of caffeine. And what we see is basically, if you look at the different quartiles of caffeine, you see that people with a low intake, moderate and higher, you see basically a dose response that there's a reduced relationship to Parkinson's disease. We did a lot basically also to look at the time windows where this occurred, and I think this speaks to Alexis that I think this is potentially not reverse causality. This actually might be there, and other people have seen this as well. Now, let's look at when we actually isolated caffeine from this nested case control study. Remind you, this is a one measurement, 8 years and longer before Parkinson's disease occurred. So you see here caffeine and all the metabolites that actually come from caffeine that Gary was able to pull out of the data. And we actually retrieved back the association that we actually had on self-reports of coffee intake, that when we actually measure caffeine in these biological samples, we see a reduced risk towards the later occurrence of Parkinson's disease. We see that also with 2 of the main metabolites, pyroxine and thiophyllene, which interestingly have been used in clinical trials to see if you actually could reduce some of the symptoms of Parkinson's. So there is biological reasoning that these actually might be active, and these are the 2 compounds that actually show the strongest relationship with the reduction in Parkinson's disease. When you go to the other metabolites, it becomes much more diverse. To Alexis' point, when we actually then reduce the data set to people where we have the blood sample longer than 12 years or 16 years, before Parkinson's disease occurrence, we still see the same relationship. So there's no evidence that the time between this blood measure and Parkinson's disease had any influence on this relationship. So it speaks strongly against reverse causality. I bring this in because we have to realize that, and this is slightly where I disagree with, although I wasn't there yesterday, but heard that single biological samples can be informative. It depends basically on the stability of the exposure, the half-life of the exposure, the strength of the association. Again, if we see something, I think that's meaningful. If we don't see it, it might be because of the exposure misclassification. But it's important to realize that we should not dismiss basically discovery results based on single samples, because I think there's valuable information in there that we don't always need to have repeated samples to actually do that. To go back to pesticides, this is the most surprising slide that I can show you, because I didn't believe it was true, but we cannot calculate it away. So this is where we actually then took the cumulative pesticide score with this simple addition metric, put it in tertiles, looked at basically does it relate to Parkinson's disease 8 or longer from now. And lo and behold, it seemed to have a relationship. So when we look at the first tertile, it's basically a 40% increase. When we look at the highest tertile, it's an 80% increase. I'm happy to hear basically how that can be explained by confounding, but if you actually calculate E-values, which is basically calculating how strong the pesticide has to be related to a confounding exposure and to the endpoint, you basically end up with E-values around 3. There's nothing in the literature that has that strong of a relationship with Parkinson's disease. So I'm happy to hear alternative explanations, but we cannot get rid of this effect, correcting for nutrition for all the other things. So it's an interesting thing, and I think it's really speaking to the fact that these kind of technologies really can give us new insights. When I go to the D1 analysis, where we basically go through single pesticides, right? We first look at the ones with high neurotoxic potential, and what comes out there is emetrin. And emetrin is a triazine herbicide, and that's interesting because triazines have been postulated to be related to Parkinson's disease. One of the major ones there is atrazine. It's one of the major triazines used in the US, but we basically see here a clear signal of emetrin. We see that in continuous analysis, we see that in tertiles, we see it when we reduce the Parkinson cases to the ones where we have clinical confirmation. And we see it also when we actually start to exclude cases that are much more recent. And again, the similar thing as we saw for caffeine, if we actually go to 12 years out, we still see the relationship to emetrin. I'm not arguing that emetrin is the causal association here, but it's interesting that we now actually have a further point where we can actually focus on. We did do a mixture analysis with all the triazines, but then still emetrin seems to be the driving force within the cluster of triazines. So this is really something that we need to follow up more experimentally. When we look at the discovery part, where we take all the other 250 pesticides where we have no evidence that they're neurotoxic, the evidence is basically null. We see some basically that are negatively, positively, nothing survives a false discovery rate, and if you look at the number of positives and negatives, it's really indicative basically of a null finding. So this really didn't give us new insights that we actually could give, but we now have 2 solid leads. One is basically a lead to look further into the triazines. The other one's to actually look at mixture effects when we actually put all the pesticides together. Interestingly, if you put them both in the model, they both are related. So it's not that emetrin is causing the cumulative effect. It's not that the cumulative effect takes away the emetrin effect. Just something to think about. So when we then actually take it to the metabolomics, so this is then basically doing a pathway analysis where we look at the overlap of the metabolome versus the endpoint, in this case Parkinson, and then look at the relationship between emetrin and the small molecules and see basically what is the mediation on a pathway level. There are 18 pathways that are basically common between Parkinson's and the metabolome and between emetrin and the metabolome. 16 are displayed here because they actually cluster into families, which basically gets you into amino acid metabolism, into lipid metabolism, energy metabolism, and vitamin metabolism. The dots before are basically not the statistical strength, but how many of the metabolites are in that pathway that are significantly associated. So you see some of the leading pathways within that analysis. They all basically point to a mitochondrial metabolic dysregulation. And that is something that we think mitochondrial dysregulation is important in the driving force of Parkinson's disease. So there's also biological reasons to think that this might be an interesting finding that warrants further up, and we hope that this paper gets out now very quickly. So I go again back to the plea of the patient. That, you know, we have to search for a cure, we have to see if we can mitigate some of the progressions of Parkinson's, but we also really deserve to actually look at the origin of these neurodegenerative diseases. This is also, and that's where I'm going to conclude, where I strongly believe we need to share our resources. So I'm not here to present basically the science we do. I'm presenting here the inspiration of data sets and what we can do if we all work together. These are all QR codes of all the exposome tools. This is basically statistical methods and other things that are collated by the International Human Exposome Network that I coordinate together with Martina Vrijheid at IS Global. Exposome Maps is where all the geospatial information from Europe is actually collated into one facility that is accessible to everyone. Most of the exposures in Europe are now mapped at a 50 meter by 50 meter scale, so very high resolution, time resolved over time, and I think we can do much more with that data. There's also a cohort catalog, so there is an awful lot of data already there, so we don't have to start new cohorts. I would argue don't. Let's first use the ones that we actually have in the most efficient way that we can. And this is basically a plea to put in your cohort resources into the cohort catalog. This is basically showing from a few months ago when we had the CITES meeting where what we have now, but this is basically all the different cohorts that are in there. A few observations here. One is that North America is largely absent in the cohort catalog, and I know that there are cohorts in the US, so I would strongly urge you to actually put that information in, because we need to actually know what we can do in Europe and what you can do in the US and how we actually can work together. The other aspects, of course, that the Global South is underrepresented, and this is something where we really have to focus on. Not that I don't believe they actually have been put in, but it's basically because they are not there. And if we do new cohorts, new efforts, then they should be there, and I would argue not necessarily in the Global North. The other aspect that is important here is when you go to the right is that we actually see less elderly cohorts in the catalog. And this is important when we talk about neurodegenerative diseases. Of course, it has a long prodromal effect and it has early life risk factors. But if we really want to understand that, we also basically need to have those cohorts in as well. And this is a plea perhaps more to the clinical-oriented people here to really put their cohorts, their resources in as well, because we are not leveraging those resources within the communities at this moment. Why that is important, and this is to the point of Bob. So thanks, Bob, for this morning, because I added 2 slides on that. This is basically showing a completely different project, but this is the EXPANSE project that we just finished, where we look at asthma and the exposome, where we combined all the environmental data into exposome risk scores. What you can see here is that the relationship between those exposome externally and asthma is actually equal between what we see in the adult cohorts and what we see in the birth cohorts. So the top ones are basically in blue, all the adult cohorts. The red ones are the birth cohorts. And this starts for us to mean that we actually can put that evidence base together. I need to finish up, so please reach out if you want to work with the EPIC4ND resource. E3N, Alexis will join soon, so these numbers will increase, but there's a richness on data there that we actually can leverage. Also, we have new predictive markers for the disease based on the somologic scans. Please reach out because more can be done. Dutch census data, we can actually help to follow up many of the environmental exposures. Please reach out to our team. This is the exposome scan facility that we have in the Netherlands to actually measure all these chemicals and so on, completely robotized in clean rooms. So we're there to help you, and then I just want to end with introducing the team that's really working on these things. People on the left side, Thomas Hankemeyer, Leiden University, and Robert Vossenbos, Utrecht University, working on metabolomics. Then the large EPIC group, Natalia Vilor-Tejedor is here in the audience, there she is. Kahina is here as well as a PhD student. And then the people that are working on neurodevelopment, and then the people that work on exposure assessment, Kees de Hoog, but especially Danielle Figueredo, who's on parental leave and couldn't be here, that does a lot of the pesticide modeling, is actually working with Asif to get this all done. So thank you very much.
Thank you, Will. That was wonderful. You pointed out that you've been following the cases longitudinally. Have you done any analyses? I'm just curious.
Sorry, Bob. This is basically a protocol paper that we just put out because the new recruitment has just started, so the answer is no. There is another data set that we are currently doing where we do the same thing. And the good thing about the clinical study is that we have CSF. So what we're doing there is that we have blood and CSF, which we actually can submit to exposomic analysis and actually see how that actually relates to the further development. So that's really where the clinical studies are hugely important, because in the EPIC or in the other studies, of course, we don't have access to CSF.
Great, thank you. I had one quick follow-up. I really like Sandrine's suggestion about biomarkers such as biological age. I just wonder what you thought of using that as a way to follow folks forward.
Yeah, so what I didn't talk about today is that we did this a massive effort within EPIC. So we scanned more than 10,000 samples on the SummerScan 7K, both for cancer and neurodegenerative diseases. There we do have the protein clocks for different organs. So we can look at that. For now, we have been looking at predictive markers. So there are new proteins that predict for Parkinson's disease, also for Alzheimer, basically 7 or 10 years before. That's what we have been working on in the last year to get there. Those publications will come out in the next month, I think. And then we'll basically go to aging or to other biological inferred pathways. I don't think aging is the only one, and I think to give a shout out to Marc Chateau-Guillaume will show that there are other biological scores that actually might be informative next to actually only looking at aging.
We're running behind, so we got one question.
Don't. Yeah. I'm not going to Sweden. I did promise to go the mountain once and not.
To be part of this. To be part of this in our part of the world, I'm Rima Habib from. We know each other from very well from EPICO. Role. Is it just longitudinal studies that you want here? Because ours is cross-sectional, for instance, and it's on workers spraying pesticides, neurobehavioral performance, and all the works. And the exposure is very meticulously assessed.
Right. A very good point, and thank you. Tomorrow I will talk a little bit more about the International Human Exposome Network, and we'll come back to the global exchange that we have. But I think you make an important point. I think we should not regard basically cross-sectional studies not as being relevant. There is a hierarchy that we actually are taught in epidemiology, but sometimes certain studies can be more informative than others. And especially we also have to realize what is there in the absence of other studies. And so again, I'm reflecting to countries where we have less resources, that not always there is no EPIC that you can use, and therefore we should not basically bias our evidence base by discrediting basically cross-sectional studies, other studies. So we're very open for all study designs to actually be informative to be doing that. Lea Metre is also here with ICE Global coordinating part of basically getting this catalog together with Groningen University done. Reach out to us and we can basically see how we actually can integrate that. Thanks.
Okay, thank you very much, Roel. So up next, we have Dr. Lea Metre. She's an assistant professor, research professor, and the Exposome Hub coordinator at the Barcelona Institute for Global Health, also known as IS Global. She'll be talking about from hormonal signatures to brain health across generations, exposome predictors of pregnancy, steroid milieu, child neurodevelopment, and maternal postpartum depression risk. So without further ado, great.
I need to lower that a little bit. Yeah. So today I'm going to present some very recent research we've been doing in my group. I usually present research in childhood, environmental effect on childhood health from the Helix cohort, but today will be different. Today I'm going to focus most on maternal health. And I'll start by focusing on the biological question. It's a very important time during pregnancy to study the steroid hormone change. During pregnancy, we have a huge shift in the production of mainly estrogen and progesterone by up to 1,000-fold increase in the third trimester compared to the beginning of the pregnancy. And these hormones have a strong influence on the growth of the baby, but also modulating the maternal brain health. And these steroids are essential for fetal development, for birthing, for maternal neurobiological adaptation. This is a dynamic change and longitudinal, and it also helps to regulate postpartum the relationship between the mother and the child. There are different pathways involved. Normally, when we look at steroid hormones, they are measured in blood. We measure few of them, testosterone, progesterone, but actually hundreds of steroid hormone metabolites that may have slightly different health effects. Some are active, some are inactive when we measure in blood. And there's been recent studies, actually in Barcelona, where they measured very precisely these hormone changes in women, and they looked at also brain changes during pregnancy and postpartum. I thought in this conference I had to present some brain images, so here we go. And in this study, they looked at same-sex parents, so women parents, and they looked at the brain changes throughout pregnancy and postpartum in both women, the one that was gestating and the non-gestating women. And that's very useful because then you can disentangle effect of pregnancy on like life changes and more biological changes. And they found that there is a global 5% decrease in the global volume of the gray matter, and there is a partial rebound in postpartum. So that's just to show there is a huge brain remodeling during pregnancy, so potentially a sensitive period to environment. And this steroid exposure, it's also associated with the developing brain. Well, that's what we know from animal studies, but there is very little evidence in human. And these are very interesting potential markers of early environmental insults on the brain development of the child. We know that some steroids are neuroactive, such as alloprogesterone, and there's been some studies relating it to autism. So the same steroid milieu shapes both the maternal brain and the fetal brain. So I'm going to present 4 studies. The first part is going to focus on the steroid metabolic milieu question. First, what are the determinants of these hormones in pregnancy? And are they associated with the child brain development, which was our initial question when we wrote the project. Then we're going to also look at, in part 2, how some of the environmental exposure and hormones can be associated with the maternal brain health. For this first part, we focused on 2 cohorts in Spain. And the first objective was to evaluate this maternal steroid milieu during pregnancy and its effect on the child brain development and the main determinants. And these are very interesting biomarkers. They basically, the metabolite we measure in the maternal urine and blood, result from a complex interaction between the mother, between the placenta, which is the main organ producing this hormone during pregnancy, and the fetus. The fetus adrenal gland actually is producing some of these androgens that then have influence on the mother. So it's a very nice metabolic pathway to study this interaction between these three important actors. And we want, in this project, to move beyond single steroid measurements. So we wanted a comprehensive characterization of this metabolic pathway, looking also at phase 1 and phase 2 metabolism of these hormones, so conjugated metabolites that inform on the clearance of these metabolites, but also potentially look at more active metabolites or inactive metabolites. In the first study done by my postdoc Emily, we looked at the main determinants of these hormone profiles in 2 different cohorts. In the BISC cohort, that's based in Barcelona, we had samples for 720 women. And that's the best well-characterized cohort because it's the recent cohort. The women were recruited during COVID, before and after. So we could use novel technology, new ways to collect urine samples with repeated sampling. As we've seen, it's important for changing short life chemicals. And we did a replication analysis in an older cohort where there were slightly less information and different types of sampling, but still could help validate some of the determinants. So we actually looked at almost 50 determinants, genetic of the mother, lifestyle factors, including sleep, diet, physical activity, also information on the maternal mental health, perceived stress and depression risk scales, and also some environmental factors, but not chemical in this paper, so smoking, and also more obstetric-related determinants, such as if the mother had preeclampsia or gynecologic factors. And we find, this is quite a dense figure, but we found actually some of the main determinants were the BMI of the mother at the beginning of pregnancy, was associated with most of the hormones, but also the age of the mother. So older women had a lower total testosterone and androgens metabolite. And this is the variance explained plot. So actually, we could explain with these determinants up to 10% of the variability in the hormone levels of these women. When we look at the actual determinants that were replicated across both cohorts, so we could find a higher BMI with a higher level of some of the corticosteroids, androgens, and also the number of children the mother had parity, physical activity, tobacco was associated with the hormone health, age at assay, also the origin of the mothers, and the sex of the fetus. Then there were things we could only look in one cohort in BISC, but that's still 700 women. And we found also some genetic determinants, and very interestingly, maternal mental health at the time, cross-sectional analysis, were associated with some of the metabolites. Our second question was about how these early steroid signatures could be associated with child brain development. This study was done by Estelle, who is here and had a poster yesterday. In case you missed it, I'm going to explain some of it now. So with the same urine metabolic signatures, we looked at this association in both cohorts, INMA and BISC, on child neurodevelopment. We had longitudinal data. We had up to 6 time points in INMA, so from 15 months old children to 15-year-olds, so really covering neurodevelopment over 15 years. And we had different types of cognitive outcomes and behavioral problems. And we could replicate part of this analysis and assessment in BISC, but only looking at the early mental and psychomotor development because it's a younger cohort. And one of the main reproducible results was with this cortisol metabolite, which was associated with poorer early cognitive performance, and that was replicated in both cohorts. And another interesting result is that some of these effects were very sex-specific. So the hormonal exposure during pregnancy had different effects in male and female children. For example, androgen bioavailability, so we looked at ratios of the conjugate, was associated with more externalizing behavior in girls only. But some of the same metabolites, they were associated with better fluid intelligence in boys. So, and here I show the volcano plots, because I'm not going to go into every single metabolite, but you could see there is an overall tendency of effect, so red being females and blue being males, that there is a differential effect of this metabolite during pregnancy. Okay, so in the second part of the talk, I will go more into environmental determinants. And here we focus on a different outcome, but directly looking at the mothers. It's been underlooked actually in birth cohorts. We're always interested in the children, but I think it's a great opportunity to look at also midlife health outcome in the mothers. We have 20 years of follow-up of the children and somehow of the mothers. And one very important outcome to look at, I think, it's postpartum depression. It's very common, up to between 12 and 20% of prevalence across country. It occurs in the first 6 months after childbirth, but it can persist for years after if it's untreated. And 50% of cases are undiagnosed. And it's actually the main leading cause of maternal deaths in the first year. And it really matters. It has lasting effect on the mothers, but also on infant bonding and child development. And timely treatment can be very effective. There is a very easy way to treat postpartum depression. The etiology, there is a biological etiology from the withdrawal of hormonal exposure during pregnancy, and that's quite established. And the neuroactive hormones increase during pregnancy, and there is a sudden drop in postpartum, which affect the brain potentially in pathological way for some women. And also psychosocial stressors, of course, severe life events, limited family support is a predictor, but not only. It doesn't explain all the cases. There is also clinical predictors, such as prior mental health issues, such as depression. There is a recent scoping review on environmental determinants, and there's been studies that looked at air pollution and postpartum depression, and they found some associations. Phthalates and PBDEs have been associated, and some emerging literature on PFAS and flame retardants that may have an impact. I'm going to talk about some potential mechanism, and metals. So, yeah, my background is biology, so I always like to look a little bit what could happen, what's our biological understanding of these associations. So for PFAS exposure, which we know is not one type of compound, there's thousands of different types of PFAS nowadays. So there might be slightly different mechanism for long half-life PFAS, long-chain PFAS, persistent ones, and the replacement one, the short chains. But it's been established that they cross the blood-brain barrier and may have an impact on the HPA axis, but also on basically neurotransmitter metabolism, so glutamate signaling, and also through neuroinflammation. And fourth mechanism, also PFAS may disrupt breastfeeding and oxytocin, which are important for mental health. And when we looked at effect of postpartum, there's different outcomes we can look at. We can look at the prevalence of postpartum symptoms. So it could be that depression starts already in pregnancy and lasts throughout to postpartum, or new incident cases in postpartum. And nowadays it's screened through this Enderburg scale. Actually, it's routinely implemented, at least in Spain. From the first visit at the gynecologist, they screen for postpartum depression with this questionnaire. So it's available very easily. And it has different subscales from anhedonia, anxiety, or depression. So in this study, there was actually a collaboration between Gary Joseph and Lauren Petrick in Mount Sinai, where we worked in the Progress cohort based in Mexico City. And we also had a look at the same question in the BISC cohort in Barcelona. So the two populations, both had available PFAS exposure and postpartum depression. Longitudinal, they were repeatedly measured in pregnancy up to 2 years. And, but there were slight differences in the way PFAS was assessed. So in Progress cohort, there are data from untargeted mass spectrometry in 1 month postpartum. And 8 PFAS could be detected through untargeted mass spec, and these were the one we were using, so their relative intensity or abundance. In BISC, we had targeted PFAS, and we selected the same 8 PFAS that we could be measured also in the Progress cohort. And we used the same model in both cohorts statistically to look at the question of how PFAS is associated with postpartum depression. What we found in the Progress cohort is that this PFAS, the PFNA, was associated with higher incident postpartum depression, so new cases of postpartum depression. And there was some mixture effect also of the PFAS on one aspect of postpartum depression, which is anhedonia. So we can see the effect here, and you can see there is a specific effect on this subscale. Okay, what did we find in BISC? Nothing. There was no effect of these 8 PFAS that were also measured in Progress on the BISC mothers. Why did we see this inconsistent results? There could be many reasons. The two cohorts actually, they about, I think, 10 to 15 years apart in time, so potentially different PFAS profile. The timing of the exposure is slightly different, although these PFAS are persistent. So in Progress, they were measured 1 month postpartum, but in BISC, it was in the 3rd trimester of pregnancy. And slightly lower prevalence of postpartum depression in BISC. In BISC, the mothers, they're highly educated, higher socioeconomic level, potentially less socioeconomic stress. So that could explain also some of these differences. In our 4th study that's not published, I'm still going through the results, so I'm very happy here if you have any comments or suggestions. I thought, okay, let's take this very well-characterized cohort of BISC, let's look at the exposome approach, looking how together all the data we have in this cohort from psychosocial factors, which are very important for depression, socio-demographic, clinical factors, lifestyle, environmental chemicals. We have up to 50 different chemicals that were targeted in the urine and blood samples, and also including the hormone profile we have in the same population. So looking at all these potential exposome variables, covering different domains of exposome, how does this predict postpartum depression? For this, I had a student from more engineering who liked fancy not so fancy anymore, but 2 years ago it was fancy. Some machine learning prediction models. We tested different types of machine learning classifiers. And we picked the one that had the best performance based on the ROC curve. So we focused on the XGBoost model and did some interpretation with SHAP values. So it wasn't just a black box of prediction. We could go back of what are the main predictors of postpartum depression in this model and potential interaction of the determinants. So what did we find? We find a modest prediction. So with all these exposome factors together, we had a ROC curve of 0.64. So not relevant for clinical diagnostic. For clinical diagnostic, you just need a questionnaire with 10 questions that would help you to predict it. But for public health, potentially interesting. So here we classified the different predictors based on their family. So we can see the main prediction came from lifestyle variables, then previous mental health determinants, but also hormones, contaminants. But when we look at individual variables, we see that after previous depression, the main predictor is one of the PFAS, and in the right direction, expected direction, because often these PFAS with brain outcomes, they can be protective or because of residual confounding or everything we talked about today. But here it was a more higher level of this PFAS, higher incidence of higher risk of postpartum depression. I was a bit worried when I saw that because in our previous paper we saw that PFAS had no effect on the postpartum depression. But then I realized that this PFAS was not included in the previous paper. It's a new PFAS that we could only measure in the newer cohort in BISC. It's a replacement PFAS, a short chain, the PFBS. And so I asked Estelle to run again the analysis, including this other PFAS that we didn't include in the previous paper. And we found that only this PFAS here is associated with postpartum depression. Adjusting with using a DAG and more causal epidemiological framework, adjusting for the potential confounders, including breastfeeding, which is important for PFAS excretion, etc. Where does this PFAS come from? Why do we see this PFAS in particular? When we look at the concentration of PFAS in this population, because we have targeted quantified data, we see that it's one of the most abundant PFAS in mother's blood, with the also PFOS. And there was also another study where they measured PFAS in tap water in Barcelona. In a subsample of the BISC mother, they measured PFAS in the blood and matching samples of unfiltered tap water. And they found that this PFBS is the most abundant PFAS in Barcelona tap water. It's not the main source of exposure, because when we correlate the blood level and the tap water level, they don't correlate. And in Barcelona, at least, we don't drink the tap water. We filter it or drink bottled water, but there could be other sources of exposure than just directly drinking water. So I don't know the main source. For the older PFAS, it's, in our population, it was fish exposure. But this shorter chain, short half-life PFAS might be other sources. So I'll finish here with some take-home messages. In terms of looking at biological markers of brain remodeling and hormonal changes, I really encourage people to look at urine sample. I know Dinesh is very into the blood exposome as the main equivalent to genetic, but personally I'm a big fan of urine, because that's where most of the pollutant that goes through our body will be found in higher concentration, easier to measure. But also for endogenous metabolism, to look at microbial metabolism, it's a great sample. And non-invasive, much easier to collect. But you need maybe slightly more samples. The second thing is that steroids are very good biomarkers to track maternal and possibly offspring brain health, in particular some of the conjugated metabolites. And the third point is that replacement chemicals might be more associated with some brain health, neurotoxicity than the old ones, not because they have such a short half-life that they're not neurotoxic. Just makes them more challenging to measure. And also I want to emphasize that pregnancy and postpartum are under-recognized window of maternal brain susceptibility to chemicals, and very interesting life course period to look at. I would like to thank the cohort participating families, as we've seen in the trials. Also, the cohort participants, they have a very heavy protocol to follow. In BISC, they had to collect 14 urines during a week and many other things. So that's why we're always biased to more educated families. And I think maybe we can learn from these clinical trials on how to better recruit families that are not so well educated or higher social income. And the team also, I put this picture where I just had my second baby, and I'm using this opportunity to really connect with the families of Barcelona through the postpartum groups. And here's one example where we talked a little bit about our perceived environmental risk. What can we do about avoiding some chemical exposures for us, for the children? And that's it. Yeah.
Ashley Jaberge, University of Washington. Thank you for a really interesting talk. I had a question about one of the things you had posed as a limitation towards the end, which is the recruitment of people from lower socioeconomic statuses. And I was wondering, what's the current method that was used for the initial recruitment in the cohorts you mentioned? And is the method of recruitment potentially a cause of the bias towards higher socioeconomic status, or is it really, like what you mentioned, the burden of the multiple specimen collections?
So in Spain, and because of free healthcare, actually most women go to the public hospital. So the recruitment, it was through the first hospital visits. So here we reach most of the population. So I think it's more the burden. And also, yeah, I like the ideas earlier, like the lack of conception, like of prevention, and the conception maybe that women can't do anything about the environmental exposures. But yeah, the recruitment, I think it's, yeah.
Then maybe one quick follow-up question for the burden. Was all of the urine done through like a home collection and then mailed in, or was there any like in-person component that was required?
We were sending a kit to collect the urine at home, and then field workers were going to the house to collect the urine 2 or 3 times during pregnancy. But then there was also visits at the hospitals for anthropometric measurements, etc.
Yeah, I only asked because in some of our studies with good representation in lower socioeconomic status, they mentioned that having the flexibility to do the sample collection at home and then also like mailing it in was helpful, not having to coordinate times for pickups and things like that, because they have often very complex work schedules and also caregiver schedules. So maybe something to consider. But thank you so much for the inspiring work.
Hi, thanks, Leah. Very nice presentation. So knowing that you have MRI data in the BIS cohort, I think it would be great to also include this information because like for depression in general, you can also determine some subtypes using MRI information. And I think this can add also some information regarding more the mechanistic and biological part. And actually, I also have another question more related to the machine learning model that you were showing. If I understood correctly, you have this Mexican cohort that is pretty similar to yours. So are you perhaps thinking to validate the model on that cohort?
Well, let's speak after the talk with Megan or anyone from Progress cohort interested in this question.
Could you repeat the question? I'm sorry.
I didn't hear.
In terms of the validation replication, I believe we have the data to do that, and I'll let Megan talk about the MRI.
It was a great talk, Leah. And yes, we do have, I think, very similar both exposure metrics in terms of a lot of the measures in urine, and I think we both followed very similar protocols for the MRI. So there's a lot of replication that we could do across cohorts, and also with the SHAP models. So with the XGBoost and the exposures, as well as with the MRI. So it's a good point. Very good.
Yeah, just to specify, we don't have brain MRI in mothers in BISC yet.
Same answer for Progress. Yet.
It's just a technical question on the distribution of the metabolites you have. What we see in our data is sometimes very, because of the detection thresholds, so there is not much into the data. It's not Gaussian variables, but really very few people have, in fact, detected metabolites versus a lot of missing data. So in practice, how do you deal with that kind of data? It's sometimes very challenging to integrate all that. Do you have a strategy to share with us, or a common pipeline, or is it case by case and you, depending on the database you are treating?
Yeah. So actually, if I have 1 minute, in this project, we did only targeted profiling. So hormones were targeted, all the chemicals were targeted, so we don't have so much this issue because we have a low limit of detection and very robust measurements, because here we had strong hypothesis-driven work. But now we're going back to exploratory work through the athlete project and the BISC model. We also have untargeted, where we have this issue of a lot of missing data, and yeah, you need to use several approaches, keeping all your data with low missing threshold.
And yeah, sometimes you have to binarize your data, and then the models become very sensitive to that mixture of data, which are continuous versus binary. And it's a technical question. We can discuss that.
No, if it's exploratory, yeah, you need to have a lot of samples to have enough detection. And if you have a strong biological question, then you shouldn't look at untargeted data. You should look at targeted assays.
Great job. Thank you. Okay, thank you so much, Leah. Okay, so before we take a group photo and for the break, we're going to gather at the stairwell, from the lobby leading into the auditorium for a group photo. And we'll meet back here after the break at 4:15. So I apologize, I'm a terrible moderator, and I've not kept anybody on time. So we're running a little bit behind, so I hope you'll give me that. But we're going to meet back here in the auditorium at 4:15. But before then, I'd just like to take a quick minute to invite Bob up. So Bob, can you come up here to say a few words? And after that, we are going to meet in the on the stairwell for photos, and then meet back here at 4:15. So just before that, I'd just like to invite Bob up for a quick intro and just to say a few words. So Bob, can you come here? Thanks.
I'm actually not the important person for this. We wanted to give David Balshaw a memento for all the work he's done in Exposomics over the last 20 plus years, and just to say thank you. Thank you, David.
So if we can, if we can just meet on the stairwells, and we'll get a group photo, and then we'll have the coffee break, and we'll meet back here at 4:15. Thank you so much.
Okay. So I think we should start the session now. We are running late, as you could notice. So I'm really happy to chair the session on the markers session, and the actual title is Prodromal Biomarkers and Diagnostic Advances in ADRD, Opportunities to Integrate Exposomics. I think markers are really useful in the clinics because early markers, hopefully, because this will be really useful for prevention or secondary prevention, but it is also useful if you want to know the pathways between the exposures and the outcome, which is health, and you need some markers in between. So I think I'm really excited, and I guess you are also very excited to listen to the talks. The only issue is that we have 15 minutes, only 15 minutes, and after the 3 talks, there will not be questions after each talk, but after the 3 talks, we have a 30-minute discussion that we will do here. So the first speaker is Yue Lang, and she's an associate professor at UCSF, and Yue will speak about sleep as a window into the aging brain. I just learned that Yue means the moon, and this is why she will be speaking about sleep. So, Yue.
Thank you, Robert, for that very nice introduction. So I don't need to let people know why I was born to study sleep. And I think this is just the right time to talk about sleep this time. Is the microphone okay? Okay, good. So sort of an interest along my entire career is this close relationship between sleep and the brain. And this is a commentary published in Nature that says sleep is of the brain, by the brain, and for the brain. So I guess we all have that experience, why sleep is so important and necessary for our brain health and function. And especially as many of us may have realized or felt in some way that sleep change as we get older. So usually you have more fragmented sleep, it takes you maybe longer to get sleep, and then you also have more daytime sleepiness. And also there are many sleep disorders that increase with aging. For example, sleep apnea, sleep-related movement disorders like REM behavioral sleep disorder that was mentioned earlier, and then also disruptions in circadian rhythms. And these sleep disorders all get exacerbated in neurodegenerative diseases. What's really exciting is over the past, I guess, since 2009, 15 years or so, there has been this notion that sleep is not only, it doesn't only come with aging or neurodegeneration, but actually plays a really key role in the dynamics of Alzheimer's-related pathology. So these 2 landmark studies that showed during sleep, both there is the clearance of amyloid beta, and also if you are sleep deprived, you have more production of the Alzheimer's proteins. These 2 studies that were both in mice, where they showed significantly greater A-beta plaques after chronic sleep restriction, and also during sleeping mice cleared twice as much A-beta from their brains as conscious mice. And this is mostly evidence coming from the WashU group over the past few years. They show this DAO-orexin receptor antagonist, which is a DORA, so it's a drug for insomnia. They show actually by taking this, it regulates AD pathology, and they show this both in human and in rats. So this is really exciting, showing sleep medication actually have some therapeutic effects or preventive effects potentially for Alzheimer's. So we have been really interested in this bidirectional relationship between sleep or circadian disturbances and neurodegeneration. And why are we especially interested in this? Because we know if we can prove that sleep or circadian disturbances are prodrome for neurodegeneration, then it can really help with the early detection, early diagnosis of neurodegenerative diseases. And if we can prove this is a risk factor, then intervening on sleep can help prevent or even treat the disease. So increasingly, I guess this is a tie specifically to the exposome world. We're trying to really study things earlier. So we're studying life course sleep and neurodegeneration, and this is thanks to data collected over many years. And this is I'm trying to harmonizing data from many previous longitudinal cohorts, and we're looking at how sleep earlier in life and also accumulation of effects of sleep over the life course and how that can affect your cognitive aging processes. You saw earlier this graph, the Lancet Commission for risk factors, modifiable risk factors for dementia. And you also saw in Sanjay's talk, there was a little question mark, where is sleep? And here I'm trying to emphasize this. We have a lot of debate and a lot of, especially voice coming from the sleep community in the Alzheimer's field. Where is sleep? We're not, I'm not going to go into that too much today, although I still believe sleep should be there. But today I would like to really take a sort of a different aspect. So what if, even if sleep we may not be proving that sleep is causal yet, how about we see sleep as a window into brain health? And we really use sleep as a prodromal marker in this case that can help us with early diagnosis, which is equally, if not more important. And I think we also talked about, measurement today. And I think I was talking to Fanny, and Fanny was saying, maybe it's the measurement that's really challenging. And I would say, today I also want to talk to you about how we're actually measuring sleep, and this is becoming increasingly accessible in home, in real-world settings, and how I can see this really fits nicely within the exposome concept, and that's why I would really like to propose this sleeposome concept. So on the right-hand side, you see that's a person usually sleeping in a sleep lab, and you can see it's lots of wires and very burdensome. And what we get from this what we call polysomnography, the gold standard sleep measurement, is we have electrodes across the body. So you really get physiological signals measured across different organs, different parts of the body. How we usually use this data is we usually just use this, total sleep time, sleep efficiency, how much time you spend in each stage of sleep, etc. So it's really sort of taking from that very rich information and condense them to this very low-dimensional data variables, which has sort of limited value. And what we've been trying to do is to go back to these rich physiological signals. And because the electrodes attach to different parts of the body, we're really seeing this as a measure of physiology across the different organs. So today I'm going to mainly talking about kind of three broad aspects of this. One is brain signals, so that's with EEG, and that's really cool in sleep, as you can imagine. The second is cardiorespiratory signals, and we're interested in this because this is the sort of the common language between the polysomnography and the wearable or nearable devices that's very easily collected data. And then the third one is more circadian rhythms, and they measure 24-hour, as you can imagine. So I'm particularly interested in these three signals because these three broad parts, they can all be measured very easily at home in real-world settings. So you can see with the EEG headband, the under-the-pillow mat that measures cardiorespiratory, and then the watch, the actigraph, that measures 24-hour circadian rhythms. So I'm going to go very quickly through some of the digital prodromal markers we have been developing during sleep in these broad three aspects. And you can see I put a little icon in the bottom in terms of which module it represents. So the first one I want to talk about is brain EEG markers. So this is in collaboration with Dr. Hao-Chi Sun from Beth Israel Dinkins Health Medical Center. Hao-Chi is a biomedical engineer, and he has developed this really interesting brain age from EEG measured. And by calculating the deviation from EEG predicted age and chronological age, we got this brain age index. And what he has shown before was people really have different brain age even though they have a different same chronological age. And what we did recently was applying this in 5 established cohorts, including Mr. Ossoff, Eric Mesa, and Framingham Heart Study, and we used individual participant data meta-analysis. We calculated the sleep EEG brain age across all these cohorts in each participant, and then linked them to future risk of developing dementia. And we found that every 10-year increase in BAI, this brain age index, is associated with 39% increased risk of incident dementia. And after we published this study, I got a lot of interest, and including, I remember a primary care doctor reached out and said her patient takes this paper to her and said, I'm worried that I have really high brain age, like my brain may be aging faster than others. How can I measure this brain age? And I told her, there are these multiple consumer-based EEG headbands that may be valuable, but I don't think they incorporate these algorithms yet. But I can definitely see that as an opportunity in doing this. Some more sleep EEG markers. I was fortunate to be part of this work from my colleague Brandon Westover from Harvard, or he's now in Stanford. And then they used a sort of end-to-end approach to predict cognition, death, and a bunch of different downstream diseases from just one night overnight central EEG. And they found this brain health score, by deep learning, it predicts dementia really well. So what we're trying to do now is to use this to predict Parkinson's disease. And we're seeing some very promising results. Another thing is rapid eye movement latency, which was kind of ignored before, and we showed this REM latencies, especially associated with A-beta PET and also plasma p-tau181, so some Alzheimer's disease biomarkers. And this work has also got a lot of media interest, including this, you might know this guy, he's a sort of a influencer in the Asian space. And he literally put up this tweet and said, stop what you're doing right now and check the sleep data from your wearable to see, to assess your brain's potential amyloid plaque burden. I mean, that's definitely an exaggeration of our finding. We're nowhere close to that. But I think you can see that there is all this potential, or what you can do with all these prodromal markers. Maybe they can be easily measured with your wearable devices. Another modality we're really interested in is, as I mentioned, cardiopulmonary metrics. So this is using ECG and breathing-related polysomnography measures. And as you can imagine, they are really good measures of autonomic dysfunction. So here we're focusing on two autonomic dysfunction measures. One is heart rate variability, and then the other is cardiopulmonary coupling, which is a measure of coupling between the heart rate variability and respiratory rate variability. And we were looking at this for future Parkinson's disease risk, and we know that's important. We also heard this afternoon that there is this body-first PD, and for these people, autonomic dysfunction is a very early, can be early feature for the Parkinson's disease. So we think, what if we can measure this autonomic dysfunction during sleep, passively, when people just go to sleep? Then that can be a really valuable measure for assessing downstream Parkinson's disease risk. So given the time, I'm not going to go into details, but basically here we're looking at data, clinical data from the Mass General Hospital, and then we developed, using principal component analysis, we developed two main components. One is the global cardiac variability, which indicates the overall magnitude of autonomic fluctuations during sleep, and then the other is autonomic balance, which really reflects the relative vagal predominance. We also conducted another individual participant meta-analysis across 4 other community-based cohorts, and we showed that especially these measures, when they are measured in rapid eye movement sleep, they are associated with higher PD risk down the line. And in Eric especially, they have a follow-up up to 19 years. And this was, you can see very strong effects, and this is after adjusting for all the covariates. This again is showing the, with different sleep stages. So imagine if you have a wearable or some kind of sleep device that can just measure your heart rate variability, very simple measure, and if it can measure sleep stage accurately, it actually tells you a pretty good, gives you a good sense of downstream Parkinson's disease risk. Also very happy to share, like recently we have been using an AI model like transfer learning to apply knowledge that we have built using the cardiorespiratory signals from polysomnography and then apply them to home devices. And in this case, specifically, it's under the pillow mat that's built on ballistocardiography. So that measures exactly cardio and respiratory signals. And here we show that this device was validated against polysomnography, showing very good performance in both sleep apnea and sleep staging. And this work was just recently accepted. You might have noticed this paper that was published in Nature Medicine earlier this year that triggered a lot of interest. So this is work by James So and Emmanuel Mignon from Stanford. And then they built this multi-model sleep foundation model that they showed can predict more than 130 diseases. And this is thanks to the recent advances in large language model where they're really treating sleep signals as a language that can predict diseases. And what we have done is we built also a sleep foundation model, but only on cardiorespiratory signals. And then with this model, we can then easily apply this to other nearable or this MAT device specifically. I'm running out of time. So we have shown that this can be used to fine-tune into predicting multi-organ health in a range of diseases. We also use the MAT to validate this and show it translates well to real-world sleep tracking. We also fine-tune this for detecting Parkinson's disease, and again, showing pretty good performance on this. And then finally, I'm going to talk about we have done using wrist actigraphy, and then we have looked at the different profiles of 24-hour sleep-wake activity. We have shown that it especially increasing daytime sleepiness, which is one of the profiles that really predicts future dementia risk. We also looked at sleep-wake regularity, which again is this 24-hour, one of the really important 24-hour metrics that has been understudied before. And we show this more regular 24-hour sleep-wake habits also predict future dementia risk. That's me, usually wearing 6, 7 devices every night, and then that's all the wearables, and then you have, as I mentioned, the neurables, and then even wearables that use radar to predict, to measure your sleep. And then you can get 1 night of sleep, that's my 1 night of sleep, and then I can also get a whole year of sleep. So I think there's a lot of potential in using this sleep wearables to measure not only sleep, but here we're even measuring aging speed from just 1 night or even multiple nights of sleep data. So some clinical take-home message, I've shown that sleep is really a window into brain health, but not only brain, it actually is a window into organs beyond the brain. And there is really a great opportunity to develop complementary digital sleep biomarkers. I've shown these 3 modalities of sleep markers, and then can be used for different devices. And then finally, we can really translate this clinical big data to precision brain health at home. This is what it looks like right now with the polysomnography measure. It's not very comfortable. And then in the future, you can see we can really make home the new clinic by this miniaturization, wireless transmission, and also autonomic analysis, machine learning. And even with the closed-loop feedback, we can really get intervene on sleep by measuring it. And with that, I want to conclude. We just came back from the sleep meeting, so you're the first one to see this photo. And then there is a sunny and foggy Golden Gate Bridge that welcome you all to San Francisco. Thank you.
Thank you very much. Very important. So we'll keep the discussion after the different talks. So the next speaker will be Fanny Elahi. She is from the Icahn School of Medicine at Mount Sinai, and she will speak about the plasma molecular signature of ADRD for early diagnosis. Fanny.
Thank you so much to the organizers for inviting me to speak. I have learned so much. This is one of my favorite conferences. I feel like I'm in elementary school when it comes to exposomics, and it's been sort of the elephant in the room that I've never measured. I'm a neurodegenerative disease specialist. The topic is ADRD, but out of spite, I have nothing on Alzheimer's, so you'll see how I think about dementia. Oh, this is funny. Okay. So
A very biased model of dementia in my head is that it actually doesn't start with the brain. Neurodegenerative diseases, now there's increasing evidence, actually may start in the periphery. There are biological changes in the systemic milieu that eventually affect the brain's barriers and lead to brain dysfunction and degeneration. And if you think about the markers of neurodegenerative diseases, whatever aggregated proteins they are, it's actually a loss of proteostasis. It's a cellular dysfunction in the brain. And ultimately, there can be a ton of pathology, but only some people develop dementia. And so there's also resilience and the biology of resilience that needs to be taken into account. So if you think about it, really exposures are probably through and through, but we can take each of these different components and look to see, for instance, at the end, when you have measures of pathology, who has dementia and who doesn't, and what are potential exposures that can actually moderate those associations. This is how we think about neurodegenerative diseases. And some of the data that I'm going to show you will hopefully convince you that we're not crazy. But I think other labs and other groups are also increasingly generating data to suggest that vascular pathologies and microvasculature, small vessel diseases being the most important kind of vascular pathology, are really important to all end organs, including the brain. So we think that blood vessels age. This is part of that age vulnerability. This loss of protective barrier and associated changes in literally the physics of the brain are also accompanied by miscommunication of cells. So a lot of our single cell, single nuke data and the ones that are out there, the atlases, show that the phenotype of cells are sort of in between. There's an increasing number of in-between phenotypes before cell death. Ultimately, I see this as a loss of end-differentiated identity. And this dysfunction propagates in ways that we have not understood biologically. If you look at autopsy series, so the numbers in each section are actually percentiles, going from normal-ish cognition, say that they don't have mild cognitive impairment or dementia at the time of death, to dementia, the hue outside of it shows all the different components that actually have a vascular component. So as you compare cognitively okay with and without pathology to cognitively no longer okay, really the predominant difference may be actually the vascular co-pathologies. This is what we haven't measured. We have incredible measuring tools for Alzheimer's disease, which really just mark the disease state. They actually don't really tell us how that brain got to the point of feed-forward neurodegenerative disease. And we know, we've heard earlier from many people, that the Alzheimer's neuropathology, which is amyloid and tau, is one of the many pathologies. And the pie chart that I showed you before really shows you that the predominant number of brains actually have mixed pathology. Yet, we don't actually have the tools for measuring the non-tau, non-amyloid co-pathologies. And so this is really at the heart of my lab and the emphasis, and which is why we should be collaborating, because the pathologies that we are measuring, I think, are even more prone to exposomics impact, namely the vasculature. So this is our approach. We begin in humans. We do a deep dive in the biospecimens. Proteomics is our main tool, but as other kinds of omics have become more and more reliable, we're expanding. But frankly, if you have a good tool and you can capture the molecular pathways, I'm not sure we need metabolomics outside of exposomics, for instance. So we've stuck with proteomics. We like quantitative phenotypes. So the presentation that we just heard is sleep phenotyping. We use wearables for that because we want to model pathology before someone actually develops dementia. And all the abnormalities and dysregulations are going to be way better measures of problems than cognition. We are really focused on monogenic forms of disease because we want to then take it into model systems. Stem cells being our main model system, but they're also decent animal models for some of these pathologies. And so the only way to really do that is to actually have a genetic link, which is why we've chosen monogenic forms of disease. ApoE4 homozygote carriers in my book are acting like monogenic, so there are also sporadic genetic risk factors that have very high penetrance. And ultimately, all of this, and I'll show you a few data points down the line,
are building towards better, more precise clinical trials. The clinical trials need to be combination therapeutics if we want to slow down progression of disease and prevent dementia. There's no way one drug is going to do it. And so we really need to have precise measurements and biomarkers to have go, no go for our interventions, or we stand no chance of actually having very efficacious therapeutics. This is my only slide on Alzheimer's disease. This study will eventually come out, but we're hoping to actually add exposomics to it. So the figures are very tiny, but I'll show you what we looked at. Mount Sinai BioMe cohort is a really unique resource of 60,000 plasma samples and whole genome SNP arrays and whole exome sequencing that was created. So what we did is we pulled all homozygous carriers of ApoE4, and we had genetically determined ancestry, African ancestry, Hispanics, and Northern European ancestry. And obviously these are percentiles, but if you bin them, what we wanted to ask first and foremost is there's a lot of question about Alzheimer's neuropathology and the effect of E4. And we wanted to know whether that's actually true if you look at early stages and if you look at the molecular markers. And what we wanted to do, and there's a lot more in this paper, is to look at specifically the ApoE4 effect and across the lifespan. And so the first figure here is basically showing you brain-derived p-tau217 and the total p-tau217. And you can see, I don't know if you can actually see, but ApoE4 homozygous carriers start increasing, separating from ApoE33 homozygous carriers in early 40s. This was very eye-opening. So way before there is actually any symptoms. That was the first thing. And then this is actually an ELISA panel, and we also have some other proteomics in there. And so if you look at the cardinal biomarkers of neurodegenerative disease, ApoE4, A-beta 42/40, the other p-taus, you can basically see that the markers of Alzheimer's disease increase across ancestries. So, this idea that there must be different thresholds depending on genetic ancestry may not have legs. However, if you actually look at the genotype risk factors across the ancestries, you can see that ApoE3 is maybe a bigger risk factor actually in African ancestry than ApoE4 homozygous carriers. So the genotype, phenotype, and molecular phenotype is important, but whether the markers for Alzheimer's disease are capturing disease state, I think is pretty safe to say they are. So then, in order to discover the biosignatures of small vessel disease, we focused on Notch3 mutations that cause an autosomal dominant form of small vessel disease. And in this study, what we did is we did our discovery in genetic carriers, and then we looked at large biobanks to see whether the proteomic signature that we discover in this monogenic form of disease actually captures anything relevant to aging and sporadic disease. So these are the signatures. We had early disease and late disease, and by applying machine learning algorithms across 3 different cohorts, we uncovered 2 signatures with some overlap. This is the principal component analysis. You can see that the signature, anywhere between 16 to 24 proteins, can separate these groups really nicely, but there's a shift in which proteins are most predictive in early disease versus later disease. Using the UK Biobank, and now we have other cohorts as well in this paper. There's an earlier version on bioRxiv. The revision looks very different, though. This proteomic signature is really not specific to the brain. It's actually predicting all kinds of end organs, including myocardial infarction. And I think this is really the power of small vessel disease. It's not just important to the brain. So if we have good measurements, it may be an important part of systemic aging. And you can imagine if your other organs are also not functioning super well, then there's a sort of exponential risk of developing neurodegenerative disease. And so we had negative controls. This is all human data, and I'm always bothered by the fact that it's sort of biased. So we created these negative groups such as cancer or non-vascular outcomes, and you can see that this red line, which is all vascular outcomes,
is just cumulative increased incidence, and the others are remaining flat according to the risk score. In interest of time, I'm going to skip this, but we always look at brain. So all our discoveries are in biospecimens because we're interested in aging and the early stages of neurodegenerative disease, but we want to know how the molecular signatures actually behave in brain. So looking at brain proteomics and transcriptomics, we see that our signature actually separates disease from controls. Again, a benefit of actually doing genetic stratification, because you can imagine that if we didn't have genetics, we wouldn't know what brains to actually look at. So this slide is just one of the proteins in this risk score, and it's just to illustrate the approach to taking human biosignatures all the way to validating a model that you will then use for drug screening or testing of the effect of exposomics. So we took fibronectin, which is really involved in changes to the extracellular matrix and stiffening of blood vessels. And you can see that in our genetic small vessel disease score, the levels were elevated. On brain tissue, the levels of fibronectin were also elevated. And by staining the vasculature, we see that fibronectin is actually deposited around blood vessels of individuals with disease versus the controls. It's really tricky to have controls for brain tissue because everyone's dead, and there was a reason for that, but there's an increased enrichment. And then by using single cell or a single nucleus RNA-seq, we actually demonstrate that the cells highly expressing these are the smooth muscle cells and the mural cells. And that's important because depending on what kind of therapeutic, you want to make sure that you're delivering your therapeutics to it. And finally, what was really exciting is that by differentiating stem cell into these primary cell types from the genetic carriers and the isogenic controls, we demonstrate that indeed the smooth muscle cells and the endothelial cells are expressing more fibronectin. So it's the full arc of the toolkit that we actually need. What was really interesting is that this risk score behaved exactly the same in controls and amyloid positive individuals. And I think there may be a lot of explanations to this, but amyloid in some ways has a cerebral amyloid angiopathy. It has the vascular component. So it may be that the small vessel risk score is just capturing the aging component, and that there may not be a difference in various states of proteinopathy. This is showing you the same figure that I showed earlier, but on the right, we looked at various kinds of end organs, and one of the most important outcomes that had an increased hazard ratio was actually kidney function. And then you can see as you come towards the right with lower predictive ability that there's vascular dementia just a little bit above the line. And I think there are real issues with capturing dementias and neurodegenerative diseases, whereas these other end organs are actually way better diagnosed and quantified. So there's a little bit of bias there. What was really interesting is that the risk score was much more predictive of bad outcomes in women than in men. And the time point in life that it was most predictive in was earlier in life, midlife, which is when we think that the vascular risk factors are really having their deleterious effect. And so here I'm showing you hazard ratios across the lifespan of women with just increasing. So if you're in your 70s and 80s and you have a high risk score, it's not that predictive anymore. And there may be many, many different reasons for that. And on the right side, it's men. What was also very interesting is that the higher risk score in women was associated with poorer cognition, but it was a flat line for men. If you take, again, fibronectin, which is what I showed you, and map the lifespan trajectory, you can see that there's a huge increase for women throughout the lifespan. We are still trying to assess whether menopause and hormones have an effect on this. I don't think we have the right data sets. It's a very hard question to ask. And this is in two completely different data sets. The next slide is showing you exactly the figures that you just saw, but then we also looked at CSF, and the levels of fibronectin are actually not different in CSF across the sexes. So I think the brain has a lot of specific things that we need to look at. Plasma is predicting brain in all sorts of ways that may not be direct. By the way,
fibronectin, circulating levels of fibronectin are not the ones that are actually deposited in the brain. So the source of fibronectin deposited in the brain vessels is actually different than the circulating levels. I think I'm out of time. So this was a modular talk. I'm going to skip the last module. This paper is going to come out soon. And I'm going to come back to here and say that it's criminal to continue studying neurodegenerative diseases without measuring exposomics. I think there's maybe potentially a bigger component that will be predicted by exposomics than genetics, but it really truly is an interaction. So I think looking at the vulnerable genetics for neurodegenerative diseases may give us not the 1 million cohort that we need or even 10,000, but smaller groups that we can actually study. And I think we need to really study it at every measure, at every segment, and the success of that really depends on our measurement tools and how accurate they are for these various components. This is the amazing group that I have the privilege of working with, and these are my sponsors. Thank you for your attention.
Thank you, Fanny. And the last talk of this session, before the discussion, is by Carole Dufouille from Bordeaux Public Health and INSERM, and she will speak about the interplay between exposomics and the ADRD phenotype. 15 minutes.
Good afternoon. Thank you to the organizers for inviting me. I wanted to criticize Exposomics, but I've just heard it's criminal, so I might avoid that. In fact, I agree with what was said before, and I'm going to use a more public health perspective on all that. Okay, so I have to show all your slides before mine. I have no disclosure, except I'm French, grumpy, and it's a bit warm outside. Before going to associations and exposomics, I just want to remind you the big picture of dementia, and just to update on the last paper that was published last year based on the ARIC study, that is a cohort that started in the 80s with 15,000 people aged 45 years and 64, and between 45 and 64, and 3 that have been followed up since then. And the ARIC study has provided very interesting and quite scary result, because we had in mind that about 1/3 of people aged 55 and above would get dementia, and with the ARIC study, the forecast is even worse. So based on their result, that are really updated, they said that 42% of people aged 55 and above will get dementia, and you see in the graph on the right that the scenario is even worse for women, and this is after taking into account modality. So just for the US, what does that tell us in terms of burden of dementia? So in the years 2020, there were about 730,000 cases per year, and it's expected that it's going to be more than 1 million in 2060, and even worse for women as usual. But we need to go back. What does it mean to have dementia? And before being to very sophisticated biomarkers, we need to go back to the basic, I think. And it was mentioned before, but I wanted to mention the result from the CFAS study. So it's a population-based cohort in England that collected the brain of people who agreed and when they were dead. And it's a very important study because it gives a very interesting view on what is seen in the brain of demented and not demented participants. So these graphs shows so they have the latest number of brain they have in their brain bank is 456. And what they look at is the difference in distribution of the brain lesion at autopsy according to dementia status. And you see that for both changes that are more related to Alzheimer's disease and changes that are more vascular, the burden of neuropathology is higher in demented participants. And this shows that dementia is a functional outcome caused by many diseases. When they try to, based on this neuropathological data, to calculate the attributable risk of the different pathology, they found that age was a big driver. 18% of cases were attributable to age. But you see that the small vessel disease, the vascular pathology, the cerebral angiopathy that are likely to be more vascular, the risk attributable to this lesion is more than 33%. So the picture is not as Alzheimer's. When we look at real data, the Alzheimer is not, and it was said in the previous talk, but the Alzheimer is not necessarily the main driver in dementia epidemiology, but it's rather a mixture of many pathology that we need to take into account better rather than adopting some, that's the grumpy part of the French person I am, but rather than adopting a very simplistic definition of Alzheimer's based on blood biomarkers. So what the study showed is that the Alzheimer's disease neuropathological changes and vascular pathology were highly prevalent in older population and commonly coexist, and that we need to take into account the multiple pathology to understand better the underlying causes of dementia. And this also has implication on the way we think about risk stratification and therapy. So once we have that, so dementia is a mixture of different pathologies. What about internal and external exposome? In fact, what is really important is that if we want to look at exposome, we need to work on a really long follow-up. In that study of the Whitehall, it's a study of the Whitehall sample. It's a sample of civil servants in UK, and they did a case control study out of the initial cohort, and they found that in people that, so it's a case control study of dementia cases and not dementia cases, and they found that there was a change in BMI more than 10 years before diagnosis between demented and non-demented participants. So if we want to study the impact of exposome on dementia, we need to follow up people during very long. And it's even worse because there's a bit, it's a bit provoking a paper. So it's a Newsweek paper that stated that Alzheimer's starts in childhood, and I don't know if you're familiar with that. It's probably not the best study methodologically, but it's quite interesting. So it's a study that took place in Mexico City, where they had the brain autopsy of 134 person age on average 20 years old, and it's people who died from non-natural causes. And they measured so they studied the brain, and they looked also at the PM2.5 because Mexico City is a highly polluted city. And what they found is that so these are the causes of death: accident, homicide, suicide. And what they found is that even in this sample of very young people, you can find some markers of Alzheimer's disease, and even for a very small proportion of participants, but 5% is the highest stage of neurofibrillary tangles. And it's also the same, so the brains of these young people, very selected, so there's a lot to say about the methodology, but still, it seems that this biomarker, this change in brain can be measured very early in life, so this has some implication on how we study brain over time. And just to show that they stratified by age the different pathologies, so that's neurofibrillary tangles, and that's A-beta lesions. And again, they show that there's a trend with age, so the severity of pathology is more frequent in the age group that is more age. So this is very, it's a small sample, but on the other hand, we don't have such data in that young age. But if we study exposome, we need to work on a very long follow-up. It's also required that we have some precise phenotype, and this paper is from the Diane study. The Diane study is a sample of people with genetic mutation or with family history, of people with Alzheimer. And they included 230 participants that were asymptomatic at the time of inclusion, but who had a family with either mutation, so the family history, and among those, 120 had the mutation of Alzheimer, and 110 were asymptomatic non-carriers. And what they did in that study is they calculated the estimated year of onset based on age at study and age at parents' first symptoms. And they found that something that is not very specific of dementia or of dementia onset changed more than 17 years. So there's a change between non-carriers and carriers more than 17 years before the symptom onset. So again, this goes with the same idea that we need to measure things very early before the first symptoms if we want to show association, but also we need to have a very good phenotyping of cases. What is interesting, so Diane is very specific because it's people that we are sure will get Alzheimer at some point. But what they found in that study is that, in fact, the change in between carriers and non-carriers was not specific to BMI, but was also found for a test or for something more specific of Alzheimer, which is CSF habitat. But those results show that we need to find very, very good phenotypes, and I'm not sure that CSF is a good one. I'm not sure that logical memory is a good one, but we need to do better if we want to take into account the complexity of dementia that we see from neuropathological studies. Similarly, what is very interesting for small vessel disease is also that we can find some early life predictors. And so this paper was published in Brain 2 years ago. And they looked at different studies, did the meta-analysis looking at early life risk factor in relation to small vessel disease. And they found quite consistently that low birth weight was associated with more than 60 years later with more white matter lesion volumes, more lacunes, and more severe small vessel disease. They also found the same with the childhood IQ. So it's a meta-analysis of 4 or 5 studies, depending on the outcome. But they also found consistently that childhood IQ is predictive of the vascular brain health many, many years later. So, as I've said before, we need to take that into account to, if we think about public health dementia prevention, because dementia is a functional consequence caused by many diseases, I've said that. It's long and insidious development because for many years there is no precise moment of onset. We diagnose usually very late dementia. And it's very likely the changes that are either physiological or cognitive are detectable more than 30 years before dementia diagnosis. So it's also very likely that people with Alzheimer's disease and related dementia have subclinical abnormalities years before the diagnosis of dementia. But what we have to keep in mind is that all the risk factors that are, and all the exposomic probably is very associated with socioeconomic status during childhood. So when we look at exposome, we need to have that in mind and take into account socioeconomic status. So based on all that, it's very likely that the prevention must begin decades before diagnosis. So I know we discussed differently before, but I don't think that randomized control trial can inform us about primary prevention. And secondary prevention is likely to be possible, but it means that we need to prevent the clinical impact of the disease, and that's really in favor of working not on dementia prevention as primary, but on dementia prevention based on brain resilience. And for that, we need to have a population approach and not high-risk approach, because that's famous in public health, and that's the work from Jeffrey Rose. But if we focus on, and that's something we tend to do in Alzheimer's dementia field, if we focus on people at high risk, it's going to be a small number of people that are going to be dealt with, whereas if we do population study, we are going to shift the distribution of risk factors towards less negative distribution, and this will have more impact on the population distribution and the dementia prevention. Also, given, well, this graph, you've seen it 100 of times now, I guess, but we need to think about the causes of causes, and I think exposomic research is really the room for that, because when we, in that graph, when the focus is made on midlife risk factors, they are not assigned randomly, and we also need to take into account the different factors that promote unhealthy behaviors that lead to these risk factors. So that's true especially for diabetes, smoking, overweight, and others. So it's very, I think exposomic research in Alzheimer's disease is very appealing. We bring very complex exposure that are going to bring very interesting results, but on the other hand, we need to make sure that we do not oversimplify the outcomes, and we really need to keep in mind that dementia is a combination of neurodegenerative, vascular, and other components, but it's not just amyloid, just tau. And I think even in exposomic research, if we want to improve the quality of the research, we need to bring more causal inference and replication in order to make sure that what is brought is evidence-based. Thank you.
Thank you, Carol. And I think, the speakers should come to the floor, and we can start the discussion. Yeah. Okay, so...
You take the bottle.
Okay, it's working.
It's okay, I've been drinking.
Yes, have a drink, you'll need it. So
Here, do you want to take this?
we can have, maybe a half an hour discussion, and Carla will monitor that. Before that, the audience will prepare questions, but before that, maybe let me try to start the discussion. And I would like to raise the issue of specificity, because it was present in almost all your talks, and I think the specificity of the marker towards the endpoint, and maybe sometimes the specificity of the marker towards the trigger, eventually in exposomics. So you would like to start commenting on the specificity, what you see in sleep patterns, for example, towards, for example, dementia or AD or aging. Could you comment on that, please?
Yes, very good question. And I think that's exactly what we struggle most, especially if we're just using sort of summary sleep measures. It's very unspecific. For example, if you think about, short, long sleep duration, or even just fragmentation, it's not a very specific measure for any of the disease. It can be for even cardiovascular disease, mortality, everything. And I would say if you go deeper into the more granular measures of sleep, for example, with the new AI foundation model that we built, then the specificity gets much higher.
Okay.
So I think it really depends on how much information you are incorporating from that measure.
And do you think that it's so important to be specific? I mean, could you use still the data even if it's not that specific?
I mean, I think it depends on, again, what you want to do with that, those findings, right? So if you say, I was calling this predict dementia risk, but that's also a very controversial term, especially for epidemiologists. We shouldn't be using that term. And when you talk about predicting, it's really, you have to be both sensitive and specific. So I think it's important in that sense. Yeah,
but also it's also about maybe starting secondary prevention, and maybe this could, also be non-specific to this. So I mean, it's not an easy issue to deal with, but I think it's really important.
Yeah, I agree. I think with secondary prevention, or even just, clinicians do pay attention to these findings. And I remember I was working with Epic Norfolk for my PhD, and I remember very clearly we had a participant meeting at the time. And at the time, I was really interested in daytime napping. So I had some findings on daytime napping with increased risk of basically everything, mortality, cardiovascular diseases, etc. And then I had a participant's spouse come up to me and said, I love what you did, because my husband, before he died of stroke, like several months before that, he just suddenly became really sleepy, and he never had the habit of napping, and then he suddenly developed this habit. It's not specific, but I feel it's still useful as a sign.
So Fanny, what about the markers you mentioned about proteomic marker? I mean, you mentioned fibronectin, for example, at one point, which may be related to many diseases. What's your opinion about that?
I think as we're building models to debunk what is actually driving dementia, as Carol and we have sort of emphasized that, amyloid and tau is sort of a good outcome, but it's not the process or the mechanism. I think we do need them to be accurate. So if we're entering different measures into a model that are capturing various pathways and biologies, they need to be accurate. But if we have outcomes for clinical trials, I tend to agree with you. So if a combination therapeutics is going to work to prevent dementia, it needs to be really robust. And there's nothing super specific that I, in my head, think is robust enough to actually prevent cognitive impairment and decline. So in some ways, if you look at psychiatric diseases, the drugs are pretty dirty. So I don't think that our therapeutics need to be that clean, or the readouts. In fact, we want functional readout, right? There's a health span movement to functional fitness, which is not that specific. It's multiple different kinds of perturbations that can cause a decline and multiple things that need to be in homeostasis in order for you to be okay. And so sleep is a good measure. We're phenotyping it because we think that for the vascular therapeutics, it'll be an excellent readout. And we already see that there's sleep fragmentation. They don't have Alzheimer's disease. Neurofilament light is actually another example. It's being used as a vascular biomarker for clinical trials. It's the least specific biomarker that we have.
Yeah. Carol, what do you think?
Same.
That's easy.
No, I don't have much to add. I think the specificity we need more specific measure for the outcome, and even dementia is not a very good one because there are too many. Age at onset, for example, is not precise enough. But I don't think the specificity is a problem really for the exposure.
So let's open, any question from the audience. Wow.
Everyone's in stage 2 sleep right now.
Stage 1 maybe.
Sleep.
Okay.
Yes, Bob. Yeah, make my life easier. Yeah.
So for anyone on the panel, it seems like I was struck by a couple of times in different talks that there were multiple diseases that seemed to be predictive of dementia. Obesity, obviously, would be one, but cardiovascular disease would be another. And is there anyone, those are sort of intermediates, I would possibly even mediators between an environmental exposure and the outcome. And is anyone looking at that the way we're also, as a biomarker, the way we're also looking at sleep, which I guess could also fall in that category, or molecular biomarkers, that the pathway by which you get to dementia may be specific. Maybe there's some information there that might be useful.
Sure, I can start. I think with sleep especially, we do see a lot of differences. As I mentioned, for example, you would imagine with EEG brain markers, it can be very different mechanisms than cardiorespiratory markers. An example I could give is, for example, sleep apnea, so obstructive sleep apnea, which is a sleep disordered breathing problems, and common mechanisms associated with it is hypoxia that builds up all these vascular burdens in the brain. So I think that's well known, and we have seen when we look at Alzheimer's or like neurodegeneration, it's not really in those patients, but it's like very specific to vascular. And then if you look at sort of 24-hour rhythms, then it's more systemic, and then you get more, inflammation and neurodegeneration can be there. So I can only speak for sleep, but within sleep, I would say different modalities you are looking at, different sleep metrics, and also depending on the different organs, it does operate through different mechanisms. And I think it's very important to also study those mediators. I think they're still pretty not well established. And part of the challenge is because we don't have good measures many studies don't have good measures of sleep yet. So I think we have done a better job in the biomarker side in some way. And maybe I'm biased, but yeah.
Thank you. Anybody else would like to address this?
Just for the results on weight, for example, is quite consistent. It's quite interesting that in both the Diane study with cases of dementia with mutation and in sporadic Alzheimer, we see dementia, we see the same thing. So a change in BMI of more than 10 years before the diagnosis. But it's very hard to see whether it's in the pathway or that's the results of a change in... so the result is that people who get dementia have lower weight, and it could also be that they are... it's a marker of change in dietary habits that leads to... But I'm not sure we are still not able to say whether it's really a causal pathway.
Okay. I have a question to Fanny. I mean, you mentioned brain rigidity at one point, and so I was wondering if this could be measured non-invasively. I mean, because this would be relatively specific. I mean, could you comment on that?
Yeah, so we worked with engineers, again, going back to the stem cell lines, because there are imaging measures, I think, that people are trying to develop for that. Pulse wave velocity is almost a reflection of that. But we want to make it like really, really specific. We want to know the cellular, the molecular drivers. So driving the stem cell models from genetic carriers versus the isogenic controls, we actually have a pressure index where we see the stiffness of the tissue days after we've actually differentiated and formed these vascular organoids. So I think these are the aspects of neurodegenerative diseases that remain a dark frontier, but so critical to the phenomenology of what it is. If you think about it, I really think we've actually shooed in the syndromes into separate syndromes, and then told when I was training, amyloid and tau is Alzheimer's, synuclein is synucleinopathy, then you have TDP-43. And the reality is that when people die, there are multiple different kinds of proteinopathies. And even in their life, their symptomatology is not as clean. Patients with FTD have memory impairment, and patients with Alzheimer's disease have neuropsychiatric and executive dysfunction before maybe they have. So I think we need to really move from how we used to categorize when we didn't have these tools, these sort of endophenotypes and the molecular tools, to having a biologically defined clusters within neurodegenerative disease space.
Yeah. Yes.
There we go. Ashley Taberge, University of Washington. Thank you all for very interesting talks. I have a question that sort of synthesizes some of what I was hearing in these talks with Bob Wright's talk earlier this morning about health span and helping people to be more participatory in their own health and prevention. So some of you have shown, blood-based biomarkers. Others have shown kind of wearable sleep-based biomarkers that might be quite predictive, if not fully specific. And I'm curious what your thoughts are about the ethics, or I'm not sure if that's the right word, but yeah, of reporting those data back to participants, or even having direct-to-consumer products like the one that you mentioned, people wanting to be able to measure their own sleep biomarkers and starting to take action.
Yeah, I would say, I think on the sleep side, as you alluded to, it's a sort of an easy one that is, people would never say no if you want to give them their sleep reports. And even if you give them your age in, how old are you, like how old is your brain, I think people are still, they really want to know this. So I think with sleep, people just are interested in this broadly, so I don't see any ethical issues, unless you are claiming actual medical, if you are like giving this see it as a medical value, then that's a different thing. So maybe that's more as a biomarker.
I have a problem with aging clocks at N of 1 or even at the group level. So I don't think they're at the level of accuracy that allows us to actually return the results. These longevity or concierge services are doing it, and I end up seeing those patients who come in and they're like, I'm running my hedge fund and my brain age was like 60 and I'm like 45. And so I don't know the accuracy. That's the major problem. However, I have a pretty controversial stance with regards to p-tau, for instance, or neurofilament light. I think we do know the accuracy of those. What we don't know is how predictive are they if you're higher than the general average for your age and demographics at 40 or 45. And that data really needs to come out. But I think if we destigmatize what they mean and think of them as sort of readouts of brain health, no one says that higher neurofilament light is great. I think we know the directionality of that. And we say, we're not telling you you're gonna get dementia. We're saying it's a little bit higher than what it should be. It actually provides incredible tools to intervene at N of 1. And so we're starting to do pilot studies to see how much they can move with various kinds of interventions. But I think there's a future in which these are going to be done at primary care on a yearly basis. But again, it's not telling someone you're going to develop dementia. It's just saying that you should maybe live differently.
I would not. I quite. I mean, I would. I think it's a very complicated. For PITO, for example, it would be already. I'm not sure it's told in clinic to people. So you'd say that you would do that in routine and give people results and what. So what?
Without saying that you're bound to get Alzheimer's disease. I think it allows, because when you look at the data, it's not just the data that we generated. It starts ticking up well before you're probably in an irreversible stage of disease. And so I think if we want to give really accurate prediction of dementia, yes, you wouldn't tell it until you're sort of in risk zone. But they're just so much more useful as tools for early intervention. And at that point, maybe that person would have never developed dementia because they have a lot of resilience. But should they sleep better? Should they eat better? Should they, do different things? Yeah, that's the perspective.
That's where the ethical point comes, I think, because in a way you tell people you should change your personal life. It's going to change your risk, and I don't think we have nothing like that we can tell. Even if they have PITO that is elevated or whatever. So you can't tell people eat better or sleep better because it's not right. You can't. So that's why I see
So we're getting a little debate finally at the end. Finally, we stopped agreeing on something. I think if you piece the different pieces of evidence, we don't have people that we've followed and we've intervened on and showed that, we don't have that level of evidence, but we know that these increase sort of almost in a linear fashion. At some point it's nonlinear, and that they're really strongly associated with bad outcomes. So that's the kind of evidence that we have.
But it's at the population level, not individual. So I would be really reluctant. When you go at the individual level, you need to have more evidence that we have. What we have is, for me, population.
I would agree with that, but it's a starting point.
You would not agree?
I would agree.
Ah, okay.
Yeah, with that.
Okay.
So I'll make a comment and then I'll ask a question. The comment is on the prior conversation, which is the challenge always is handing a result to a patient or even just providing it commercially, and then we're not sure how the patient's going to use it or how the individual is going to use it or how they interpret it and how that influences their decision-making process. We also don't know how to have the necessary support systems in place to deal with that. I had the pleasure of talking with a lady who was diagnosed with Alzheimer's disease at 52 and was forced to retire, and she lost everything because she had to withdraw a lot of her money to support her health, and she couldn't get health insurance and all of that going down the road. However, she was still able to work. But her bosses said, you have Alzheimer's disease, so you should retire. And so I think there's a lot of, she was able to work, she can still talk. She actually gave a talk at the conference I was. So you have to really, so that's where the challenges are with what these results can mean. It's easier for sleep because we all sleep anyway. So that's where I don't know that there's a clean answer to the question, and the debate on stage is an indication of that, and I think it becomes a case-by-case basis. Now I'll stop talking at that point. My question actually has to do with the ApoE results that you presented. And one of the things you mentioned was that the E3 seemed to have higher risk or sort of higher burden of disease in certain respect based on the forest plot that you showed. And my thought was, to what extent was that result able to be genotyped for instance, especially among the Africans, which was your result, to what extent was it genotyped for other variants that are on the E3? Because among Africans, there's the E3 R145C which in combination with E4 has the same risk as having a homozygosity for E4, and I don't know to what extent that was ferreted out in that study.
Yeah. So I would have failed my EPI test if I misformulated it. I'm going to say what those forest plots actually show. They're looking at the standardized beta between your markers of tauopathy, all the p-taus, the brain-derived and the non-brain-derived p-taus, neurofilament light, and GFAP. And basically, in E3 carriers, we looked at the risk genes, by the way, for African ancestry. It didn't explain, but in E3, the association between the p-taus and these measures of axonal degeneration and neuroinflammation were stronger than in E4 homozygous carriers. So it's about the association of the markers of Alzheimer's disease with degenerative biomarkers. So it was misspeaking like what it actually represents.
Please.
Okay, good. So I'm just coming back to the previous discussion. I don't want to go into whether we can give advice on an individual level because of lack of, convincing interventional studies. But even before that, I mean, there's a major issue. How do we communicate to people, the information about amyloid positivity using the blood tests? So so there's a big difference whether we communicate a relative risk versus an absolute risk. So there's a great study by the Mayo Clinic group, by Cliff Jack, where they were able to, it's I think 2025 in Lancet Neurology, where they were able to estimate absolute risk of MCI and dementia based on brain amyloid and ApoE status and age, starting from the age of 50. And it's great because they were able to deal with attrition using the Minnesota system and so forth. Of course, it's very first step because there's no exposomics information there and there are not many other factors, but it's great. So for example, just to give an example, and it's a surprise to everybody in the field. So if somebody is 50 and they're cognitively normal, and they have positive amyloid, then you do a PET scan and they're positive in amyloid, let's assume that it's a blood test. So the possibility of getting dementia at the age of 75, 25 years later, is 2%. I couldn't believe it when I was seeing it, and it's coming from proponents of the amyloid hypothesis, right? And it's 2%. So if you don't have amyloid at the age of 50, it's 1%. Yeah. So having amyloid doubles your risk. But the absolute risk at the 25 years down the road is 2%. So, and there are other examples I could give. Even if you're 75 and you're amyloid positive and you're normal and you're cognitively normal, because we're talking about going early, the possibility of having dementia 5 years down the road at the age of 80, from 75 to 80, goes to around 12%. But still, it's like 88% of not getting dementia, right? So there's a big issue there. How do we communicate? Because if we talk about relative risk, we can tell people, oh, it doubles, and then you should focus on lifestyle and all the other elements of exposomic. But in terms of absolute risk, it's really low. So I think we have to be very careful there, even before we go to what can we do to change this. And there's a lot of discussion about that.
Yeah, I agree with that. I just want to add that dementia shouldn't be the only outcome that we're targeting. I think we lack tools that are measuring quality of life and cognitive fitness later in life. And if you look at our older population, they retire, they sort of step aside. What are we shooting for as a society? And I think that really drives what do we want to measure and what do we want to intervene on. If we just want to prevent dementia, yes, maybe the absolute risk is not that much. But if we are measuring abnormalities that are actionable in some way. So for me, frankly, Alzheimer's is a clearance abnormality, to really boil it down and simplify. It's a lot more than that. But in midlife, if your levels are elevated, maybe someone should look into the sleep that you have. Or maybe we do that anyway. So do we want to sort of risk stratify individuals and dive deeper into the state of brain health? Or do we just implement sort of brain health measure screening tools in midlife for absolutely everyone?
Yeah, up here, Eric Timmy from Swiss Public Health Institute. Thank you very much to each of the panelists for the insights. I would like to briefly draw the discussion back to the ethical components that has sparked most controversy amongst the panelists. We talked briefly about the question whether information of a personalized specific exposomics done with a patient should be shared with the patient or not, either between the physician or some kind of provider. But I think the ethics becomes increasingly difficult at a stage where we include third parties like medical insurances. And to draw the comparison to what has happened 20 years ago with the genome, we are about to enter to a similar dilemma when in a couple of years we will be increasingly able to provide these very specific personalized exposome profiles of people. And then the question is, are we able, should we or should we not share these with medical insurers so that they will then in turn penalize or reward or incentivize certain kind of lifestyle and changes? Because this could undermine principles of solidarity in the medical insurance. And a couple of countries have introduced gene diagnostic regulations that prevents medical insurers to access these data, because otherwise this could happen. I would like to know if panelists have thought of this or know of other initiatives that try to tackle this ethical dilemma that is about to come in the next couple of years.
Anybody has an answer? Fanny, you.
I think we need to destigmatize neurodegenerative diseases. They're so incredibly common. So right now, many people are probably having preclinical disease that don't know. You know, it just speaks to the multi-stakeholder, and usually what we don't have at conferences are politicians. So ultimately, to really protect individuals at risk as we shift prediction to preclinical, you need policies in place. And that's not, I don't see that as my job. I think our job is to think about what do we need to measure, what do we need to intervene in order to prevent these awful outcomes. But I understand that you make individuals more vulnerable in a society where they're not actually protected. So one of the things that I do when I'm seeing N of 1 patient in clinic, I say, do you have everything in place? Because you're supposed to be protected, but I can't guarantee that you will be, because an insurance company is going to ask you whether you've been diagnosed with any pre-existing conditions, and you would be lying if you said no. And so just get all your ducks in a row, and then we can start the workup. So there are ways to do that at N of 1, but I do think at societal level we need better policies in place. And maybe like we should actually phenotype the politicians themselves. How many are going to test positive? That may debunk, destigmatize.
Okay, last question.
I'm not sure this is worthy of a last question, but just maybe a comment. You know, I think we're making this overly complicated. And as a physician, I don't really need p-tau217 or any of these other biomarkers to tell people to eat well, sleep well, exercise. I mean, you know, I don't think that shouldn't be the dilemma here. I mean, it's just generally what we tell people. And when I read a grant, when somebody's going to tell me, well, the results of this project are going to tell me whether we should take better care of ourselves, I'm like, well, of course we should. So like, I don't need to study for that. So I think fundamentally the question for me, Fanny, is you know, if the lab value is going to change your medical management, you're going to give a monoclonal antibody. Well, that's a decision, right? That's a medical decision you would make. If you're going to make that decision, you need to know that. But otherwise, if it's all about lifestyle, I just don't see why we need these tests are not going to tell us that.
Thank you. That's a nice conclusion, as a matter of fact. Thank you very much. So with this, I think I would like to thank the speakers for their talks and for a lively discussion. I think we can applaud. And the session is closed now, and see you tomorrow at 9. Well, at 8 if you want to have coffee, and at 9 for the speaker.